24th morning here. Welcome to all the participants and the faculty members and the resource persons. This is in fact the second day of the virtual international conference on stem cells. Title is Update on Stem Cells, Academic and Industrial Perspectives, Future Challenges. Before we start, a brief announcement to the participants. Please be reminded that you have to attend at least 5 sessions, including the inaugural, in order to be eligible for the e-certificate. Also, we will be circulating the link for the feedback forms sometime today. You need to fill that out to be eligible to receive the e-certificate. Please keep this in mind and please circulate this information among all the registrants. Okay. So now I would like to welcome the guest, Dr. Ashim Gupta, and the chairperson, Dr. Anil Kumar Gopinathan. I will be the moderator for this session. Specifically, my role would be to handle the Q&A. I will be assisting Dr. Anil Kumar Gopinathan in this process. And now I am going to project the slide which will have the profile of the speaker. Now over to Dr. Anil Kumar Gopinathan, who will be chairing this session. Dr. Anil Kumar.
Thank you, Dr. Suresh, for having introduced me to the audience and also for initiating the process. Good morning to everybody. And at the outset, I would like to welcome Dr. Ashim Gupta, the speaker of the session, to this August audience. And he is going to talk on orthobiologics, which is, I would say, it's a relatively new branch, wherein the cementing of the tissues and the synthetic tissue, synthetic in the sense it could be from the same body of the person, and for joining, cementing the bones and other parts of the body. I don't want to elaborate further because Dr. Ashim Gupta, who is an expert in this field, is here. And I welcome you once again, Dr. Ashim Gupta. And
thank you.
I would like to introduce you to the audience. Dr. Gupta has led both basic science and clinical research projects in the field of orthopedics, plastic surgery, pain management, and neuromodulation. He has published several research articles, book chapters, review articles, and abstract journals. Abstraction journals. He has been, there is problem with, yes, abstracts in peer-reviewed journals. He has been awarded several grants and has authored and co-authored over 60 abstracts accepted in regional, national, and international conferences for presentations, some of which have won awards. Dr. Gupta also won the 2018 Medical Device Innovator of the Year Award at Illinois Capital Innovation Awards for developing a syringe system for fluid separation with applications in the field of orthopedics and plastic surgery, and a United States patent has been issued for the same. Dr. Gupta is a member of the numerous societies, including American College of Sports Medicine, Orthopedic Research Society, North American Neuromodulation Society. He is a reviewer for several international peer-reviewed journals, including Journal of Orthopedic Surgery and Research, Journal of Orthopedic Research, then Arthroscopy, the Journal of Arthroscopic and Related Surgery, Bone and Joint Journal, Bone and Joint Research, Cytotechnology, Neuromodulation, and the like. Technology at Neural Interface, and an abstract reviewer for Orthopedic Research Society annual meetings. Can I have the next slide, please?
Okay. Oh, the second slide was first. So, okay. Yeah, fine.
Okay. He's a scientist, entrepreneur, founder and president of Future Biologics, chief scientific officer for South Texas Orthopedic Research Institute, then Chief Science Officer for Veterans in Pain, then Doctor of Research and Development for Biointegrate, then directly commissioned as Captain in the United States Army Reserves. And he has previously served as an Associate Director of Research at Millennium Pain Center, also worked as an adjunct researcher at Illinois Wesleyan University, and as the assistant professor, research and director of laboratory for regenerative medicine and applied sciences at Institute of Plastic Surgery, Southern Illinois University School of Medicine. Completed his Masters of Business Administration from School of Business, Southern Illinois University, Edwardsville. And Dr. Gupta has also completed his Doctor of Philosophy and Master of Science in Molecular Biology, Microbiology, and Biochemistry from Southern Illinois University, Carbondale. He obtained his Bachelor of Pharmacy from Delhi Institute of Pharmaceutical Sciences and Research, University of Delhi. So he has a wide-ranging understanding of the mechanisms, which is oriented towards clinical research, and also, of course, basic research. And we are very glad to have him amidst us today this morning for his talk, but maybe the evening where he is delivering the lecture from. And once again, welcome Dr. Ashim Gupta, and over to Dr. Ashim Gupta for his presentation. Thank you very much.
Thank you. I'll try to get my... Can you see my slides?
Yes.
Great.
Yeah.
Right. So yeah, thank you for the kind introduction. I really appreciate it, and also giving me the opportunity to be part of this international symposium. So today I'll talk briefly about orthobiologics and mostly focus on tissue engineering and regenerative medicine. So I'll start with a brief introduction on tissue engineering. So tissue engineering is defined as the application of biological, chemical, and engineering principles towards the repair, restoration, or regeneration of living tissues using biomaterials, cells, and other factors alone or in combination. So the figure on the right describes the basic principle behind tissue engineering, where we use biodegradable scaffolds in the form of electrospun nanofibers, or they could be sintered microspheres that I'll be touching on shortly. We can see different kinds of cells on them and culture them in vitro, and they can be implanted in the body to regenerate or repair different tissues such as bone, cartilage, or liver. The National Institute of Health defines regenerative medicine as a process of creating living functional tissues to repair or replace tissue or organ function lost due to age, disease, damage, or congenital defects. The figure on the right gives an overview that regenerative medicine is actually an overlap between three fields, namely tissue engineering, biomaterials, and stem cell therapy. Some examples of tissue engineered tissues or organs that you are familiar with is the intraocular lens, vascular grafts, heart wall replacements. Another example is of the world famous ear developed by Charles Vacanti at MIT, and I'm pretty sure most of you would have seen this image of a human ear growing on the back of the mouse. Another example is of a nose scaffold also developed at MIT, where you can see a scaffold before and after seeding chondrocytes on it. Another example is of this fingertip reconstruction of this lady who got her pinky fingers chopped after getting it slammed in a door. Two surgeons in California used extracellular matrix components and actually reconstructed her pinky, and this is the original one that got chopped off. Last example is of this nose reconstruction, which featured in 2010 on the Times magazine cover of this Afghan girl whose nose was cut off, and then she ended up getting a new nose. So I tried to divide my talk into two aspects. One, I'll talk mostly about the academic perspective, how we do research, and then I'll briefly touch on where things change when it comes to an industrial perspective. So in the first part, I'll be talking about evaluation of non-functionalized single-walled carbon nanotubes composites for bone tissue engineering. So the problem statement we looked at is that bone defects and non-unions caused by trauma, tumor resection, periprosthetic fractures, or pathological deformation pose a great challenge in the field of orthopedics. And in this study, we specifically focused on the non-union fractures. So what are non-union fractures? Non-union is a permanent failure of healing following a broken bone unless intervention such as surgery is performed. There are two kinds: hypertrophic non-union fractures, where there is a formation of the callus, but the bone fractures have not joined due to inadequate fracture fixation. Other kind is the atrophic non-unions, where there is no formation of the callus, which can happen due to impaired bone healing, and two major factors that contribute to it are impaired blood supply, or if people are diabetic or they smoke a lot. And this is what they can look like in an X-ray. So just to give you a better understanding, when there is a fracture, how a bone heals. So in normal instances, first there is formation of hematoma, followed by formation of a fibrocartilaginous callus, which then solidifies into a hard bony callus, which leads to remodeling of the bone, leading to the healing of the fracture. Why these non-union fractures are challenging? Because they require multiple surgeries utilizing plating, fusion, use of bone matrix systems, and bone grafting. These procedures are time intensive and they require really well-trained surgeons. For example, this was one case that I saw of a non-union fracture. By the time a surgeon is done, this is how the patient will look like. So the issues with these kind of techniques are this person is never going to be normal like any of us. So to overcome these, the current treatments involve use of autografts. Autografts are the tissues coming from the same person, and they are considered a gold standard for clinical bone repair because of their osteoconductive and osteoinductive nature. However, they pose a limitation of donor shortage and donor site morbidity. Other alternate is allografts, which come from a different human being. However, they pose the limitation of disease transfer and immune rejection. Thus, to overcome these limitations, tissue engineering has evolved as an alternative to develop ideal viable bone grafts. So an ideal bone graft should be both osteoinductive and osteoconductive, should be strong, minimally antigenic. It can be injected to conform to complex tissue shapes, and it can eliminate the donor site morbidity and quantity issues. So specifically for bone tissue engineering, it involves the combination of biodegradable composites with or without the use of cells and growth factors to regenerate the bone. And the success of this approach heavily relies on the effectiveness of the biodegradable composites we choose. To prepare those composites, biodegradable polymers are used because they offer certain advantages, such as they are commercially available. They can promote optimal growth conditions for tissue of interest. They are biocompatible. They are non-immunogenic. Their degradation rate can be controlled, and they can also be utilized for controlled delivery of hormones or drugs. In this study, we used polylactic co-glycolic acid, otherwise called PLAGA, and it's a widely used suture material approved by FDA. So one of the essential requirements of a composite material in bone tissue engineering is to have the desired mechanical properties, which can be increased by reinforcement with a second phase material. So while I was looking at it, I had the opportunity to talk to a mechanical engineer who actually builds pistons and brakes for Formula One cars and for Boeing aircrafts. And he introduced me to carbon nanotubes. And what I found very fascinating is carbon nanotubes are actually 300 stronger than the best quality steel. So after listening to that, I did some research, and what I found that actually carbon-based biomaterials, they have been used in the past as coatings and fillers in implants. Different types of carbon-based materials have also been used for biomedical applications and have been found to be biocompatible. They have been used for implants specifically because of being hard. have low coefficient of friction, they are chemically inert, and they have high wear and corrosion resistance. And they have been used in biomedical systems and devices. One example that I came across was back in 2013 when Nokia won $1.35 billion in grant to make strongest phones made up of graphene, and they also claimed that this graphene is 300 times stronger than steel. Interestingly, same time, National Geographic came up with a magazine citing 100 scientific discoveries that changed the world, and carbon nanotubes were listed number 2 on the list. For any of you who were curious what number 1 is, that was nanolithography. So what are carbon nanotubes? They are allotropes of carbon with a cylindrical nanostructure. What makes them so fascinating is their high length to diameter ratio. They are members of fullerene structure family, and their name is derived from a long hollow structure with the walls formed by 1 atom thick sheet of carbon called graphene. What I like most about carbon nanotubes is that these sheets can actually be rolled at specific angles, and how they are rolled and the amount of radius they have, you can actually make them either conducting, semiconducting, or insulating. In general, carbon nanotubes are of 2 types, single-walled carbon nanotubes or multi-walled. Multi-walled are 2 kinds. They could be Russian doll models. So think about a bigger pipe, then a smaller pipe inside it, another smaller pipe inside it, or they could be in the shape of a parchment model. That's like if you roll a newspaper. So in this study, we focused on single-walled carbon nanotubes, which are 1 atom thick layer of graphite called graphene rolled into a cylinder. So when I was looking at it, one question I specifically was asked, and I looked into literature and found 2 schools of thought. Some people said carbon nanotubes are good. Some said they are bad for the body. And what I found that these single-walled carbon nanotubes are solely made up of carbon with the same scale size as our DNA. And the fact that all living entities are carbon-based makes them an ideal candidate for introduction into our systems. And to address whether they can be secreted out of the body or not, I came across a study which said that by putting some functional groups, they can actually be made even more biocompatible and biodegradable, and functionalization, they can be degraded by use of oxidative enzymes. So based on this, we designed our study and we came up with 2 objectives. First is to determine the in vitro biocompatibility by examining the interaction of cells via focusing on extracellular matrix production and mineralization. And then for clinical translational perspective, we wanted to evaluate its toxicity and biocompatibility in vivo in a rat subcutaneous implant model. So the first step was to fabricate 2-dimensional carbon composites. So what we did is we used the simple solvent evaporation technique where the polymer was dissolved in the solvent, poured in Petri plates coated with the BITAC paper, and we found these nice 2D films which we cut into 12mm dia discs for future experiments. To incorporate carbon nanotubes, we just modified our technique a little bit, and before pouring it on the Petri plates, we actually suspended carbon nanotubes after dissolving polymer in the solvent. And using this methodology, we used just the plaga as the control, and we came up with 5 different concentrations of carbon nanotubes suspended in the polymer. Then we did some scanning electron microscopy, and at different magnifications, we found that there was a homogeneous distribution of carbon nanotubes in the composites. And more interestingly, the degradation profile of carbon nanotube composites was similar to the FDA-approved plaga polymer. Using scanning electron microscopy and by utilizing mouse pre-osteoblast MC3T3 cells and human bone marrow-derived stem cells, we found that these cells actually grew and adhered on the surface of the composites, and they maintained their morphology as if they were grown on controlled tissue culture polystyrene. For consilience, we also performed confocal microscopy where we stained the cells with beta-actin and nuclear Hooks dye. And we found that both the cell types actually grew, adhered, and retained morphology on the surface of these composites. Next, we wanted to see whether the cells we are seeing are actually alive or dead. So we did a live-dead assay where the green color represents the live cells and the red color represents the dead cells. And what we found that these cells actually grew and survived on the surface because we did not notice many red cells. We also performed a cell proliferation assay over a period of 7 days using different concentrations. And we found that the cell proliferation rate was highest on composites with 10 milligram carbon nanotubes. So this gave us the concentration which we want to use to translate into a 3-dimensional model. So to create 3-dimensional composites, we utilize the same solvent evaporation technique. And this time we actually suspended the polymer solvent combination in 1% PVA solution and came up with these microspheres. And after drying, we did electron microscopy and found the surface was smooth. We used similar technology and just suspended carbon nanotubes in the solution, and the light microscopy imaging also showed that the carbon was actually enclosed inside the polymer microspheres, and the surface of the microspheres were again smooth, which is very essential for sintering them. So next step was to sinter these microspheres to fabricate 3-dimensional composites. So we created some aluminum molds with a 10 mm diameter and 2 mm thickness. And the key is to heat the microspheres between their glass transition and the melting temperature to get the desired composites. If the microspheres are heated between their glass transition and melting temperature, we'll see nice fusion with a nice pore in between. However, if we fluctuate and go higher the melting temperature, the microspheres will melt and there will be fusion of pores. So we will lose the ideology behind creating porous 3-dimensional composites. So using this methodology, we created these two 3-dimensional disks, and we did electron microscopy, and you can see these microspheres are sintered together and the structure is porous. So when we looked into the literature, we found that most of the studies are actually using microspheres of the same size in hopes to get higher mechanical strength. And they beg to differ from us, but when we looked into the trabecular structure of the bone, we found that the random packing of microspheres is what actually resembles the trabecular bone and not the microspheres if they are of the same size. And interestingly, even with this random packing, addition of carbon increased both the compressive modulus as well as the ultimate compressive strength. Additionally, these cells also adhered and grew on the surface of these microspheres, and they formed these cytoplasmic extensions to bridge the gap between the microspheres. For consilience, we found that these cells, again stained with beta-actin and nuclear Hooks dye, were growing and adhering on the surface of these sintered composites. Next, we again wanted to check whether these cells are live or dead, and we saw only few cells which were dead, and majority of the cells actually grew and survived on the surface of the composites. Then we performed some cell proliferation assay, and we found that over a period of 21 days, the carbon addition of carbon nanotubes actually increased the rate of cell proliferation at all the 3 time points we assessed. More importantly, we also saw expression of collagen 1, osteogenic markers like alkaline phosphatase, late osteogenic markers osteopontin and osteocalcin, and bone sialoprotein. And we also saw significant increase in expression of osteoblast differentiation marker RUNX2 at all the 3 time points. Next, we wanted to see whether the composites we created are toxic or not, and whether are they biocompatible in vivo. So we used these Sprague Dawley rats, and we divided the rats into 3 groups: sham, where only an incision was made and the wound was closed, and the rats which were implanted with plaga only, and where they are implanted with the carbon-based composites. And we assessed the rats at 4 time points. and we used 5 animals per group per time point. So just to give you an overview of the subcutaneous implant model, we use these SD rats. The anesthesia was performed and we shaved and prepped their backs using ethanol and betadine. We created 2 1 centimeter long incisions, 1 inch apart from each other, and subcutaneous pockets were created. Then these composites were implanted in these pockets and they were clipped back. So our results showed that over a period of 84 days, there was a consistent weight gain for all the groups. And there was the pattern of rate gain was also similar between the sham, Plaga, and the carbon groups. We also found that there was the same pattern for food consumption with higher intake post-operatively. We also performed complete blood count as well as WBC differential count. At some places you'll see asterisks or like significant differences. However, all these differences observed, they were still within the normal range of values reported for the rats. Then we used these metabolic cages and collected also the urine samples of these rats. And we performed an 11-way UriSpec analysis. And what we found that actually there is no significant difference for any of the 11 parameters between the 3 groups. For representation only, I'm showing the image only for 8-week and 12-week. So we collected the subcutaneous tissue surrounding implants. And as you can see, grossly, the tissue surrounding the implants, both in case of Plaga as well as the carbon composites at 8 and 12 weeks, looks normal. We also collected different organs to see if something is going on in the body, and we collected adrenal glands, lungs, spleen, kidneys, liver, and heart, and we found the relative organ weights between the group. There is no significant difference. To further confirm that there is no toxicity, we performed histopathology, and what we found that the sham group healed like normal, and there is formation of, there's some fibrosis and fibroplasia in both the groups, which is actually there's a formation of capsule whenever any foreign body or any implant is introduced in the body. To quantify these results, we looked into 11 parameters like presence of polymorphonuclear cells, giant cells, macrophages, fibroplasia, fibrosis, and all those 11 factors were rated from a scale of 0 to 4. 0 means no findings and 4 means severe. And we converted that into a summary toxicity score ranging from 0 to 44. And what we found that only at the 2-week time point, there was a significant difference between the carbon and the PLAGA group. However, as the time subsided over a period of 12 weeks, there was no significant difference between the 2 composites, which shows that the toxicity profile of carbon composites is similar to FDA-approved PLAGA material. And all this work was published in a series of articles. So in future, what we would like to do is like to create a non-union ulnar defect model. So rats are small, so we decided to use rabbits. In a rabbit, a 15 millimeter defect is considered a non-union as it's not going to heal on its own. And we already created, using similar sintering methodology, 15 millimeter long composites, and we performed some electron microscopy and found that we were able to randomly pack these microspheres while maintaining the porosity. Ideology would be to implant these in those defects in the rat. And we propose to divide this into 5 groups where we'll have just like a sham surgery with the scaffolds alone. And we propose to do bone marrow aspirate. So this was planned considering the FDA regulatory environment. And due to time constraints, I won't dig deeper into the FDA requirements. But currently, these are the only procedures which are approved by FDA to be performed on humans. And that was one of the reasons we thought we would like to keep it as close to the clinical applications as we can. Now, switching gears, when we are involved in a industrial setting, we try to do things differently. The industrial sector is geared more towards the profit business, and approach to the market is quicker compared to how we do things in an academic settings. So just to give an overview, in this part, I'll talk about one of the projects we are currently working on is umbilical cord derived Wharton's jelly for regenerative medicine applications. And just for representation, we all know what an umbilical cord is. And if we look into the structure of an umbilical cord, it consists of two arteries and one veins. And the center portion, the jelly, is what consists of the stem cells, growth factors, cytokines, and hyaluronic acid. So just a brief introduction that as we all know that musculoskeletal injuries, they result in pain, loss of function, instability, and secondary development of osteoarthritis. Traditionally, they are treated using activity modification, by using physical therapy, use of pharmacological agents such as non-steroidal anti-inflammatory drugs, corticosteroids, narcotics, or viscosupplementations, and if everything fails, then a surgery. However, these modalities have certain limitations and potential side effects. To overcome these limitations, as I mentioned, regenerative medicine is evolving and there is a rise in use of orthobiologics. What are orthobiologics? They can be classified into two categories: autologous sources coming from the same person, or allogenic sources coming from a different human being. Examples of autologous sources includes platelet-rich plasma created from spinning patient's own blood, bone marrow aspirate, or lipoaspirate prepared by extracting and harvesting the fat from the patient. Allogenic sources include amniotic fluid, amniotic membrane, cord blood, umbilical cord, or umbilical cord derived Wharton's jelly, which we focused on in this study. So the objective of this study was to develop a novel Wharton's jelly formulation and to evaluate the presence of growth factors, cytokines, hyaluronic acid, and extracellular vesicles, including exosomes, into it. Briefly about methodology. So we procured human umbilical cords from consenting C-section donors. These cords undergo extensive infectious disease testing at a CLIA accredited independent lab for all these viruses. And then the Wharton's jelly was isolated from procured umbilical cord, and we formulated it into an injectable form. Those final formulations then undergo sterility testing using United States Pharmacopoeia Chapter 71 sterility testing guidelines. Then we performed ELISA to determine the amount of growth factors and cytokines, as well as the amount of hyaluronic acid, and the nanoparticle tracking analysis to determine the amount of extracellular vesicles in the formulation. What we found that there were numerous growth factors in this formulated Wharton's jelly. For example, we found presence of insulin-like growth factors binding proteins 1, 2, 3, 4, and 6, which are known to be a carrier proteins for insulin-like growth factor 1, which improves osteogenic differentiation, can induce androgenic differentiation, and can stimulate production of extracellular matrix. We found presence of TGF-alpha, which is a known ligand for HFR, which can promote proliferation and survival of osteoprogenitors. Another example is PDGF-AA, which stands for platelet-derived growth factor AA, which is a potent mitogen for cells of mesenchymal origin, and it's known to be downregulated whenever there is degradation of cartilage. We also found presence of immunomodulatory cytokines, such as RANTES, which is known to modulate macrophage phenotype from M1 to M2. M1 is the pro-inflammatory phase to a tissue healing M2 type. It's known to play a role in chemotaxis, osteoblast survival, and bone remodeling. We also found presence of interleukin-6R, which is known to bind to interleukin-6, and it plays a role in immune regulation and tissue regeneration. And it's known to activate downstream STAT3 pathway, which can promote osteogenic differentiation of mesenchymal cells via a autocrine-paracrine feedback loop. Interestingly, we also found presence of pro-inflammatory cytokines. So there is always a misconception in the clinical community. Okay, osteoarthritis is already an inflammatory disease, and now the product has presence of pro-inflammatory cytokines, so it should be bad. Actually, it's of the opposite, because the pro-inflammatory cytokines are actually the potential initiators of regeneration, and a proper sequence of inflammatory signals followed by anti-inflammatory signals is essential for healing. So we found presence of MCSF7 and MIP1 alpha. These both are essential for osteoclast formation, and then they play a role in early bone healing and maintain and improve structural strength of the bone. We also found essential anti-inflammatory cytokines such as interleukin-1 receptor antagonist, which is known to compete with both interleukin-1 alpha and 1 beta by binding to the interleukin-1 receptor. It can attenuate or prevent the cytokine-mediated inflammatory hyperalgesia, and an intra-articular injection is known to slow the disease progression and improve pain and WOMAC score. WOMAC is a outcome measures assessed for knee osteoarthritis. We also found presence of homeostatic cytokines, TIMP1 and TIMP2, which are known to regulate MMP activity. MMP is known to degrade connective tissue. It's known to be downregulated in aged or injured tendons. And TIMP1 and TIMP2 can regulate cell growth, differentiation, and apoptosis, also independent of their MMP activity. Similarly, we found presence of wound healing cytokines, such as ICAM1, which can promote leukocyte accumulation at wound site required for wound healing. MCP1, which is again reported to promote wound healing. And growth hormone, which can stimulate cell growth and is known to have a role in cartilage regeneration. We also found presence of hyaluronic acid, and it's known that umbilical cord tissue actually contains the high molecular weight hyaluronic acid, which is associated with fluid retention in joints. It's known for its anti-inflammatory properties, as well as to combat knee OA via counterprotection and other actions. Lastly, we also found presence of extracellular vesicles in the formulated Wharton's jelly. So firstly, we did the nanoparticle tracking analysis, and we found presence of 9 billion particles. So what this NTA does is similar to a Brownian motion. The limitation is it's actually tracking presence of all the particles going through the tube, and it could be cell debris or it could be other apoptotic bodies. Interestingly, majority of the particles, actually the mode size was 136, and it stayed between the exosome size range of 50 to 150 nanometers. To determine true extracellular vesicles, we used a fluorescent cell mask orange dye, which is known to only stain membrane-bound particles, and that showed presence of particles with a mode size of 137 nanometer. But again, one of the limitations of this technique is again that it will detect not only exosomes, but it will also detect microvesicles. So exosomes or extracellular vesicles, they are known for their potential anti-inflammatory and pro-regenerative effects. They are known to positively affect cell proliferation and viability, angiogenesis and immunomodulation. Some preclinical studies have shown that they can promote cartilage repair and chondrocyte proliferation in osteoarthritis models. So as I mentioned, there are certain limitations and future studies are required for this study. The ELISA kits we used, they can only assess only 40 growth factors when we know there are thousands of growth factors known. So there is a need to determine other growth factors and cytokines present in this formulation. As I said, that using cell mask orange, yes, we did get rid of apoptotic bodies and whole cells, but there is still possible presence and detection of microvesicles in addition to exosomes. Thus, we need to do some Western blottings or now the other kind of scopes which are in the market, which can actually stain these particles using exosome-specific markers. And we also need to determine other extracellular matrix components such as collagen and glycosaminoglycans in addition to hyaluronic acid in this formulation. So this work was recently published in the Journal of Orthopedic Surgery and Research. Without digging too much deeply, so we did a brief case report with Dr. Potty, who's going to be our next speaker, and he can talk more into the clinical perspective of use of different kind of stem cell treatments and orthobiologics. So we were presented with a 27-year-old Hispanic male with grade 2 osteoarthritis in the lateral compartment of the right knee. This patient had a previous history of right knee ACL reconstruction, and on physical exam showed mild crepitus, was positive on McMurray's test, showed laxity, showed ligamentous instability, anterior drawer sign was positive, and showed positive pivot shift and Lachman test. So just to give you an idea, knee osteoarthritis is graded using a Kallgren-Lawrence scale and consists of 4 grades, grade 1, 2, 3, and 4. So in grade 2, we see formation of osteophytes, but the joint spacing is maintained. As it progresses to grade 3, it's just not only formation of osteophytes, but the joint spacing is kind of lost. And 4 is even worse. So this patient was treated with the Wharton's jelly, and what we found that even immediately after the injection, he saw significant reduction in its pain. And over a period of 3 months, there is a 50% pain reduction. So 50% pain reduction is considered clinically significant. We also looked into the knee osteoarthritis and outcome scores. And what we found that over a period of 3 months, there is a 12-point improvement or 12% improvement in the patient score. KOO scale consists of 5 sub-questionnaires, and we also analyzed them individually. And what we found that the KOO's symptoms and stiffness total over a period of 3 months also showed a 14-point improvement. The pain subtotal showed a difference of 11 points. We did not notice much difference in the daily function. However, the function, sports, and recreational activities of the patient were again improved. And we saw a significant improvement in the patient's quality of life. So this is data from only one patient. So we see some trend, and this warrants like further investigation to determine the safety and efficacy of this Wharton's jelly for treating knee OA. And as we speak, we have already sought approval for 2 clinical trials where we will be just doing a pilot study, and then we will actually be determining the efficacy of Wharton's jelly compared to hyaluronic acid and a placebo group. And we hope by next year we'll have some better clinical results to show. With that, I would like to thank all of you. Merry Christmas, and I'm happy to take any questions.
Dr. Anil Kumar Gopinathan. Dr. Anil Kumar Gopinathan. Okay, Dr. Hashim,
I'm here.
All right, please.
I have unmuted. I unmuted. Yes. Thank you, Dr. Gupta, for your wonderful presentation. Not only the way of presentation, but also the content of this. The speech has been really marvelous, very much enlightened, very much informative. Thank you very much for that.
Thank you.
Now, and I have a question. How many years did you take? Because it involves so much of experiments, different kinds of experiments. How many years did you take for the entire thing? Whatever you presented here.
So the academic section that I presented took me about 2 years.
Oh.
And the industrial part took us about 6 months. So one thing, and important for our students too, so when we work in an industrial setting, so most of the times we actually outsource some of the works to independent laboratories. Okay. And for 2 reasons. One is it gives us independently performed experiments. So when we go to the market, people can't say that we were biased. And second thing is it speeds up the process because now we just have experts performing those experiments rather than having undergraduates trying to learn and figure out. Okay. And that's one point I wanted to say, that why industrial world is little different than academic, because time, you can say like time is money for them.
Yeah.
They want to move quick.
Great. Thank you very much. And now we invite questions from the audience, please.
Thank you, Dr. Kumar Gopinathan.
Yeah.
From my side, I'm happy that Dr. Ashim was able to take time out and come and deliver. For those who are interested, we went to the same university, Southern Illinois University, Edwardsville, but I think he's my junior. I mean, he joined the MBA program. I was in the environmental studies program. So that way we have some kind of a commonality, I suppose. From my side, more a cell-based question. At some point in your presentation, did you mention about the fibroblast feeder layer? Did you say you have a feeder layer of cultures, the mouse embryonic fibroblasts?
We use, yes, the mouse pre-osteoblast, MC3T3E1, yes.
Okay. How do you take care of the any xenogenic agents which could be introduced? Or do you irradiate do you irradiate the cultures?
So they were actually meant more for just the in vitro culture. So we actually bought like a commercial cell line from ATCC. So all we really did was just cultured it. But one thing in our laboratory setting we had 2 different labs. One was geared towards culturing rodent cells, and then we had another cell which was geared towards culturing the human cells. So that way we never have any cross contamination or anything like that.
Okay.
Dr. Asim, I have one question.
Yeah.
Yes.
So actually, you said that in that Hispanic guy, you injected this Warden jelly. Where did you inject, and how much cells did you inject?
Can you repeat that, the first part of the question again?
The clinical case study that you showed, no, for the Hispanic guy injecting the Warden jelly cells on his knee. So where did you inject, and how much cells did you inject?
So I can answer the second part of the question. So Dr. Potty is here. So Dr. Potty was the one who actually performed the procedure, and he can answer.
Sorry, Dr. Potty.
He can answer exactly where he injected, but for the cell part, I didn't touch on the FDA regulatory framework.
No, forget about that. I just want to know how much Warden jelly cells were injected and where was the locations.
Yeah.
So we did not. I cannot comment on the number of the cells we had in it. So let's say that way, it will get us into FDA trouble if we answer that question.
So it's supposed to be acellular because according to FDA restrictions, we can't inject anything which is cellular-based products. So as physicians, we only trying to inject it as allografts. So the standard injective procedures for any orthopedic surgery, it's going to be mostly a standard lateral portal on the lateral part of the knee. So that's what I used, using a standard 20 gauge needle in sterile conditions, and it was injected through the lateral portal. We injected close to 2 cc's. That's what the volume I chose to inject. And usually when I try to inject these, I try to give them at time 0 and then probably repeat it in 3 months time to get another booster dosage. And we've seen good results trending towards that.
No, very good result. Very good result. Very interesting. So you could inject 2 ml there?
2 cc's, yes.
Oh, okay. There is so much
space there. Even inject
absolutely. In the knee joint, you could actually go up to like 10, 15 cc's, you know. It's as sometimes we inject cortisone or other injectables, you can actually go up to 15 cc's. After that, people will start feeling a little bit of a bloated sensation. But anything above 10 is kind of an ideal, and 4 cc's is pretty much negligible. Most patients don't feel anything at all.
Sure. No, so I have little fundamental question, Dr. Potty, because this is a vascular area, and if there is no blood vessels, then how do these cells survive even for a little period of time? Maybe cells are not surviving; they are only paracrine factors.
And
what is your guess?
Absolutely, that's a great question. So the idea behind that is whenever we inject, there is synovium around the knee joint. The synovium is where most of the cells are alive. And that is nothing but the membrane which is encapsulating around the joint. the articular surface where the actual cartilage is actually not very vascular, but most of the nutrients and the supply which gets to this articular cartilage actually gets its nutrients from the synovium, which is joined around. So we think that this is enhancing the effect, the paracrine effect of the synovial cells, indirectly helping the pain receptors and the cartilage.
Residing the inflammation, right?
Breakfast, daddy சாப்பிட்டாங்களா? நாங்க எல்லாம் சாப்பிட்டோம். So, auntie.
Dr. Ashim?
Yes.
Yeah. The question actually was more related to whether the feeder, see, we talk about feeder-free cultures instead of feeder. So that hence I asked the question, because if you, in order to cut down on the possible addition of xenogenic agents, there's a lot of information literature, but we need to go for feeder-free cultures. So that hence the question. There's one more question from Dr. Manjubala, madam. What about degradation of carbon nanotubes in vitro and in vivo studies? Did you see remnants of CNT in the tissue in your histological analysis?
So we did not, and the reason for that is because we use the PLAGA with a composition of 85 to 15, and the degradation time for that PLAGA is up to 1 year. And the way those carbon nanotubes were embedded in the scaffolds, and one of the limitations of the study was it was only carried out up to 3 months. So by the time we euthanized the animals, the implants were actually intact, and we did not notice any in vivo degradation. In vitro, yes, we saw, because we increased the temperatures, it was continuously rotating, we sped up the process. So we did see some of the polymer getting degraded and remnants of the carbons. And the idea behind that study was from more basic science perspective, what this carbon nanotubes can do, and not really geared towards controlling their degradation, because for clinical applications, we know that there are presence of functionalized single wall carbon nanotubes. And in those scenarios, we will actually use the functionalized ones. So even if there are remnants, we know having a hydroxyl or a carboxylic acid group, they will actually be easily secreted by the urine in case they don't get degraded.
Thank you, Dr. Ashim. I don't see any more questions in the chat box, so I have
Professor, can I ask a question? I'm Tamar Selvi here.
Please, madam, go ahead, madam. Good morning.
Yeah, good morning. Dr. Ashim, the pro-inflammatory, actually in an inflammatory condition, there will be more pro-inflammatory mediators secreted, right? But here, when you inject this Watson-Selly MSCs, you say that they are producing some pro-inflammatory mediators. It would be additional pro-inflammatory mediators, right? How come they could initiate regeneration?
So the way we do it, and considering the FDA regulatory environment, so the way FDA currently permits use of these birth tissues is only two processes. One is, we call it like FDA 351, where it will be considered a drug, where we can actually manipulate the Wharton's jelly and get rid of those pro-inflammatory cytokines. And the other alternate that we are using is FDA 361, which is based on use of that the product should be minimally manipulated and should be only for homologous use. So we only just see the presence of those pro-inflammatory cytokines, which do come with the product. And there is actually nothing we can do by not crossing that line from 361 to 351 if we try to get rid of those pro-inflammatory cytokines. But what we have seen over the years, so this product is actually out in the market, and we have seen the amount of anti-inflammatory markers is way higher compared to the amount of pro-inflammatory cytokines. And as Dr. Potty mentioned too, we do not use any cryoprotectants. So when we thaw these vials, we're pretty sure all the cells are dead. And we also believe that, and I've been actually talking to Dr. Kaplan for a while on it. So he used to call these cells mesenchymal stem cells, and now he changed the theory that these are medicinally signaling cells, and all these MSCs now are activated parasites. So parasites are actually present on every single blood vessel in our body, so there is an abundance. So as a scientist, I also personally believe that there is actually no need for exogenous MSCs to be transplanted into the body. Body has a lot of them. So all we really need to do, for example, in case of osteoarthritis, is our body is actually programmed to handle acute inflammation. Osteoarthritis is a chronic inflammatory state. All we really need to do is just modulate that microenvironment from chronic towards the acute state, and presence of these anti-inflammatory markers and other growth factors. I think it just modulates that microenvironment enough for the body to recognize this as a diminishing inflammatory state, and that's where body actually releases all these stem cells to the site of injury. And that's where we also believe that exosomes, which are actually involved in cell to cell communication, comes into play, and even send more signals to these different kind of stem cells in the body to go accumulate at the injury site, where they can initiate that process of repair and ultimately leading to the regeneration of those tissues. So that's like my theory, like talking to a couple of peers and experts in the field where we feel like they are not needed. And I know Dr. Potty has been using these kind of products for a while now, and him and I like pretty much talk on regular basis. And that's one question, like me coming from scientific perspective and he from clinical, I always ask him like, hey, what are the outcomes you are getting? So I can see if my scientific hypothesis kind of aligns with the clinical outcomes we are seeing. So we can like design some studies to actually determine the mechanism of action. And we call it this field of regenerative medicine in United States that it's a wild west, because it works differently than the normal drug pathways. Usually drug pathways, we do everything, we know everything, then a product comes out in the market. While in regenerative medicine, with all these orthobiologics, everything is in the market and nobody really knows how they work, what's the composition. And that's one of the reasons we were the first one for Wharton's jelly to even just like put in, okay, what growth factors are in there, and journals were interested. Oh, we'll publish that because nobody has even done it. And everybody is selling it. So yeah, this field is, I'll say, still in the infancy stage and it has more questions that needs to be answered before we say affirmatively, yes, these treatments are safe and efficacious.
Thank you, Dr. Asheen. If there are no other questions, I'll request Dr. Anil Kumar Gopinathan to take over.
Okay. Thank you. So I think we will consolidate the entire session, isn't it, so Dr. Suresh? Hello. Hello.
Hello.
Hello.
Yeah, you're audible. You're audible.
Oh, audible. Okay, and nothing is seen on the screen. Okay, so we will consolidate. Yeah. Okay. This is for the next session. Dr. Suresh.
Yes.
Hello.
Yes, yes.
So we are going to consolidate this session, isn't it? So
yeah. It was from Dr. Potty's side. Dr. Potty, could you just wait for a couple of minutes? An introduction has to be made, Dr. Potty.
Of course, not a problem.
Yeah, that will be made by our chairperson, for which I need to project your intro slide, Dr. Potty.
Oh, okay.
Yes, please.
So I need to stop sharing, right?
Yeah, briefly. I should have told you that. I told Dr. Asheen in the morning. I should have told you that. I'm sorry.
Okay, how do I? Okay.
There will be a stop sharing.
I already stopped sharing. So.
Fine. Thank you.
Dr. Anil Kumar Gopinathan?
Yeah. So we are ending this session, and the next. I once again, on behalf of the organizing committee, I would like to thank Dr. Ashim Gupta for the wonderful talk, which was very much informative, and at the same time, it is very valuable from the application perspective. So thank you very much, and we are moving into the next talk, and I am handing over to Dr. Suresh. Thank you, Dr. Suresh.
Thank you, Dr. Anil Kumar Gopinathan, for starting the first session. Now I am going to project. So now I'm going to welcome the chairperson for the next session, Dr. Kavita Tirumurugan. Welcome, madam.
Good morning, sir.
Yes, good morning, and I will be the moderator assisting her with especially with the Q&A. Now I am going to project the slide for madam to make the introduction. And for this, I need to share the screen. 1 second. Okay, need to make it bigger. Yeah. Is it visible, madam? Is it visible?
Yeah, visible. Yes, sir. Yes.
Yeah, please go ahead, madam.
Yeah. Thank you, Professor Suresh. So it is a great delight for me to welcome Dr. Anish Potti, orthopedic surgeon, Laredo Sports Medicine Clinic, Laredo, Texas, USA, to the International Virtual Conference on Update on Stem Cells, Academic and Industrial Perspectives, Future Challenges. Okay, Dr. Anish is transforming orthopedic care by the integration of technology. He developed great expertise in orthoscopic surgeries of knee, hip, shoulder, and ankle in adults and children. His practice interests include joint preservation, joint orthoplasty, deformity correction, trauma, fragility fractures, and metabolic bone diseases. His clinical practice has been averaging about 3,000 outpatient cases and 600 surgical cases a year, and orthopedic care to underserved area in South Texas region. That is remarkable. Dr. Anish serves in the editorial board for Orthoscopy Journal and reviewer for the Bone and Joint Journal, Journal of Pediatric Orthopedics, HSS Journal, and Journal of Experimental Orthopedics. His keen research focus has been in developing future cutting-edge technology and innovations in patient outcomes. Serving as Chief Medical Officer, Scientific Advisor, and Consultant with various companies, he has gained experience in implants designing, development of novel technology, and FDA processing. It's a great pleasure for me to welcome Dr. Anish Potti to deliver a lecture on augmenting biology in bone and tissue repair. Are we closer to a perfect repair? We will hear from him, and it will be a great session, I suppose. Please, Dr. Anish, please, over to you. Yeah. I'll stop sharing 1 minute.
Yeah, stop sharing. Madam, I have stopped.
Yes, you stopped. Yes, yes.
I think new share.
You need to get to the PPT. Yeah, we are able to see your screen. You need to just open your PPT.
Perfect. Can you see it now?
Yes. Could you do it in the full screen mode?
Okay. Is that good?
Yeah, it is clear. It's clear.
Perfect. Okay, thank you for the kind introduction, Dr. Kavita. I think appreciate it. It's always an honor to be welcomed in such a prestigious institute and giving me an opportunity to talk about what we do here in South Texas. We try to go the cowboy way, you know, but that's how my OR operating room looks like. But I'm going to try to go a little bit easier and not the cowboy way today, and maybe the normal way I came up from. So here I'm going to talk about augmenting biology in bone and tissue repair. Are we closer to a perfect repair? These are my disclosures, but I don't have any disclosure for this talk. What's new in cartilage restoration? A biological approach in early arthritis. So I just wanted to go about and saying, what are we doing now? We are just really in the tip of the iceberg, trying to just hit main points in kind of how we can repair cartilage. At the moment, surgically, what we do is chondral debridement, which is we go in with keyhole microscopic surgery. We go into the cartilage. We just kind of use a shaver and just debride or remove the broken pieces of cartilage, just like how a gardener kind of just removes grass from the surface of an overgrown grass. So the same way, we just go in and remove that. We also do something called microfracture. What microfracture really suggests is we make tiny little kind of puncture holes into the surface of the cartilage or on the bone and encourage the bone marrow and the stem cells of the natural bone to come in and form new cartilage. We also have going ahead with doing multiple osteochondral grafting, which means that we can get a cadaver cartilage from a donor, and then we can transplant it into the area of the cartilage where the defect is. We also do multiple bone marrow stimulation. One is obviously with the microfracture, but this bone marrow stimulations can be done with multiple techniques, from an inside out technique or from an outside in technique. Over the last decade, we have gone into leaps and bounds into something called autologous chondrocyte implantation. What it really means is we go in with a primary surgery, remove a piece of the patient's cartilage, send it to the lab, mostly in South Korea or in Germany, where, but nowadays they do it in Boston as well, where they grow this cartilage and the patient's own cartilage into numerous cells. And we then get this source back from the company and we inject it back into the patient's knee. But again, that was the first generation of the autologous chondrocyte implantation. But over the years, we have been improving our technique, and this autologous chondrocyte implantation has gone in and we are doing a little bit more in terms of that, which is called the matrix autologous chondrocyte implantation. So there is a real excitement here when I talk to you about this, that how we are getting better in terms of allowing the cartilage to regenerate better and deliver this chondrocytes or cartilage cells into this area of defect to improve healing and decrease the incidence of osteoarthritis in the future. So we do something called augmented microfracture, which is we do a microfracture technique, and maybe we inject it along with the stem cell or a PRP rich process. So we're just kind of increasing the patient's own marrow cells and adding something, an adjuvant, to kind of increase, and that is called an augmented microfracture process. We also do the matrix-assisted autologous chondrocyte implantation, which I was just talking to you about, where we can get the collagen matrix, and on top of the collagen matrix, the autologous chondrocytes are grown, and then this is again sent back from the company, and this small graft is then sutured back onto the lesion where this cartilage defect is. We also have a matrix and the stem cells combined together. So Mintz cartilage was also another process we recently developed. I presented it in multiple places, and it's known to be very effective, especially in adolescent and pediatric population, where the cartilage has much more regenerative ability compared to the adult population. So Mintz cartilage is a technique where there is a defect, and you take the patient's own cartilage, we kind of mince it into 1 to 2 millimeters, small little pieces, and then we introduce these pieces back into the defect and paste it with a fibrin clot to allow this to kind of restore the natural surface of the cartilage. Again, osteochondral implants are again in multiple ways. You could actually borrow a part of the chondral cartilage from the patient's own knee, which you don't actually is not in the weight-bearing portion, and we attach it back into the area where there is more necessity for a weight-bearing process. And there are also multiple injectables which are being coming out, what Dr. Gupta was talking about, the Wharton's jelly and things. So this field is exploding, and it is really going to be a $1 trillion market in the future for treatment of arthritis. But what are the various challenges we face? We have so many options, but we really don't have the best way. And what we think might be a very good laboratory process, but this process might not be a great clinical process, because there's a lot more we need to understand and know how this can be translated into actual clinical process and giving greater outcomes to these patients. So during in my operating room and before my decision process starts, even before I start thinking about how I go and repair these. So there are a few points which I really think in terms of my strategy to understand and repair these cartilage lesions. The first and foremost, the important thing is to identify the lesion and to see where this lesion is. For example, the site of the lesion, the size of the lesion, and the amount of lesion, how long it has been there for. Once we identify and know these lesions, which are best done with various MRI machines and MRI technology, and our MRIs have got even better. And we also do something called a degeneric MRI, where you can really map the amount of cartilage and the thickness of the cartilage to identify these lesions in a much more sophisticated manner. Then the option is to select the technology. What technology, which I described now, is the right technology for the right patient. And then comes the crucial part of the surgical technique and how we are going to deliver these cartilage cells into the right spot to make the best process of surgical technique into delivering this. And finally, is the postoperative rehabilitation. And it is very important that once you repair the cartilage, you need to rehab the patient in the right way to get the best best results or the outcome. And I also know we just talk about know your lesion and using, sometimes you also need to do X-rays, MRIs, as I told you about the digemeric MRI, and also about the arthroscopic evaluation we can do using optical reflective spectroscopy, where you can understand the depth and multiple lesions. So this is an arthroscopic view where the microscope is in the knee and we are looking at the kneecap, and this is the spectroscopy view where it's called a bio-optical coloring technique, where you can see that wherever there is no color, there is no cartilage damage, and wherever there is red and dark, there is severe cartilage damage. And once you put in this optical spectroscopy, you can really understand which part of the cartilage is really damaged in a more intense manner. So in terms of selecting the technology, we are going through multiple things. We went through marrow stimulation, microfracture, subchondral bone drilling, and then osteochondral bone grafting, which can be called something which we call it as an Oates procedure, or osteochondral allograft, which is a graft which we get from a cadaver. Marrow stimulation. The advantage of these multiple procedures is marrow stimulation is very simple, inexpensive, but the process is, unfortunately, you don't get a good repair. The quality of the repair is bad because you don't get articular cartilage. The cartilage which regenerates is more of a fibrocartilaginous process. So the durability of this cartilage is much less compared to a normal articular cartilage. And within a few years, the patients will start getting pain again. And the larger the lesion, the marrow stimulation is not that effective. ACI was first introduced in 1987 and first published in 1994. I was there for the first few trials when I was at the Royal National Orthopedics in Stanmore in England. And we did a great study about greater longevity compared to microfracture, and they're good for larger bone lesions compared to microfracture. But the process of ACI is laborious. It's a two-stage process. We have to do the surgery on the patient twice, and also it's very expensive. Each processing can cost up to $40,000, which can be spent, and it can be really an expensive process in terms of dealing this. And again, with ACI, with autologous chondrocyte implantation, you're getting closer to a good repair, but it's still, it's hyaline-like cartilage, not true articular cartilage. Osteochondral allografts are a little bit more better in terms of you get immediate hyaline cartilage. It restores subchondral bone architecture because it gives you both the cartilage and the bone. And the only problem is in a lot of the countries, allografts are not available, and it's very hard to get a good site allograft, because you got to really get it from the knee, or you got to get it from a good younger population to have better, because by the time you get older, then there's more osteoarthritis, and those type of cartilage grafting is less ideal. And again, there is a process of disease transmission and donor variability, which is again a big risk. So again, I'm more interested in what I discover than what I invent. So as Paul Simpson said, so I try to look into understanding those in a much more clinical aspect whenever I try to read most of my papers. So augmented marrow stimulation, like matrix and scaffold, you can see this is a paper by Cole et al., and which addresses multiple combination of different subgroups together. So it's called you augment the technology and autologous matrix-induced chondrogenesis. Again, there are multiple companies which come into it, and part of it is there's a CarGel, there is a GelRin-C, there's a biocartilage which is from a company called Arthrex, and then there is again a natural chondral tissue. So AMIC was studied by Brehans and colleagues in 2010. AMIC is a porcine collagen derivative. It is porcine collagen of 1 and 2 ECM. There are multiple studies which have done. There is also an RCT which was compared with conventional microfracture versus AMIC, and shows microfracture had declined patient-related outcome metrics compared to AMIC, and showed good results in 2 to 5 years. The BST Cartigel, you can see that again, this is a Canadian-based liquid scaffolding. You can see how the drop time implantation, you just drop it into the defect of the cartilage here. You drop this source, and basically this cartilage is made up of liquid chitosan and autologous whole cell blood. Again, an RCT on these shows superior scores And when the surgeon went back to look into those defects, there was good healing. But they never did any kind of biopsies to confirm the type of the actual cartilage. Gelrin C is another product. Again, you can actually see again how these holes made are actually the microfracture process, and the lesion. This is a small little instrument which comes across like this, and you can see this membrane across this, which kind of seals this area to kind of improve the cartilage healing. And polyethylene glycol and diacrylic is what they use with denatured fibrinogen to kind of supplement this. And once that's done, you got to do UV light to cross-link these polymers so that this kind of stays into that process. Again, very laborious and very hard to do in an operative technique. But the results are kind of, again, variable. So so we need to do more studies to increase and understand about these. BioCartilage, again, is the Arthrex BioCartilage developed in Florida. Again, it is micronized allogenic cartilage, which we add with platelet-rich plasma. And we do have some data which is coming out, and MRI studies shown after that shown that normal cartilage-like process. This is one of my patients. You can see where the defect is, and you can see how when I went back, the lesion is kind of much better compared to the previous lesion. So chondral tissues is again another process, again from the biotissues from Zurich. This is a PGA and hyaluronic acid composition, which you can actually see that there's a good knee outcome score improvements from this tissue as well. So the matrix-assisted autologous chondrocyte implantation, this is how kind of it kind of looks like, where you take a piece of it and then you kind of suture this back into the knee to cover this cartilage. The generation of Macy's, as you can see, that this is the actual initial lesion in the knee, and that's the white part is the cartilage, and where this is the lesion, what you see in the knee. And at time 0 of the implantation, you can see that how we kind of shaved the remaining lesion and sutured this lesion back. In 8 weeks, you can see how this kind of improves healing, and by 6 months, you can see it looks like almost like a normal cartilage. So the other one is MSCs and Matrix. So again, there's multiple companies kind of doing that. This is a Boston-based company which shows where you have this a scaffold which absorbs the actual cartilage, and then you kind of put it back into that lesion, just like how I showed in my previous slide. This is the Mintz cartilage technique. This is what we developed, you know, like you can see the cartilage is micro cut into multiple small pieces, and then we put it back into the lesion. This is the undersurface of the kneecap on a young child, which I did, and then you paste this across. So this is called the Mintz cartilage. So multiple companies are doing this. So De Novo is the Zimmer Biomet based one, and you can also do it from the harvest from the same person as well. So osteochondral allografts are again fresh frozen allografts. You can this is how the company kind of makes it and dries the whole graft and has micro kind of punctures into it, and you can usually fashion this to whatever size lesion it is by using a scissors. You can cut it out just like how a tailor can cut for patching up the clothes, and you just kind of put that patch there. And Cardiform is again an Arthrex product which is more commonly used. BioUni is another interesting, where we take a piece of the actual bone, which is actually cut into same size. So again, this is a patient of mine where the lesion was so huge. So we drilled that piece of bone, and then we put this cartilage back into that position to kind of get enhanced healing. So osteochondral allografts are multiple companies, have different different phases. So usually this in MyoRegen, it's a 3-layered biomimetic osteochondral scaffold where it's got equine cartilage, 40% magnesium, and the deep layer has got equine collagen. And you can see those 3 layers in that. European trials shown that 75% fill and 90% cartilage restoration using these techniques. And various injectables, as we know, were widely popularly used is a PRP, where you can see the platelet poor plasma and the platelet rich plasma, and this is what you want to kind of inject into getting better quality results. The other injectables are BMAC, it's bone marrow aspiration. Bone marrow aspirate concentrates. Chella and his colleagues shown that it significantly improves the osteoarthritis. You can use lipogerms, spermifene, or OP, that is a BMP7. All these are being tried in this thing. So tips for managing the cartilage lesion is in non-operative patients, I would try to use PRP and BMAC injections. If the lesion is smaller than microfracture and augmenting with bone stimulation. If larger lesions, then we use minced cartilage and biocartilage. If the lesions are really large, then I go for an osteochondral graft with PRP. Here I'm going to show you one of the papers we just published recently for doing intraosseous bioplasty of a cyst, where you can see that what are the common procedures, or you can do it for arthritis. You can use it for rheumatoid arthritis, and it's an emerging technique, especially when there is collapse of the bone below the cartilage. So we had the 74-year-old male with no other history. So after we got his PRP and mixed it with the demineralized bone matrix, I decompressed the cyst and filled that cartilage lesion onto it. So if you see that on my left side, that is an MRI image where you can see there is a normal articular cartilage, and this is the huge cyst which was causing the patient significant pain in his lateral femoral condyle. This is the intraoperative pictures. When I went in, you could see that how these, because of his metabolic problem and bone diseases, you can see that how the cartilage is kind of become like more bubbly in nature. Again, the way we do it is this is the knee, which is bent in 90 degrees, and this is my needle, which is called the Jamshedi needle. I'm putting the needle into the knee, into the thigh bone, and aspirating with a 30 syringe needle and getting almost 60 cc's of bone marrow. Once we obtain this bone marrow, and on the right side, you can also see that this is my microscope, the arthroscope, which kind of goes into that. These are only 2 tiny incisions. That's all you see, which is usually completely done with a 0.5 millimeter incision. Then once you go inside, you kind of mix this with demineralized bone matrix, and then you get the concentrated bone marrow and form it into a nice little putty, and collect this putty using a 14 millimeter syringe, and then kind of inject it back into the defect. I don't know whether I can show you this video of how I'm kind of clearing that. Hopefully we can show you that. Okay. Yeah, it's a big video, so it's taking a little bit of a time for that to come back. Yeah, apologies. I think I opened all my. Okay, anyways, I can't open that. So we'll go to the next one. So the results showed that the radiographs from 3 and 6 months indicated that the intraosseous bioplasty was successfully filled the defect, and the patient had increased range of motion and almost 50% reduction in pain. So you can actually see that the slide A shows that that's where the defect was. And in 6 months, in 3 months, and in 6 months, you can see that how this is completely kind of gone. You can't see this bone defect at all. So the discussion says that intraosseous bioplasty is a way to kind of deal with the bone lesion, which is below the cartilage, and that really helps to enhance the bone lesion. Next, I'm coming into how you manage a rotator cuff, which is like more like a tendon problem. And it's one of the most common problems, what you see in people with shoulder pain. The outcome for rotator cuff has been improving with recent advantages in surgical techniques, and everything is pretty much done with keyhole surgery. But however, there is still a very increased failure rate, especially for big cuff tears. And can we do some biologics, or can we do something stem cell wise to kind of improve this this healing process? So the re-tear rate is actually high, and most of the re-tear is attributed to older age and bad quality tissue, chronicity, and the size of the tear, muscle atrophy, and fat getting infiltrated into the tendon and decreasing the ability to heal. And some surgical techniques, some say that using a double row technique can improve the quality, and definitely the bone density kind of plays a crucial role too. So how can we get better? The first step is to understand the anatomy and the way how the tears happen, and knowing the healing process of how once a tear happens, how is it going to heal back, and how we can enhance this with better bone fixations and with better quality tendon repair. So what options do we have? Improve the mechanical construct by repairing the graft and augmenting the graft, enhancing the biological process by repair in addition with the biology. So multiple strategies can be utilized for us, so it is kind of the balance between biologics and mechanical formation. So you can use BMAC, marrow stimulation, and PRP. Increase surgical technique. You can use extracellular matrix and using anchors, which enhances the quality of the tendon. So mechanical graft augmentation, synthetic and natural biomaterials have been developed to improve into the scaffold. So we have multiple different types of scaffolds, as we said. There is synthetic and biological materials. Xenograft is obviously obtained from the porcine or from equine type of collagen and the small intestinal mucosa. And synthetic grafts have been kind of raising concerns with adverse host reactions and poor tissue integration and need for multiple surgeries. So we are kind of not using any of these synthetic scaffolds at the moment. The ideal material should be able to meet the physiological demands of the native tendon, where there's extreme amount of force which actually goes through the tendon when there is a lifting motion against gravity. So we need to kind of restore that the physiological needs and the anatomical orientation of the tendon to give a maximum ability for healing. And the other important thing is also to provide an environment where enhanced healing and regeneration can take place. So allografts, as you can see, is again acellular human dermal matrix. has been promising, but still now we haven't had a lot of studies which makes their efficacy validated. Bond et al. Reviewed the outcome of 16 patients with massively contracted rotator cuff tears and arthroscopic placement of a graft jacket, and this yielded a failure rate of 19%. And a similar study by Barber et al., which is a multi-centric clinical study on 42 patients, also showed there was some superior outcomes with the augmented group compared with the non-augmented group. So definitely there is some role in that. Similar results were found by Gupta et al., who we looked into like 24 patients as well. So next, coming to synthetic grafts. So synthetic grafts were also used where we enhance with PLA or PLA-GA. But again, there is some tissue reaction, which is kind of put them on less favorable. The other problem with these PGAs were rapid reabsorption and failure of the healing, and which created more problems as the mechanical strength at the tendon insertion was significantly less compared to the primary type 3 collagen found in those bone tendon integration area. Moffatt conducted an in vitro evaluation and aligned an electrospun PLA-GA-based nanofiber scaffolds with pre-engineered mechanical properties matching those of native tissue. But again, this is still being in vitro stages, and we haven't actually seen that at clinical this thing. So autografts. So what are the different types of autografts we can use? We can use a fascia lata, we can use an ITB, and we can use a biceps tendon to kind of repair this. This is an extremely busy slide, but it kind of really captures that so much of work has been done, and people are still trying to find the ideal graft or the ideal candidate because we still have issues with re-tears and failure rates in spite of getting the best graft in its right position with the best repair at time zero. But again, during the process of the healing, it doesn't give the patient a good outcome. So we are still trying to find what is an ideal situation, and that's why the biological augmentation has come into a huge huge success nowadays. Again, you can see marrow stimulation process combined with PRP and stem cells, and also the question of amnion. But again, the literature is very sparse in terms of amniotic injection, and we really don't have any long-term or actual clinical evidence which says that these works. In my personal experience, I have used multiple amniotic injections as well as amniotic grafts, and I'm going to show you some slides which we actually how we place it. But again, we still need more robust data to kind of show that these processes really work. Next slide. Okay, strategies for biological augmentation in rotator cuff. The proper growth factor or a combination of growth factors are very essential because you want to balance the biological environment in the shoulder, in the rotator cuff region, because you got to stimulate the marrow cells to help the healing of the tendon into the bone, and the interface where the tendon to bone healing is a very complex process of how you can unite the tendon. The cells at the host site to respond also respond for growth factor signaling. We need to consider that. We need to also have a good blood supply or an adequate bed where these host cells can actually reach the actual tendon and improve the healing process. Again, the delivery method or the actual surgical process is also very important, because you're trying to balance the mechanical stability with the biological augmentation to get a great outcome. Again, this is a small video of a graft which I'm just placing through a small little portal in the shoulder, and this is kind of pushed back into the area where the tendon is, and then we kind of use these sutures to shuttle them and tie these sutures on top of the graft to kind of place these sutures back into its position. This is another technique for a BMAC. As you can see that I'm using a small little needle which is going into the humeral bone, and as you can see, these fat cells coming out, and I'm aspirating the needle to get the bone marrow aspiration so that we can concentrate this and use it on the repair of our graft. This is again another technique where I'm instilling an amniotic patch. I'm using a small little probe, and this is a dry scope where this is a patch of the amnion which I'm laying on top of my graft so that we can enhance the healing process onto that graft. Here we need to make sure that the graft is kind of well seated, and the actual tendon is integrated into the bone using some sutures and the anchors on the bottom. So again, if you look at the real evidence, there is not much of clinical evidence, because we haven't really moved or we don't have enough data which is moved from the lab to the actual clinical process, which shows that there is an improvement. But again, with PRP and stem cells, one of my mentors, Dr. Mafuli, has documented that lower re-tears with PRP use for small and medium type of tears. But one study has shown that PRP doesn't really work for massive or larger tears. Papalia also found that one out of 7 studies indicated decreased amount of re-tears using biologics. Stem cells, Philippe Hernigo from France is one of the pioneers in understanding the uses of stem cells in orthopedic applications. He did a study on 45 patients and utilized ultrasound and MRIs at 3 months, 6 months, 1 year, and up to 10 years, which is kind of the longest study we see, and looked into re-tears and compared it with BMAC, and 56% and with 13% re-tears were seen. There is also a kind of a dose dependent with MSCs, and the lower doses and number of lower CCs kind of had a lesser healing response compared to the higher number of mesenchymal stem cells. We are also going into a gene therapy where they found with certain genes with an adenovirus in vitro demonstrated capabilities of transferring the genes into fibroblast. However, these are all again in a very infant stages, and we really don't have much of an evidence from it. In conclusion, I think there is no evidence. I feel that I'm in tip of the iceberg in this journey to get the perfect repair, and I think with all your help, I think one day we'll be able to get a good, great repair. Thank you very much for your kind attention.
And that's a marvelous talk. Dr. Suresh?
Yes.
Okay.
Yeah, and now Dr. Kavita Thunmurugan, you want to say anything?
Yeah, it's a detour for us, including seeing videos and the procedures. It looks bewildering for non-surgeons like us. From my side, people who have a brittle bone disease, osteogenesis is imperfect. So do you come across anyone with the genetic disorder? And because it's hard to do heal them, I suppose. So.
No, absolutely. I think the type of collagen is very sparse that you have OI or osteogenesis imperfecta from type 1 to type 4. Usually type 1 and type 2 are usually non-compatible to life. People with type 3 and type 4 do have some amount of compatibility to life. Usually we see patients with type 4 who have multiple bone fractures. The problem with these is because they're not forming the lamellar bone formation. They do tend to heal, but whenever they heal, their bone actually is brittle and they cause multiple fractures. We really, at the moment, we just don't have any treatment. We have tried multiple personally, we do the same techniques of mechanical stability, because if the bone is moved or angulated, we do tend to fix it with plates and some screws, and add some biologics like bone marrow aspirate, or we do add some PRP to kind of enhance the healing. But again, I think mechanical stability is pretty crucial for these people. But as it's a great question, but we still are in the tip of the iceberg here too.
Thank you, Dr. Potty. And subsequent, one more, because I'll give room for other people. From your experience, which type of fractures are very difficult to repair? It's a general question.
Yeah. So I think the fractures which have associated metabolic problems are people who have diabetes, or who have some kind of thyroid problems. These people are harder to repair, because you could put a good construct, or it's like building a house, right? You could build a good house, but if you don't utilize the right amount of bricks, the house is not going to stay too long. It's going to crumble and fall. So people with diabetes and with other problems, the cell regeneration, or cell which puts the actual bone, is glycosylated. So the amount of structural strength those particular bone has is much lower, and even though you put a good construct, it doesn't heal, and it goes into something called non-union, and that is where the problem is. So I feel challenging is fixing any fracture is actually the simplest process, but understanding the biology behind that and seeing how these fractures will behave after you fixed, I think is the most difficult part.
Oh, nice. Nice to hear that. Dr. Suresh, as a moderator, you'll have some questions to ask. Thank you very much. Yeah.
Thank you, Dr. Kavita. Dr. Anish, thank you for a wonderful talk. I just want to ask you about issues pertaining to allergenicity. I mean, are they with equine collagen?
Yes, absolutely. So the most of these collagens are like treated, and I've not noticed a huge amount of allergenic response with porcine or equine or bovine because they don't really have cells. It's pretty much the collagen. And I think the cell response is what causes them to become more of an allergenic response. Usually we try to, most of the companies, when they come, they really make it absolutely certain that they clean up most of the cells. So in my personal experience, using grafts has not been associated with huge amount of allergenic response.
Thank you. The minced cartilage, how do you actually, it's available commercially, minced cartilage?
So the minced cartilage, there are 2 or 3 companies which actually gives you minced cartilage. The problem is it's called De Novo. It's made by a company called Zimmer. So the de novo cartilage is actually got from adolescent cartilage. So you can understand that it has to happen after a death of a child, which is like below 18 years. To acquire that amount of cartilage is going to be so hard. So the availability is very rare, but you can still get it. The company actually will harvest those cells and has to be transferred to you within like 5 days. So the longer process you keep it, the uptake goes down and the chance of it surviving goes down. So there is a lot of logistic problems associated with this. So the commercial available is gone out of favor because of that, because of the expense and because of the logistics. But what we do now is to utilize the patient's own cartilage. So we take or if they have a break in the cartilage, we take off those broken pieces, we collect those cartilage, and then we take it on the back table, we mince it back, and then put it back. So I think that has become more of a fashion now, rather than getting the de novo, which is company-made cartilage, because of the expense and hard to find it.
Thank you, Dr. Patti. We have a question from a participant. The name of the participant is Shena Srivastava. The question is, two questions. Why can't the minced cartilage method be used for large lesions? First question.
So that's a great question, and totally, if it's because of the structural integrity, because when you look at the three-dimensional model of any knee, they're not flat surfaces. It's got a radius of curvature. It's got a lot of ups and downs. It's just not like a perfect perfect wall where you can actually put that cartilage and it'll stay forever. So the size of the lesion, the site of the lesion, and the weight-bearing nature of the lesion all makes a huge difference. So when you use the minced cartilage, it's just like if you have a wall which has got a bigger hole, you can't just do like a plastering and just leave it. You have to put some building blocks or something which is much more robust in terms of the articular cartilage, and also to restore the bone behind it. So you can go up to about 3 centimeters with a minced cartilage technique, but when you go beyond that, it just doesn't give the enough structural stability to get a good repair. And that's why we have to go for an allograft cartilage, which is a bigger cartilage piece.
Okay, could you, same person, could you elaborate on how cartilage is implanted in the human body?
Yeah, so once we acquire the cartilage, whether it's an autograft or an allograft, you can implant it with multiple techniques, with surgical techniques. So 95 to 99% of the techniques are done with arthroscopic technique, where you go in with a small little microscope, you make a small little hole in the knee, and you make another portal where you can actually pass these cartilage chips, or there are delivery techniques where you can put it into that defect and then paste it with fibrant glue. But if it is a large lesion, as I said, like when it goes beyond 3, 4, or 5 centimeters, then you really will have to make a small incision and look at the lesion and then graft the cartilage into that defect.
Yeah, thank you. The time is now at 10:25. Madam,
so suddenly I thought he is in the sports clinic. So athletes who have ankle sprain and very frequent injury, and it's very painful, ankle sprain. How do you deal with it? Like, because they need to heal faster and to go back to the tracks. So
absolutely, I think it's because, as you see, that the ligament injuries take actually longer time to heal than the actual bone fractures. The typical time for a fracture to heal is about 6 weeks, but the ligament can take up to 8 weeks for it to heal. And during that process of healing, the athlete can get completely, atrophic. Like it's very hard for him to get back into sports, and he can get completely deconditioned. So we use multiple techniques to kind of trying to enhance. We try to make sure that the overall muscle strength and integrity is still maintained. We augment some of those depending on the surgical necessity. If the ligament is completely torn, we do surgery, and we augment these ligament repairs with something called as an internal brace, where we use high strength sutures, which are made up of polyethylene, along with the actual native repair. So they're back to playing within like 1 to 2 weeks. It gives additional strength in the construct of our repair. And we add some biologics on top of it to get them back faster.
Interesting. Thank you. Suresh, sir.
Okay. I see in your address, Dr. Potti, you are also associated institute in San Antonio, Texas.
Yes.
Yeah, I was in Austin, Texas several years ago. I visited San Antonio. I think it's a wonderful.
Yeah, me too. Yeah, everywhere cows, the statues, and yeah, nice.
Wonderful town. And at one point, they were going to model Chennai, or rather remodel Chennai along the lines of what it is like in San Antonio, Texas. That's what we read. We read about that in the news, of course, a few years ago. I don't know what happened after that. So thank you, Dr. Anish Potti, for taking time out. I know, is it close to 10 o'clock now? Or?
It's 11.
11 o'clock. Yeah, it's very nice of you to have stayed up for us, and Dr. Ashim as well. Dr. Ashim, as you know, we went to the same university, Southern Illinois University, Edwardsville.
Yes.
He got an MBA, and I was in environment studies, but I think he was my junior. I think he must have studied several years later. Must have joined the institute several years later. Thank you, Dr. Potti, and thank you, Dr. Kavita Tirumurugan, for sharing this session.
Yeah. Dr. Potti, if you could come in person when pandemic's over, that would be great. People have several questions to ask you in person, maybe. Yeah. Thanks. Bye.
Yeah, you're most welcome to visit VIT once the pandemic situation is resolved. Please do visit us. Thank you.
Thank you so much. It's an honor. Thank you, Suresh, and thank you, Dr. Kavita. Thank you, Dr. Suresh. Bye-bye.
Thank you. Bye-bye. I'd like to make a few comments here. The time is 10:27. I think with the permission of the organizing secretaries, we will take a 10-minute break. There are quite a few questions about the feedback form. Please be patient. We will send you the link for the feedback form today. Be reminded that you need to attend 5 sessions, including the inaugural. For you to be eligible for the certificate, also you need to fill out the feedback forms. Please be patient. We will send the link for you to fill out the feedback form. You must understand that you need to attend all the sessions for you to have a good idea of what this 2-day conference is all about. Then you'll have a better idea, and you'll be able to fill out the form in a better way, which is why we are holding back. No other reason. Okay. So time is around 10:30. We'll take 10-minute break. We'll be back at 10:40. Thank you.
ସାର୍ ଭଲ ଅଛନ୍ତି? ସାର୍ ନମସ୍କାର, ଦେବାଶିଷ।
ହଁ ଭଲ, ଆପଣ ଭଲ ଅଛନ୍ତି ସାର୍?
ଆଜ୍ଞା ଆଜ୍ଞା।
ଆଚ୍ଛା ଭଲ, ଚାଲିଛି କରୋନା ଆଉ।
ଆଜ୍ଞା ଆଜ୍ଞା। ଦେବାଶିଷ ସାର୍ ମୁଁ ଟିକେ ଇଏ କରୁଛି ଅଫ୍ କରୁଛି ମୋର କ୍ଲାସ୍ ଅଛି।
ठीक अच्छे सर, ठीक अच्छे सर, किसी असुविधा नहीं, अपना ऑफ करंतु।
Dr. Debashish? Dr. Debashish? Madam, good morning. Madam.
Good morning, sir.
Good morning, madam.
Good morning, sir. How are you, sir?
I am fine. How are you doing, madam?
Fine, sir. Fine, sir.
Dr. Debashish?
Yes, sir.
Welcome.
Thank you, sir.
Yeah, we will start in about a few minutes. But we said 10:40. What will happen is the session is being chaired by Dr. Sabina. And I will be the moderator.
Right.
The other moderator had other commitments, so I'm doubling up as the moderator. So
Sure.
what I'll do is I'll basically welcome you briefly, and then I'll hand over the session to Dr. Sabina. We'll be projecting your profile slide.
Okay.
Dr. Sabina will go through the profile.
Right.
And then I will stop sharing, and then you will be able to share your PPT.
Okay.
And then,
so I will have one video in the PPT, so that should be also, it should be shareable as well, right?
Yeah, it should be okay. I think. Because even yesterday Sachin shared some videos. Today I think one video didn't work from Texas.
Okay.
Yesterday Sachin's videos worked.
Okay. We'll see. Okay. Let's see.
So how is the situation in Bangalore now? People have forgotten about the pandemic?
Yeah, even mask has become a remote thing now. So people are all going about doing their regular stuff. I don't know how the situation is going to happen over the Christmas, as the second wave is coming and all that people are talking about. So let's hope things don't go really bad.
Yeah, yesterday the first talk was on stem cell therapy for COVID-19 patients. Were you there?
No, I was not there because I had some work in the lab, so I couldn't attend that one.
Yeah, largely to take care of the cytokine storm, the measles cells. Not as a primary treatment, but as a more palliative, I think.
Yes. And also it is more like you are not curing the disease, you are kind of, keeping it under control. You don't.
We're calling it emergency use, compassionate use authorization given by FDA.
Yes.
For those
compassionate use, true.
For those in the USA. I don't know what the situation is like in India. We have not heard about this compassionate authorization in India. No.
I don't think there is any proper clinical trial going on about stem cell usage in our country for COVID. Most of us are waiting for the vaccine to come up and be the miracle drug. So I really don't know.
The other issue is some side effects of the volunteers in SRMC as an issue.
Yes.
People will. It's human nature to be very apprehensive. If you see something in the news, would we want to get vaccinated, or this herd immunity may come on its own, and there may not be a need.
Yeah, I don't know the concept of herd immunity. I'm not such a big supporter of the herd immunity concept because they tried doing that in the Northern Europe and they had issues with that.
No, herd immunity, that's a good point. Herd immunity based on natural...
Right. Yeah.
They fall sick and then they recover. And,
true.
And the magical number they are giving is 65%. I do not know how they came up with that number. 65% are immunized, you're okay. So you don't have to worry about 100. So, yeah.
I don't understand. Professor Suresh, are you there?
Yes, I'm there.
Do you think I can just check whether my slides are coming through or not? Is it possible for me to look at it?
Please go ahead.
Shall I go for share screen or what I should do?
Yeah, share screen.
Okay.
Yeah, it's working. Full screen mode.
I'm putting a full screen. 1 second. Yeah.
Oh, fantastic.
Yes, sir.
Yeah, it's moving. It's moving. Fantastic.
Okay, great. Thank you. Thanks.
Dr. Sabina, shall we get started?
Yes, sir. Yes, sir.
Okay. Good morning. Once again, we are in the second day of the virtual international conference on stem cells. Update on stem cells, academic and industrial perspectives, future challenges. The third talk for today is going to be delivered by Dr. Debashish Das, an ocular stem cell specialist based in Bangalore, working in Narayana. And I also would like to welcome the chairperson for today's session, Dr. Sabina, a faculty VIT, School of Bioscience and Technology, Department of Biomedical Sciences. Share the screen. Share screen. Madam, is the screen visible?
Yes, sir.
Is it visible?
Yes, sir.
Visible.
You have to make it. You have to make it little big. Zoom, sir.
Bigger.
Yeah, bigger, sir.
Is it working now?
Yes, sir. Okay.
Are you able to see the full screen?
Okay, sir. Yes, sir. Yes.
Okay.
Can I start, sir?
Yes, madam, please.
Yeah. Good morning to everyone. I welcome. It's my happy that I'm welcoming Dr. Debashish Das. Good morning, sir. Welcome you, sir. I'm welcoming him for the International Virtual Conference, the second day. And just I want to give the introduction about Dr. Das. He did his MS Medical Laboratory Technology at Shankara Nethralaya in an off-campus course of Birla Institute of Technology, Pilani. He then pursued his MPhil in genetics from University of Madras, where he was the best outgoing student of the university. He then pursued his MSc in genetics from University of Madras, where he was, sorry, sir, I think the same point.
Yes, okay.
Point has been repeated, sorry. He got interested in understanding the potential of stem cells into neuronal regeneration and did his postdoctoral research in stem cells at world-renowned Karolinska Medical Nobel Institute, Stockholm, under the mentorship of Professor Urban Lendahl. He is an ex-member, secretary, as well as chairman of prestigious Nobel Committee for Nobel Prize. Das then moved to Narayana Nethralaya, where he is the chief scientist, basic science R&D, and leads a team towards the usage of stem cell in health and disease. He is then moved to Narayana Nethralaya, and he is continuing his research there. He established a translational research lab, generated skill-based, personal-initiated inter and intradisciplinary research works towards the translational science and personalized regenerative medicine. He has published in several journals of international repute and also has presented in several national and international conferences. Welcome, sir. I'm just handing over the session to Dr. Das. Over to you, Dr. Das.
Dr. Debashish.
Tell me, sir.
I missed out the doctoral in Berlin, isn't it?
Yeah, that's okay, sir. No problem. It's totally okay. It's fine, sir. No problem. Just one second. Good morning. Is it visible? The slides are visible?
Yes.
Okay. Good morning to all of you. And first of all, I would like to thank Professor Suresh and Professor Sabina and all the faculty of the organizing committee of this conference for inviting me to present my talk and to give my talk on the work that we do at our lab here. So to start with, I'll be talking about notch signaling and how it is dictating the fate of coronal stem cells in the human. And so I'll talk a little bit about how coronal stem cells are found in the eye and where they're located and how people have identified them. And then I'll go about talking about a little bit about how notch signaling is modulating stem cells to either maintain the stem cell properties or to go into differentiation. So to give a brief introduction, I think you people must have, students must have looked at these slides for the same paradigm in different ways in the last talks that people have presented here. So I'll just briefly go through that again. So basically all the whole story of stem cells starts from fertilization of the egg. So that's where the story starts with. So upon the fertilization of the egg, then you have a fertilized egg that divides continuously to form totipotent stem cells. So these are basically the cells which are totipotent. So they will form not only the 3 germ layers, but also the extra embryonic tissues like placenta and all that. So after division, the cells come into a stage where it's called the blastostage, and blastulation happens. In the blastostage formation, you have the inner cell mass, which basically harbors the cells. They have harbor the cells which have pluripotent potential. So this is the primer or the first step in which stem cells are isolated from the embryo to grow them in the culture dish in the in vitro conditions. So these are called the embryonic stem cells. So these are pluripotent natures, as you all must be knowing by now. And these cells, then you have got some of the cells which derive from there also from hematopoietic neural stem cells, mesenchymal stem cells. There are multipotent. They further differentiate into specific tissues of our body, and they are which are unipotent in nature. And the cells which are isolated from the inner cell mass, they are basically the embryonic stem cells which can be cultured in the in vitro conditions in the lab, which people have been working for quite a while, but now, as you all know about it. So how the cell division happens in stem cells? Stem cells, the cell division can happen in 3 different aspects. One is you can have a symmetric cell division, and you can have an asymmetric cell division. So when you have symmetric cell division, in those conditions, stem cells basically are maintaining their pool, and so that it does not get worn out. And then you have asymmetric cell division, where you have a differentiated cell type and a stem cell type. Then you have another asymmetrical division where you have got both differentiated cell types coming from a stem cell. So these are the 3 different ways in which the stem cells do maintain a homeostasis in our body, by maintaining their own population, by maintaining a differentiated cell population, and maintaining homeostasis. The clinical application of stem cells, by now you all know that stem cells have been applied for different kinds of diseases in different tissues of our body, starting from heart, eyes, Parkinson's brain, spinal cord, skin, renal failure, in bone diseases, bronchitis, diabetes. People have been trying to explore to use stem cell for clinical application in this kind of pathological conditions. So based on the origin of stem cells, we can classify them into 3 different groups. One is the embryonic stem cells, the next is the fetal stem cells or the infant stem cells, and the last one is the adult stem cells. So embryonic stem cells, as I mentioned earlier, so they are derived from the inner cell mass of the blastocyst. So they maintain the embryonic cell type, and they're pluripotent in nature. You have the adult stem cells, which are mostly multipotent in nature. So they are basically somatic cells which are there in all our different organs of our body, and they maintain a small pool for replenishing the wear and tear that happens in the tissue specific in the specific tissues. Then you have something called the fetal stem cells, or the infant stem cells, which are obtained from the aborted fetus, umbilical cord blood, or umbilical cord tissues. So they are also from the fetal in nature. So they are called fetal stem cells, blood stem cells, mesenchymal stromal cells, or mesenchymal stem cells, which people call. So broadly, they can be classified into 3 different categories. So the next is that now when people are talking about stem cells, so how does the translation happen for the stem cells? So the translation of stem cells is the whole concept of stem cells came into picture because people wanted to use cell therapy as a modus operandi for curing diseases which were not curable by medicines which are available in the pharmacy, for example. So in order to get into cell therapy, so they wanted to find out how these cells can be used, which are derived from embryonic or adult or the induced pluripotent stem cells, to be used in the, for welfare of the patient, for the well-being of the patient. So blastocysts, you have here the blastocysts from where the industrial mass are derived. Then you have the adult stem cell population here. Then you have a fibroblast here, which has been transformed into iPSC using the 4 transcription factors. So all these cells can be grown in the culture dish, which can, like this is like oversimplified way of showing that the stem cells obtained from all these different sources can be cultured and then differentiated into a progenitor cell type of a specific tissue in which they are needed, and then transplanted back into the patient. So now, why eye? Why eye is such an important aspect in which a lot of these studies have been done in eye. So if you look at history, the king of Babylon had said, he was the first person to give so much emphasis to the eye. And he had said that if a man destroys the eye of another man, they shall destroy his eye. So it was literally an eye for an eye. So he was the first person to put a lot of emphasis on eye. And then you have a lot of philosophers and historians who talked about eye, such as Plato said beauty lies in the eye of the beholder. Mahatma Gandhi had said an eye for an eye would end up making the whole world blind. So eye has always played an important role in across the different fields of life as well as science. As they'll go on, you'll get to know about it. So how the eye comes into picture, where the eye really develops from. So this is basically a schematic representation of a 3 germ layers, where you have the ectoderm, the mesoderm, and the endoderm. So most of the parts of the eye are derived from the ectoderm. There's the eye lens, the corneal epithelium. This is the cornea of the eye, the eyelid, retina are mostly developed from the ectoderm, whereas the blood vessels and then the blood vessel component of the eye is developed from the mesoderm. The ectoderm also develops the nervous system of the eye, which is basically having both kinds of neurons which are present. So they are developed from the ectoderm as well. So why eye is an important aspect? So if you look at the importance of eye became because it was an organ which was easily accessible from outside, and also had all the milieu or the local milieu being intact, and it could be observed and followed up very easily as compared to all other organs of the body. So also it had the immunoprivileged status, which was found out by the father, by Sir Peter Medawar, who basically through his studies found that eye has an immunoprivileged status. The the 4 most important aspects for which eye has been used for research in cell therapy as well as gene therapy is that it is easily accessible for treatment and for finding, for doing research. It has an integration of an engineering component and a medicine component. Engineering is basically a physical component, which is the physics, how the image processing happens in the eye. And a medicinal or the biological component, which is basically the the biological system of the eye as such. It is immune privileged, so it doesn't mean that it does not have an immune reaction, but it has got limited immune reaction compared to the rest of the parts of the body. And it has easy readout, and the result follow-up is much more easier because you can access eye by using any kind of imaging. And that can be accessed through the retinal, through the lens, and then you can access the, outcome of the treatment or the diagnostic tool or a prognosis. Those kind of things can be done very easily using imaging tools for the eye, where you don't have to really, do any kind of invasive procedures to find out the outcome. Whereas for all other parts of the body, you need to have an invasive procedure to be able to know the outcome of the treatment or the disease prognosis or the disease, progress to the good or the bad. So in eye, when we look at, so you have got stem cells as in other parts of the body, you have got stem cells in different parts of the eye, which has got the conjunctival stem cells, the limbal stem cells, corneal stem cells, lens, iris, retina, retinal pigment epithelial stem cells. So people have shown in different publications the different, the presence of stem cells in different parts of the eye. And based on its location, eye can be divided into an anterior chamber, which is basically the front part of the eye, and a posterior chamber, which is the back part of the eye. The back part of the eye is mostly, populated with vascular and nervous tissues, because that's where the optic nerve comes in. So it has got a component of vascular and nervous tissue. There's an integration between both of them, where the front part of the eye basically is composed of the lens, the cornea, the limbus, iris. So that's basically the passage through which the light comes into the eye. And the back side of the eye is basically where the processing happens. And then we see the vision, which is transmitted to the optic nerve to the brain. So this is to show you that, the posterior half of the eye, what are the different kind of cells which has been tried, or, different trials are happening either in animal or in human trials are happening where cells are being used for different diseases. Like, for example, age-related macular degeneration, which is basically one of the most common disorders that happens in the Western world, where we have the vision gets narrower and narrower over the time, and then it totally diminishes. So people have been trying to, restore the function of the eye in this kind of patients, because the population is highly increasing in this disease condition. So people have tried using, the iris pigment epithelial cells, the adipose-derived stem cells, and all for treating AMD disease. So age-related macular degeneration is called AMD in short. The other disease which is very prevalent in our country as well is diabetic retinopathy. So since we do not have a good control of follow-up of the sugar levels of the patients and a good follow-up in our country, so people usually diabetic patients usually end up in diabetic retinopathy. So in this kind of cases also, there's a lot of vascular damage that happens in the eye, in the posterior half of the eye. So there people have tried using different kind of stem cells to find out whether they can restore the function of the eye without causing much damage. Then you have got, there are two kinds of age-related macular degeneration. One is the dry and one is the wet. So both are very common, and the wet becomes much more harsh as compared to the dry macular degeneration. So these are different kinds of tissues which are used for wet macular degeneration. People have used umbilical stem cell, derived stem cells, iPSCs, ES cells, and all that. Now coming to the front part of the eye, but this has been a place where the success has been much more better as compared to the back side, the posterior half of the eye. The people have used limbal stem cells, conjunctival epithelial cells, and stromal cells, adipose cells for diseases which are restricted to the corneal surface. So when we have a scar or stuff like that, then we get the surface of the cornea gets damaged. So in those kind of cases, people have used cells from people have used cells from starting from dental pulp to bone marrow to ocular mucosal cells, hair follicle stem cells, and so on. And success of restoring the function of the corneal surface has been much more better as compared to the posterior half of the eye, where the integration becomes a little bit difficult because there's a synergy that's existing between the vascular system and the neural system in the backside of the eye. However, the front side is mostly epithelial cells, so it becomes a little bit easier for looking for cell therapy as a option for treating the ocular surface disorders. Okay, now coming to corneal stem cells. So they are basically located in the limbal area. So what is the limbus? Let's see if it works. Okay. So limbus is basically on the margin of the corneal surface, cornea that you see here. So they the primary function is to repopulate the corneal epithelium as it gets wear and tear, and they divide asymmetrically. And another major function of limbal layer is that they act as a barrier between the sclera and the cornea. So whatever you see the red line here, that's basically dividing and making it as a barrier for the scleral epithelial cells, that's the conjunctival epithelial cells or scleral cells, not to come over the cornea. So this is important for you to note here. Why? The reason is that when you have limbal deficiency, the sclera grows over the cornea and thereby inhibits the pass of, inhibits the smooth movement of light through the eye, and then the vision problem starts. This is basically a horizontal section of the same. So you have the lens, you have the conjunctiva here. This is basically the limbal area. So this small area that you see here, that is pigmented, just a little bit dark brown color, and that harbors the stem cells at around roughly around 200 micrometer, 150 to 200 micrometer depth. So this is where it is. So this is the limbal area that I was telling you. So whatever you see here, these are basically, this looks more or less like the intestinal villi. Whatever we have in our in the gut, basically the small intestines, they look like microvilli, and they basically they are in the bottom part of this microvilli, you have the stem cells here. This is on higher magnification. So here we have basically the stem cells residing. This is a schematic representation of the same. So you have the stem cells residing in this part, whatever I'm telling you here. These are whatever you see here structure, they are called the pilocytes of Vogt. It has been named as pilocytes of Vogt, and they harbor the stem cells in the eye. So what happens generally, the stem cells are harboring here, and as and when need, they will divide, they'll migrate upwards, and then they'll migrate towards the cornea. Cornea is on the right side, whatever you see here. This is the limbus and this is the conjunctiva. So this area, the limbal area, basically acts as a barrier as well. So that the conjunctival cells, they do not cross over the barrier and migrate over the corneal surface. The cornea and the lens, they need to be properly functional for the for the passage of the light. So this functions more or less like we have in the intestinal villi, where the cells reside in the bottom crypt, and as and when needed, they will divide, become transient amplifying cells, and then slowly migrate upwards, and then finally move towards the corneal surface, to the cornea, the peripheral cornea, and then the central cornea. Let's see if it works here. So this is just a schematic to show you what happens in a healthy condition. Wow. Okay. Anyway, so basically what happens in a healthy condition is that the cells from limbal area, they are supposed to go to the peripheral cornea, sorry for the wrong labeling, peripheral cornea, and then the central cornea. They are supposed to migrate as and when there is a need of the cell turnover happening in the peripheral and the central cornea. Whereas in the disease, what happens? Okay, whereas in the disease, what happens? The cells are getting removed from the central and the peripheral and the central cornea, but since the limbal is having a deficiency, diseased, so these cells are not able to repopulate, and the peripheral and the central cornea, they get exposed to the trauma. So this is how the disease happens in the corneal surface. So giving a brief outline about the timeline about how the cornea and the limbal and the identification of stem cells happen in the limbal region. So somewhere in 1971, they looked at cornea, and they were trying to find out, to identify this Evanson and Davneger. They were trying to find out whether what are the cells which are there which can repopulate the corneal epithelium when it is getting affected. So by doing studies in rat models and all that, they found out that the cells which help for repopulating the corneal epithelium and repairing the corneal epithelium are residing on the limbal area. So then they found out that these cells were able to differentiate into different lineages and all that. Then they also identified that they were basically called the limbal epithelial stem cells by Kostralis, because they did radio labeling, and then they found out that they were slow labeling, slow dividing cells which are present in the limbal area. So they were called the limbal epithelial stem cells. Schäfer-Steng, basically, he found out the usage of these cells by using autograft, and then he said he showed that for the first time the limbal autograft was sufficient for doing ocular surface, for restoring the function on the ocular surface by removing the diseased tissue from there. So he was the first one to show that. And then in Lancet, Pellegrini et al., they showed that they were able to culture the cells by following a protocol that was followed by Howard Green, to culture those cells ex vivo and then make it as a sheet of single cell sheet of cells on an amniotic membrane, and then transplant that into the eye, and they were able to restore function of damaged corneal surface. So if you look at the progression from 1971 to this paper that came in 1997, and now in the present situation, we have roughly crossed around 20 years. The last 20 to 30 years, what people have seen is that limbal cells have been identified, characterized, and now it has been approved by the European Union as a drug of choice for ocular surface diseases. which means that people who are getting ocular surface diseases, they can use limbal stem cell therapy, which can be taken from the, which can be obtained from the contralateral eye, which is the unaffected eye, and use it for their treatment. So why this limbal stem cell deficiency happens? So this is a normal eye. So what happens is when the patient undergoes repeated surgery or exposed to a chemical, like mostly what cases we get in our hospital, most of them are workers in factories or farmers who get exposed to chemicals in their field, or fertilizers in the field, or chemicals or thermal exposure they get in the factory settings, and then they come with a damaged eye, which basically looks like that. So as I was telling you, this barrier is lost. So what happens? The conjunctival cells, they keep growing, and as they keep growing, they cross the barrier, they cross over the, cover the cornea completely, so that the person is not able to see anymore. So though the cornea is functioning, because of the conjunctivalization, the patient is unable to see anymore. So in this cells, this kind of disease is called limbal stem cell deficiency disease, where the limbal area loses its property, thereby loses its property to block the conjunctivalization over the cornea, and the disease happens. And so in this kind of cases, what we do in our hospital is that, in a unilateral case, where we have a patient comes with one eye which is having limbal stem cell deficiency, the clinician gives us a biopsy of a limbal area, which we grow in the lab in ex vivo culture on an amniotic membrane. And then after growing for 14 days, we give it back to the clinician. The clinician puts it back on the patient and the affected eye of the patient, and the patient gets restored over the time. So eye gets functionally, gains its functionality. So this happens in unilateral cases. So what is in the bilateral case? In the bilateral case, obviously we don't have any healthy limbus left around. So the clinicians take a biopsy from the buccal mucosal cells. So we use a medium that is going to transform the buccal mucosal cells into a corneal lineage in the ex vivo condition. This also happens over the 14 days. And then the tissue, when it is ready, when the sheet of cells are ready, then we give it to the clinician, and who consults the patient for the surgery and transplant that in the patient. Now, so if you look at the scenario here, so these are basically having high success rate because this is the limbal cells, which is from the ocular origin, and also it goes back to the ocular origin. Whereas the buccal problem, the issue with the buccal cells is that their cells are very, very similar to the limbus. I'll show you some pictures. However, the cells retain a property of vascularization over the time, which means that the patients who are getting the cultures derived from the buccal mucosal cells, they have to have anti-vasculature treatment ongoing for a while. That's the first thing. The second thing is the success rate of buccal mucosal transplantation is much more lower. And the third aspect is that the gain of vision by transplantation of buccal mucosal cells is minimal, whereas the success rate of limbal is much more higher compared to the buccal. Okay, so the management of limbal stem cell deficiency follows a typical bedside to bedside to back to bedside state, where we have patients who come to clinic, then we take the limbus is collected from the healthy eye, transferred to the lab, where we put it in an amniotic membrane, chop it, put it into, chop the tissue into smaller pieces. This part happens in the lab, this part in the clinic, and then this part happens in the clinic as well. So here the patient is, the amniotic membrane is getting transplanted on the patient with the cells on top of it. And this is after a while, the patient, you can see the patient has almost the amniotic membrane is getting dissolved. The patient also restored his vision. And if you see here, if you can see some amount of conjunctivation already happening here. So this is a typical scenario where we, like we say picture perfect, where we do a research, it goes back to the clinic, and patient gets benefit out of it. So this was the aim for the cell therapy. This is what is the concept that people try to follow the cell therapy, where they find out the disease, get some kind of tissue or some kind of cells for the cell therapy, then use the same tissue or the cell type for restoration or for the recovery of the patient. This is just to show you briefly about how the amniotic membrane we prepare in our lab. So we get the placenta, we clean everything up, remove the mucosa and all that, and do prepare the amniotic membrane by, these are basically nitrocellulose papers where we we stick the membrane on top of it, and then we store it in storage medium for a year and a half. So this part is basically when we want to use the membrane. So this is how the membrane looks like. So we try to get the membrane from the nitrocellulose paper. We decellularize the membrane, and then get it ready for putting the cells on top of it. Okay, so if you look at the treatment modality of limbal stem cell deficiency, is much more simple. It's really simple, which means that you collect the tissue from the patient, grow them ex vivo for 14 days, and put it back into the patient. So that should be simple, and the success rate should be really high. However, with the present scenario, what has happened is that the tissue processing has differed from lab to lab. So some lab use explant cultures, some lab use enzymatic dilations for getting single cells. Now, different matrices people have been using. So some are using amniotic membranes, some are using contact lenses, some feeder layers, some culture dishes, and some people are also using scaffolds. And the culture components are very variable among the different groups which are using. So what happens of using all this different variability being a major part of the ex vivo culture component of the limbal LSCD management? So the outcome is very variable. If you look at the literature, so there are people reporting a 40% success rate to people reporting up to 70% success rate. And every lab uses a different technique. So that has been a big drawback in this field. And they are using different tissues. They're using different ways of processing the tissue. They're using different matrices to grow the cells on. Then they're using different culture components so that to get a better outcome in the lab setting. So this eventually results in a very variable outcome in the patient success rate. So what we thought was that this needed to be addressed. If you wanted to have a standardized protocol or SOP that can be followed across different labs, independent of the tissue that has been, independent of the source of the tissue, so that eventually we are able to get corneal progenitors, corneal progenitors in the similar range, and then we are transplanting the same cell types to the patient for the recovery. So in an effort, what we did was that we used our protocol, we modified the protocol which were there in the literature, then we used some different components, and then we grew the different, so primarily limbal stem cell deficiency, the tissues which are broadly used are limbal tissues, congenital tissues, and the oral biopsy, which I mentioned earlier. So if you look at the morphological, morphology of in the face contrast, the limbal and the buccal mucosa, they look very similar, whereas conjunctival cells, they look really small. So this is by using the protocol that we developed in our lab. This is, the day the biopsy is collected. This is amniotic membrane which is decellularized. And this is where the cells have been grown in day 7. This is after 14 days of culture. Then we also looked at the markers, which are classical markers, which are used for identifying the stem cell population and the differentiated population in the corneal epithelium. So ABCD2 is basically a drug efflux transporter protein is the most common marker which is used for identifying stem cell population in corneal limbal region. CK312 is a differentiating markers which identifies corneal differentiation. Mature corneal epithelial cells will be positive for CK312. CK4 is basically a epithelial marker. CK13 is the same way connection as gabrination protein. So overall, it shows that we were able to obtain differentiated cells as well as stem cell populations by using our protocol, independent of the source of the cell type. So furthermore, we wanted to see as to how was the percentage of the stem cell population which is present in the different tissues that we cultured. So if you see here in the in vitro condition, we are getting roughly around 8% of the cells that obtained from the limbal biopsy are having stem cell properties. Those obtained from the oral and the conjunctival are a little bit lesser, and oral is a little bit higher compared to the conjunctival cells. This is just a immunofluorescence staining to show you that we were able to stain with the differentiation markers as well as the gap junction proteins. This was the protocol which we found in our lab, and these are different protocols which are used in the literature. I mean, there are more there, so the list is really exhaustive. We have listed here 3 different protocols, and this is the protocol that we had in our lab. The strength of our protocol was that, independent of the different cell types that people have used in the literature, we were able to differentiate all of them to the corneal progenitor stage. So we were all able to get the positivity for transient amplifying cells with p63 and all that. The same protocol, we have done transplantation in our patients in the hospital, and we have done roughly around 40 odd patients, and we were able to see roughly around 90% success rate. And we had one patient, 1 or 2 patients we had which failed for oral transplantation of the oral cultured oral mucosal cells, and rest of them were success. So when I say success here, which means that the corneal surface was stable. What happens is that when you have a disease condition happening on the corneal surface, it is highly inflammatory. There's a lot of immune reaction happening on the corneal surface. So when I talk about success here, that means that transplantation has remained. There has been no, the corneal surface has been stable, and there's no much of inflammation happening on the corneal surface. Okay, so far what we have seen here is that, okay, we are able to do a transplantation, there is a success rate and all that, but still we are not able to get 100% success rate that every transplantation should work equally well, because we are doing autologous transplantation, which means that immune reaction or the immune rejection should be minimal on the patients on which the transplantation is done. So in spite of that, why we are not able to achieve 100% success? If we are taking from different, from cadaver or from allogenic and all that, I understand autologous should have been better. So we tried looking a little bit into that. So during those times, we came across a paper where basically from Pellegrini et al. So she is the same person who first showed that you could culture the corneal, limbal epithelial cells on amniotic membrane, then transplant that into ocular surface for restoring the function of ocular surface. So in that paper, she said that she was able to evaluate patients, and then she found that the number of stem cells detected before transplantation with high level of p63 transcription factor was basically related to the outcome on the outcome of the graft that has been done. So which means that the cell therapy, the outcome of the cell therapy depends on the number of stem cells or cells of expressing this p63 transcription factor transplanted on the patient. So keeping that in mind, we thought, okay, if that's the condition, then why don't we try to enhance the number of p63 positive cells in our culture conditions, and then see whether we can transplant the cells, and we can see we should be able to get a uniform outcome independent of the patient as well. So it is true that some patients may have high p63 population, some patients might have lower. But since we have a component in which you can modulate the cells in the ex vivo condition, so we thought, why don't we come to a situation where we will have the maximum number of p63 population in our in vitro condition, and transplant those sheets of cells for cell therapy on corneal surface. So we started looking at papers where we could regulate p63 population. So we came across different papers where people have looked at the notch, how it regulates p63 population in cancer cell lines and other tissues as well. So there a new thing came into our mind, that is notch signaling. So let's see what is notch signaling. Let's see if the video works here. Okay, good, thank God. Okay, so this is the inside of the cell that you can see here. So notch, it is synthesized as a single protein on the Golgi complex, From there, it undergoes a cleavage in the endoplasmic reticulum, where it will become a dimer by an enzyme called furin. So this dimer then goes to the cell surface, and it attaches to the cell membrane. On attaching to the cell membrane, so this will be the Notch receptor, and this is the intracellular domain of the Notch. This is from a neighboring cell. The ligand comes into the picture. There's a binding between the Notch ligand and the receptor. The enzyme TACE comes into play here. It cleaves the dimer. This part goes into the cell. The intracellular domain, which is there, which is still attached to it, it undergoes the third cleavage by gamma secretase. So then gets into a vesicle. Then the vesicle with the intracellular domain of the Notch enters to the nuclear pore, goes into the nucleus. Yeah, it will go into the nucleus, and then it binds to the DNA transcription domain, and thereby activating, removing the repressor and activating Hess and Hay proteins, which are the downstream target of Notch pathway. So this is basically the same thing which I told you earlier. So it is synthesized as a monomer in the endoplasmic reticulum, goes to the Golgi, undergoes the S1 cleavage by furin enzyme. Then it undergoes the S2 cleavage at the membrane after the binding of the ligand. And then the S3, this is by the TACE enzyme. And then the S3 cleavage is the gamma secretase, which happens on the intracellular domain that's attached to the membrane. The intracellular domain goes into the nucleus and activates the downstream targets, which are the basic helix proteins, Hess and Hay family proteins. So how people found out that Notch was present in the cornea, Notch had a role in the cornea. So Freddy Radke is a scientist who works at FMI at Switzerland in the Friedrich Miescher Institute, and he had a knockout of Notch1. He had Notch1 knockout mice. So when he was looking at skin and other parts of the body, he also looked at the cornea, and there he found that the Notch, the mouse who were the Notch1 knockout mice had a defective cornea. So basically, there were plaques in the cornea which were without in corneal epithelial, mature corneal epithelial cells. So this he noted, and he just kept it. But that was it was an accidental finding, because nobody had thought of looking at Notch1 knockout mice model. So this accidental finding gave rise to, today we have roughly around 43 papers where people have looked at Notch signaling in the cornea. So what it really does, so it says, there are papers saying about Notch signaling plays a role in the corneal differentiation, proliferation, maintaining the corneal progenitor cells. It also has a role in the corneal wound healing and the epithelial, corneal epithelial wound healing and all that. So what it really does. So this is one of the first papers where they showed that if you look at the cornea and the limbus, you can see here there is very low amount of Notch. Notch is the green stain that you can see, and it's a membrane protein, so you can see it on the membrane. So blue is DAPI, which is the nucleus stain, and you can see that limbus is having high amount of Notch signaling. So this finding, was triggering people to find out if Notch is. Not just people who knew that Notch has a function in stem cell and all that. They wanted to know whether Notch really maintains the stem cell population in cornea as in other tissues, or expression of Notch, does it prevent differentiation and all that. So then another group, they started looking at so gamma secretase inhibitor is basically a blocker of Notch, and Jagged1 is an activator of Notch. So what you see here is that when you have activation of Notch here, when you see activation of Notch, you see over the time the number of mature cells are reducing. It's really low. Whereas if you have blockage of Notch, it is remaining high as such. This suggests that presence of Notch is preventing differentiation of cells. So cells are not able to differentiate. So the same thing that we see here, when there is a wound, and Jagged1 basically is a Notch ligand. I'll talk about that. So what happens is that when you have a wound, you see a higher amount of notch getting expressed. You can see it here in the stromal layer. So how the notch regulation happens? So it blocks differentiation and maintains stemness, and that happens in hair, bone, blood, solid tumors, and all that. Whereas whereas in skin and the corneal epithelium, it has a reverse function. It activates differentiation, thereby maintaining cell maturity. Just 1 second. This was what they showed. Okay, so differentiation and cell maturity. So these are the different people who published papers on that. So you have this signaling pathway. Notch signaling was found by a Greek scientist called Artemides Sakonas. So he used to work as development biologist, and he used to work with Drosophila, the fly, and he found that when he tried to, flies who were having the notch mutant, they were having a notch in their wing. So from there, the name came notch receptor and notch signaling. So it has four receptors, which is a transactivating domain and all that. It has got an EGF repeat, and this has got a nuclear localizing signal, as well as other domains which are present in on the cell membrane, on the plasma membrane. Then it has got 3 ligands. So sorry, 3 ligands: delta lig 1, 4, 3, jagged 1 and 2. So we have got 5 ligands. Sorry. So these ligands are basically present in the neighboring cells, and the signaling happens by across the cells. So it is cell-cell signaling pathway. It is highly conserved across the species, and it is since it is one of those developmental regulatory signaling pathway. It is present. It is crucial at different stages of development. Excessive notch can lead to cancer, and all that malformation can happen. So coming back to the corneal differentiation stage, and where notch has a function. So this is a conjunctiva. You have the limbus here. It maintains stemness. Then you have differentiation. It's a peripheral region. So you should have active notch signaling here. And then you have the mature corneal epithelial cells, where you should have again less notch. So we are talking about cells moving from limbus to the periphery to the central cornea, and this is the corneal part. So stemness or maintaining in the limbus, it might have low. Peripheral cornea should have high. Mature cornea will have low again. So let's see how it happens. These are basically cultures from a lab where we have looked at notch 1 and jagged 1 by culturing the limbal epithelial cells, differentiating them into corneal epithelial cells, and looking at the notch expression levels. This we have looked at by doing key PCR at different days. This is till day 14, and this is the Western blot using different notch receptor and ligands to show basically that is expressed at these are expressed all throughout the differentiation, but at different levels the expression is present. This is a condition where this is a disease called keratoconus, and the disease is characterized by coning of the cornea, which means that the cells which are present on the corneal surface, the corneal epithelial cells, they get inactive, they get defective. And there's a loss of collagen, for which the cornea loses its structure and becomes conical in shape. So in these patients, what happens, since the corneal epithelium is compromised, so we wanted to see whether notch also is compromised in this kind of patients. So we collected, the central cornea and the peripheral cornea cells. So this has been collected during the surgery. And there's another surgery which is called PRK, it's keratometry, photoreactive keratometry, which basically will have the patient's corneal epithelium is removed. So we can collect the central and the peripheral cornea separately. So this is what we have done here. And if you see here, in the control conditions, peripheral cornea will have higher notch, which we expected. And the central cornea will have lower notch, as expected here as well. Whereas if the disease progresses, so this is grade C, which is the severe disease. So you have very low amount of notch in peripheral cornea and high amount of notch in the cell cornea, which means the cells are still remaining as immature. They are not maturing as corneal epithelial cells, for which most likely the disease is getting aggravated. So that's what's happening at the higher grade. So notch is not present in the mature cells. They are present mostly in the transient amplifying cells. So when it is very low in number, so you will have lesser mature cells, and that's what has happened here. So yeah. So we thought, okay, let's try to modulate notch and see what's happening, because we wanted to have. So our readout was looking at corneal progenitor population by P63, by the levels of P63, and identifying the epithelial mature population by identifying the cytokeratin 3 and 12. So we will be activating notch and blocking notch and seeing how the limbal cells are, differentiating over the time. So we did a, strategy. So what we did was that we took limbal cells on day 0. Then we started, blocking them or activating them at different days. So we did a pulse activation. So this is like a temporal regulation where we'll give notch activation for a short time and then remove it. Then we'll follow it up for the remaining amount of days till day 14 and do the staining and analysis on day 14. So if you see here, the cells have been activated at different days, and then the cells were collected on day 14. So whatever you see here is a collection on day 14, and this is untreated cells here. So if you the green color is basically the stain for the CK3 and 12. So what you can see here is the sun and P63, the red color staining is the P63, which is very low here. So when we have activation of notch on different days, if we look at day 10 and day 12, we see a lot of green staining, which basically says that activating notch in these particular days yields a lot of mature corneal epithelial cells in day 14. Which is not an ideal situation for us, because when we transplant, we want more amount of progenitor population. That's what Pellegrini papers had mentioned. So when we activate in day 10 and 12, we see more of mature corneal epithelial cells, which is more green, but very low or negligible P63 population. So that was when we are activating notch. Oops. So now we blocked notch. In the similar days, we blocked the notch. And if you see here, in the same day 10 and 12, you see huge amount of progenitor population, which is not present in the mature corneal epithelial cells. And this is just for a reference, this is the control conditions. So what we see here is that when we activate notch, we see more mature cells. When we block notch, we see more of transient amplifying cells. This was a finding, and then we also found out in this paper, in this study, was that this day 10 to day 12 could be critical for the transition of the cells from progenitor to mature. So when we are switching and we are modulating the notch here, so the outcome in day 14 is getting affected. So what was our next plan for extrapolating our leading our findings for a clinical setting? So the present strategy that works now is that we take, you are using limbal cells from a patient who is having a defective eye. It is working here. In a healthy population, which is where the patient is having more of P63 cells, you get better outcome. Patients who are having bad P63 cells, they're not having any better outcome. So what our plan was that for this group of, so this patient is perfectly doing fine, whereas this patient group is not doing fine. So what we can do is that we can block notch and modulate notch for these patients, so that they also will yield a proper outcome. So this is the future treatment strategy that we are having. So keeping this in mind, we thought of finding out ways how we can modulate notch, because previously whatever I showed you, the modulation of notch was done through recombinant ligands and all that. So that cannot be used for patient treatment. So we have to find out a way that is patient suitable and will not have any more side effects. So in this aspect, we use a compound called resveratrol, which is found in in grapes and all that. So on using this compound on the cells, we found that these cells were expressing, cells exposed to resveratrol were having higher amount of notch. This is cells which were exposed to NaCl as a control. So in the presence of resveratrol, the NaCl could not minimize the notch expression levels, and then we can see that cells have having expression of high amount of knowledge. So in the next steps, what we are planning is that we will take the biopsies, we'll culture them ex vivo, maintaining all the sterility and all that, and try to modulate the P63 population, and then try to give that particular modulated cells for transplantation in patients. Before that, we'll try to do a clinic. We'll also do animal experiment before that, before going directly to the patient, because though it is well known that these cells have been obtained from the patient for autologous transplantation, since we're modulating a little bit in our lab, it would be ideal to use it on animals and then as a further step to get to the patients. This schematic, I like the schematic just to put emphasis that a researcher alone cannot really do much if it doesn't have the support of the clinical wing and the pharma wing. Clinical wing, because they are the people who see the patients and they are the people who see the daily life problems every day. We stay in the lab, and for us, our biggest problems are mice and our Western blot are our key PCR, and that's where we stick in. And the pharma company, they stay in their own world where they want to make a drug and then give it to the patients for their recovery. But unless we have a synergy between these three groups, which is very important, till that time we will not be able to find a proper treatment or cure for the patient well-being. So this was the condition a few years back when Bush was the president of US. So they were having issues with moral, religious, and ideological regions. But this has changed over the time, and now people are willing to take the risk and take into, from those times to now, people have been understanding cell therapy is a new way of treatment, and they're understanding, at least they're getting exposed to a term called stem cells, which is there in the literature. I would like to thank our chairman, vice chairman, our director of research, and other people of Narayan Nethralaya, including clinician staffs and patients. I'd like to thank our funding agencies for funding the different work that I showed here. And thank you very much.
Thank you, Dr. Debashish. It's a very good talk. I now hand over the session to Dr. Sabina. Dr. Sabina? Okay, Dr. Sabina, can you unmute yourself?
Yes, sir. Yes, sir.
Okay. Madam, you can actually go ahead and thank Dr. Debashish, and then we can raise the questions. If you have any questions, you can ask as well, madam.
Yes, sir. Dr. Dasa, your talk is very nice, very diagrammatic, and easily understandable by, I think, all the students and all the participants.
Your voice is cracking, ma'am.
Enjoyed your session, sir. Thank you so much, sir. Thank you so much for your wonderful talk.
Okay.
Das, sir, can you hear me, sir?
Yes. Thank you, madam. Thank you.
Yeah, thank you so much, sir. Really wonderful talk, sir. I think all the participants have enjoyed your talk, and it is you have explained it with the diagrammatical representation, sir. Very nice talk, sir.
Thank you.
Debashish, I have one question on buccal cells. How good are they in terms of them being reprogrammed?
So when we look at, so what we have done is that we have compared limbal cells, conjunctival cells, and buccal cells on the same platform. And we find that compared to conjunctival cells, buccal cells are better when we talk about corneal differentiation.
Okay.
Yes. So that being said, but one is to keep in mind that cornea is avascular, and buccal cells have vascular, footprint in them. So the transplantation purpose for corneal surface with buccal cells is problematic. But though we have a good percentage of corneal epithelial progenitors, it is not the, the tissue of choice.
So, in sense of translatable work, are there any patients wherein the buccal cells have been reprogrammed and they've been transplanted?
Yes.
And it's been successful?
So I'll tell you two cases that that I have seen with, I have interacted with the patient. So in those two cases, so both of them are kids. So one was, I think, 8-year-old and another one was 11-year-old kid. So they were helping their father in the farmland, and they got exposed to some horse fertilizer. So they lost both their eyes, and there was limbus, they had full deficiency was there in their eyes. And for those two patients, we used buccal cells. So one of them was able to perceive hand movement after the surgery. I mean, who is completely blind, but it's a little bit better, but I won't see it as really a success.
Okay. And in terms of the cost, how much would it cost for a transplant?
So I really can't comment more on it, but I would say it's I think 30 to 50,000 around.
Okay. And 1 week to 2 weeks hospitalization?
I think a week.
A week. All right, sir.
Okay. Then the patients are called in for follow-up.
All right, sir. And one comment about your video, is that a proprietary video? I saw Narayana in the background.
Yes.
You have made the video.
Yeah.
Oh, that's very good. As a teacher, I appreciate that. We know that pathway well, but when you look at it in the form of animation, that's very good. Thank you.
Thank you, sir.
Now I will go to the Q&A. First question from a registrant by the name of Devanjan Saha. Can human artificial cornea be developed using mesenchymal stem cells other than penetrating keratoplasty?
Okay, so yes, human artificial cornea. There is nothing called human artificial cornea. Artificial cornea has been generated. There's a group that's working in Canada, Montreal, and they have made artificial cornea using collagen. Of different collagen matrices, they've made it, and that also has been undergone clinical trials in India and somewhere in the Eastern European countries, where the success rate has been high. And this cornea, the reason for developing artificial cornea is that we don't have so much of we have a scarcity of corneas in our country, because all the people, we do not collect the cornea on the cadavers post after the death of the person. Organ donation being a little bit stigmatic still, we have scarcity of corneas, and that is one of the reasons for which artificial cornea has been developed. Yes, there is artificial cornea, and there are clinical trials are going on in different countries, and there are other groups also who are trying to develop artificial cornea in our country as well.
Thank you. The next question by Dr. Kavita Thirumurugan. What is the concentration of resveratrol used to enhance NOTCH signaling? Interested to know, is the concentration hormetic?
I can send you the paper. I don't remember in the back of my mind the concentration and all. If you look one of our papers, I can send it to Professor Suresh. I can send the paper and then say you have to forward. I can't remember the concentration and all.
Okay, no problem, sir. No problem.
I'll send it across. I can't. I'm sorry. I just can't recollect.
No problem. The next question from the same person. Wet macular degeneration, how common is it?
How common is it?
Yes, how common is it?
So when we say about macular degeneration per se is much more common in the Western world than in India or in the South Asian countries. So wet macular degeneration is more commoner than the dry macular degeneration as we see in our hospital. So this basically, when we talk about percentage of positivity and all that, it is better to look at your setting and how the positivity rate flows in your setting compared to the general country, because the load of eye diseases depends a lot on the lifestyle of the people, how they live.
Okay, all right. Thank you. I think there are no other questions. I'd like to thank Dr. Debashish Das for a wonderful talk. Hopefully you will come back in person to deliver more lectures when the pandemic situation resolves.
All right.
I would also like to thank our chairperson, Dr. Sabina, for having taken time out. There are a lot of other academic activities going on in parallel today.
Yes,
And
sir.
I'm thankful to her for having spent some time with us. And I know there is a collaboration going on between Dr. Debashish Das and Dr. Sabina through a doctoral project, I am assuming.
Yes, sir. We have completed one PhD work, sir. Sir as the guide and myself as co-guide, sir.
Yes, very good.
Thank
Very
you,
good.
madam.
Now, thank you, Dr. Debashish.
Thank you, sir. Thank you very much. Thank you,
Thank
madam.
you,
Thank you very
thank
much.
you, sir. Thank you so much, sir.
Thank you, madam. Thank you, sir.
Yeah. And now some general comments again to repeat to the registrants. Certificates will be given to those registrants who attend 5 sessions, including the inaugural. And also they need to fill out the feedback form. The link will be sent to you today via the chat box. Now the time is 11:47. I think we will take a 5-minute break and come back. A 5-minute break. Thank you. Dr. Ramesh? Could you unmute yourself, Dr. Ramesh?
Yes, sir. Good morning.
Good morning, Dr. Ramesh. Let me briefly brief you about today's session. First, I'll make a few opening remarks, and then I'll hand over the session to you.
Okay.
The session to the organizing secretary, session in charge, Dr. Tamilselvi Madam. And she will be projecting the slide with respect to the profile of Dr. Sanjay Kumar. And after you go through the profile, and then she will stop sharing, and then Dr. Sanjay Kumar will start sharing his screen. And after that, he'll be making a presentation about an hour, including Q&A. And then after that, I will be the moderator and will be handling the Q&A. Dr. Ramesh, is that okay? Yeah. You're not audible. You're not audible, Dr. Ramesh.
Now?
Yeah, now you're audible. Now you're audible.
Good. Thank you.
Is Dr. Sanjay Kumar there? 1 second. Sanjay.
Yeah, I'm here, Dr. Suresh.
Very good. Can we get started, sir?
Yeah, sure. I'm ready.
All right. It's 5 minutes before noon. I'll say good morning, everyone. Welcome to the next session. Very, very happy to have Dr. Sanjay Kumar. Dr. Sanjay Kumar is no stranger to us. He has visited the IIT several times. He's on several committees, and we have heard him before, and he's come back again, and he's kind enough to take time out from his research work to be part of this conference and present his findings. I warmly welcome the chairperson for today's session, Dr. Ramesh N. And also the session in charge will be Dr. Tamilselvi, and I will be the moderator. Specifically, I'll be handling the Q&A part. Now over to Dr. Tamilselvi, madam.
Yeah, thank you, sir. Good morning, everyone. Hope you all enjoyed and found the session informative and valuable to all. So this is the last session in the two-day international conference. And the first speaker of this conference is Dr. Sanjay Kumar, a senior scientist from Center for Stem Cell Research. And as I mentioned, Professor Ramesh will be the chairperson, and Professor Suresh will be the moderator. So may I request Professor Ramesh to give an introduction about Dr. Sanjay Kumar?
You need to project the slide, madam.
Sure, sir, I'll do it. Can I see the slide, sir?
Yeah.
Okay.
Shall I proceed?
Yes, sir, please.
Yeah. Very good morning to everyone. I welcome the participant and then the all the team and today's speaker. So very good morning once again. So I welcome Dr. Sanjay Kumar to our virtual international webinar. Dr. Sanjay Kumar is a senior scientist at the Center for Stem Cell Research at Christian Medical College, Vellore. He did his PhD in molecular biology, biochemistry from Delhi University. He worked as a research associate in Gene Therapy Center, Department of Pathology, University of Alabama at Birmingham, UK. His areas of research lies in iPSC, IMSC, and bone repair and regeneration. He has published several research articles, book chapters, and review articles in peer-reviewed journals. He has been awarded several grants. Dr. Sanjay Kumar also won the International Society of Stem Cell Research Merit Award 2019, Ramani Swamy Fellowship 2010, Department of Biotechnology, Government of India. So gold medal, and he has the Professor Rangaswamy Best PhD Thesis Award from the University of Delhi. So he's a member of American Society of Gene and Cell Therapy and International Society for Stem Cell Research. So with this, I welcome Dr. Sanjay Kumar, sir, for this session. So over to you, sir.
So
can you see my slides?
Yes, sir.
Okay, so now it's in the projection mode?
Yeah.
Yeah.
Yes, sir. You can.
You need to go to the first slide, though.
Can you maximize, sir?
Yeah, that's what I'm trying, but something has come up.
Yeah.
Now it's there?
Yeah.
Yes, sir.
Yes.
Perfect. Yeah.
So actually, let me tell you, this is the first slide that most of my slides are I'm modulating for the students because they must understand the rigor that it takes to make the research happen, and that research ultimately will lead to a product that will have a particular value in biotherapeutics. Okay, so this is the image that actually I'm going to show you. Immediately when I started my lab, we did this SCM with the IIT Chennai, and we realized that the cells which are actually growing in 3-dimensional is completely different than the routine that we have been doing in the laboratory. Okay, so I'm going to talk all these things in detail in my coming slides. This is just to give you a gist. The take-home message is that we must do everything to preserve the intrinsic property of the stem cells. Then the stem cells will do for us whatever we want them to do. Okay, so this is the take-home message that I want to actually make. So just to introduce the field and then make all the background in clear, there are more than almost close to 1,000 clinical trials that have been already been done and which have clearly established the safety of this human mesenchymal stromal cells. Okay, and actually this MSCs are very popular because this has actually not caused any problem and they have been very safe. But the issue on the other side is that for each trial, we need to have at least tens to hundreds of millions of cells per patient. Okay, and this kind of required cell and this kind of requirement actually is very difficult to meet because there are not much pharmaceutical grade human MSC that is available in a large volume to say this. So actually, that's what we are trying to resolve some of the issues. And then goal of my lab is to establish each and every variable where each of the laboratory protocol is reproducible or many things. And then we will have a set protocol where everything is established except the one variable that is the tissue of origin. So that's the long-term goal. Okay, so towards that only I'm going to show some of the slides how we are trying to resolve one issue at a time and then taking this for the basic component where actually we can produce a human MSC which will be of pharmaceutical grade in a large quantity. Okay. So this is the key timeline actually when actually Fred Stein in 1968 isolated a fibroblast like structure from the human bone marrow sample, and this he labeled as a colony forming unit fibroblast. So this is the what actually the genesis of stromal cell, and these are the key timelines just to show. I don't want to go in much details because we have to cover a lot of things in 1 hour time. So what we do in the lab is we culture some of these in vitro. There are different protocols that is available. Some in lab we will use small culture like some flask, and then we have also some cell layer stacks. And then we now, since we need large amount, we are actually also growing some in bioreactors. And actually, I have little background, so please someone mute that.
Dr. Sanjay Kumar, can you unmute yourself?
Sanjay sir, can you unmute? Sanjay sir?
Yeah. Now it's working?
Yeah, fine, sir. Excellent, please.
Okay. So these are some of the culture conditions actually where actually we culture these cells in a different laboratory conditions. And now since the requirement are large, we may have to go ultimately to the bioreactor actually where we can produce these cells in a large amount. So just for the students, I would like to actually tell what are the facts and limitations that actually we have been routinely doing. Okay? So clearly I told you that clinical trials have established the safety. But generally what we do is the culture these cells in a 2-dimension, and then actually we use some particular serum concentration media. But by doing that, actually we're overfeeding the cells, if you see in that perspective, because we never know what is the requirement of the one cell for their metabolic activity. We just take 5, 10, 15, 20% sera and just put them in the culture. Okay. So clearly by just doing it, we are overfeeding the cells. Okay. Number 2, since different batches of serum will have different cytokines and growth factors, we don't know actually what we are actually putting in the culture. We just take one batch of serum and then put them in a culture media. By putting that, clearly we are overstimulating the cells. So this is again a limitation what actually we have been routinely doing. Again, the third one is the culture condition, which is mostly in a 2-dimensional, which is poly-lysine coated culture dishes. So this is actually not the microenvironment from where actually the cells have been harvested. Most of the cells that you harvest are from the 3-dimensional tissue, and we are putting them in a 2-dimensional. And after a while, the cells actually do adapt, but that is not actually the appropriate condition. And if you see in the point that I'm trying to reach, we are trying to culture them in ambient oxygen, which is 21%. Okay, and none of the cells, except in the inner lining of the lung, actually see this kind of partial pressure of the oxygen, which is about 140 millibar of mercury. Even if you take highly oxygenated blood from the artery, that also have the oxygen partial pressure in the range of 27 to 49 millibar of mercury. So if you convert them in a percentage term, it's only 4 to 6% oxygen. So clearly that means whatever we have been routinely doing in the in vitro culture is not optimal. And if we don't allow these cells the intrinsic features to retain, then actually it's not fair on us to ask the cells to do a kind of therapeutic job that actually we intend to make in 3-dimensional tissue. So clearly that means there is a big scope for improvement. But again, in MSc field, the problem here is how do we actually characterize? So ISCT, which is the International Society for Cell Therapy, has come up with a 3 basic features that must be there in cells to call them a bona fide MHC. One, it must be able to adhere to the plastic. It should have a range of phenotypic markers, some positive, some negative. The positive should be 73, 90, and 106, and negative for CD14B, monocyte marker, CD34, 45, and HLA-DR. And it should be able to at least make 3 different differentiation: adipocyte, osteocyte, and chondrocyte. So this is the basic that ISCT has established. So now what we did is when I started my lab, we tried first from the human bone marrow, and after 3-4 passages, it became senescent. So clearly we knew that this is not the cells actually we would like to establish in the lab. So I wrote an IRB to this to get in some placenta, because after the baby's birth, generally this placental tissue is discarded. So we wrote a consent form, and we consented the people to get some bit of placenta tissue and try to culture and see if we can establish a long-term culture. With the hope that there is no ethical issue, and then if we anonymize the donor, actually we should be able to use them for the research. And clearly people agreed, and we got around 10 to 20 grams of tissue and did differential digestion, and actually we were able to culture this MSC. So here I'm going to show that we have isolated the MSC from the human placenta, and when actually we culture these mesenchymal stromal cells, what we call them, they are immune privileged. Now the immune privilege need to be described in detail, at least for the students. So what do I mean by when I say that MSC is an immune privilege? That means they have very minimal expression of MHC class 1. They lack the expression of MHC class 2. And also they are naive for stimulatory factor CD80 and CD86, as you can see in this graph. Okay. So then we asked the first question: can perinatal tissue-derived MSC can maintain intrinsic MSC characteristic during long-term culture? So now to answer this question, we had to devise a set of assay in our laboratory, and then follow this through this work flow and make sure that they are able to actually sustain the culture derived condition that we are imposing on the cells. So we try to actually culture these cells from passage 0 to passage 35 and do various phenotypic characterization by flow cytometry. Also put them under the in vitro differentiation, do a lot of molecular characteristics, gene expression, karyotyping, growth kinetic studies, cell cycle status, apoptotic pattern, And in the soft RSAs, that they don't make any aberrant colonies in a long run, and then calculate the duplication time. So all these assays we established in the lab and took every alternate passage during the culture condition and try to characterize. Here I'm going to show only two, just as a proof of concept that we have done several passages. We took cells from passage 1 and passage 5, and this is the phenotypic data. There is not much of a variation. We did cell cycle, also did not change. Karyotype, they were normal. And then we did gene expression. Gene expression also were kind of comparable and not much varied. And then we put under the in vitro differentiation. They were able to not only make mesenchymal lineage from where actually we isolated from the human placenta, they were able to even make some retinal cells and pancreatic beta cells, which is ectodermal and endodermal tissue. So there is a bit of plasticity already there in the MSCs. So it not only makes mesenchymal, it makes ectodermal as well the endodermal tissue. So if you provide the appropriate condition, they are able to actually differentiate. So since we got the placenta, we thought we should not also discard the umbilical cord also. So we also processed the umbilical cord simultaneously. And actually, since all the assays we already established, we put through the same rigor and characterize the human water jelly MSCs also. As you can see, the phenotypic markers were retained during passaging. They were able to make multilinear differentiation. Again, mesodermal and ectodermal and endodermal lineage as well. They were able to retain the cell cycle. Apoptotic pattern dramatically did not change. Karyotype was normal. They did not make aberrant colony in the soft agar assays. They were able to maintain pluripotent gene expression. And then since we had a different MSCs already, what we tried to do is, in presence of inflammatory cytokines, we saw that which is the MSCs which actually secrete the highest amount of immunomodulators. So in our assay, we found out that mostly water jelly MSC, which is in blue here, are the one actually we are producing highest amount of immunomodulators. So we thought maybe let's move on and actually establish some models and actually show some therapeutics. So immediately this water jelly took a little bit longer to culture, so but the placenta were already ready. So we created a model on spinal cord injury, because our center is here at Rehab campus, and we see a lot of patients here on spinal cord injury going through a lot of things. So that was a very good starting point. So we contacted with the CMC clinical team and tried to establish a model and then test this hypothesis that you can with cell therapy in a spinal cord injury situation. A spinal cord injury is a kind of complex, and mimicking them in a mouse was completely not possible, but we thought that at least we need to start somewhere, because it's going to take some time to get approval in non-human primates and do this research, which will have opposable thumb and everything. But since we had to start somewhere, we thought maybe let's create these human cells in a mice model and see if we can achieve the therapy. So just to put a background on spinal cord injury, the spinal cord injury primary insult is not that of a big problem, but the events that follow the primary injury, which is the secondary cascade of events, where actually a lot of inflammation happens. And then if the fibrosis sinks in, then there is no forward inroad, because if fibrotic tissue if it generates, then there is no connection restoration, and that actually will lead to the big problem where actually the sites below the injury site is completely paralyzed, and even the bladder and bowel function is not there. And most of these are generally young population, because most of them they get in either road accident or do some adventurous stuff, because of which actually they get into trouble. And then the prime of their life is actually goes down, and that is actually not acceptable. So we thought maybe if we can assist and improve their quality of life even by 50%, that will be a great deal. Okay, so that was our intent. So just to this was the background that I told. Then actually we roamed around the literature. The clinical trial using the stem cell for a spinal cord injury have met with a limited success, because the early and timely intervention is extremely critical. Because most of these intervention actually we do it later, by the time it's already the niche is completely remodeled, and then that is actually it will take a while to actually bring them to the conditions where the regenerative therapy can actually do it. So then to answer this, we asked the question, can human stem cell therapy augment the spinal cord injury in a mice model that we are trying to do? So we created a model where actually we mimic the high velocity impact where actually the vehicle has an accident and actually the spinal cord get a big momentum jerk. So with the help of bioengineering guys, we make a model where actually we drop a weight of about 20 gram with a height of about 10 centimeter on an open spinal cord injury, create a injury site. And this is reproducible because we can identify the locus and actually we can create this injury again and again. As you can see from the CT, we can actually do this repeatedly. And this is quite consistent. So there is not much mice to mice variability. So we are able to do this routinely and we are able to create in a multiple different mice in a group. So as you can see, we make a set of assay and we give it to our veterinarian, which is blinded. He doesn't know which group is what. And he will do the assessment on that. And there is a 21-point scoring on which actually he will do the points. And then actually, as you can see, the stem cell therapy has actually worked. And this has worked because it was able to actually allow the control of secondary cascade events that I talked about. Okay, so clearly, but one limitation of my study was here that we intervene immediately following the spinal cord injury, and in the real time that doesn't happen. So in spite of all the limitation, what I'm trying to drive the point here is, if you intervene early and then use the stem cell therapy, and if that actually immunomodulation has the ability to control the niche area where secondary cascade of events do not actually start, and that will actually invoke the regenerative milieu where actually much of the therapy actually will happen. So anytime we do a stem cell therapy, it's difficult to see how much actually therapy has happened because of the stem cell transplantation, because once you put them in any model system, how do you segregate, okay, how much is because of their natural niche or how much is because of the cell that you have transplanted? And then what is the fate of the stem cell? So it was, since we were handling the model system, we labeled the stem cells with ICG, which actually we developed in our lab to track the fate of the stem cell, what actually happens in the long run. As you can see, actually we can see the amount of photons that are coming out from each of the cells, and actually we can quantitate. These are the day 1, 2, 3, 4, 5, 6, 7, 8, like that actually, and we can quantitate them. So it was easy for us to actually track and see the fate of the cells. And then cell therapy actually was able to actually restore many of these things, and we were able to actually detect the cells in the transplanted mice, and that actually led to some of the therapy. Here I'm going to play one video for you guys. This is the control mice. Actually, these are very challenging experiment because every 4 hours, one of my students has to go to the animal house and empty their bladder manually. And if he forgets, then mice dies because the bladder will burst and then mice will die. So this is the control mice. Actually, nothing happened, and I'm going to show you where the we use a cell transplanted mouse. Actually, where even though it has a partial, it is actually is able to use his left leg and it is able to climb around. And actually, we will put this mouse back again, and it was able to roam around in the cages and hanging around. And since the seat was blue, we left this mouse for about half an hour. And we could see some yellow spot on this blue sheet. So clearly that means it was able to even do the urination and other thing by itself. So that is the last thing that actually comes down during the spinal cord healing. So clearly it was very encouraging for us to actually show that this is good. But again, whenever you do this, you need to follow this by different assays. And here we developed an assay to do the motor evoke potential by actually electrically stimulating in the brain and using the forelimb as a control, and then hind limb as actually the area where actually any therapy, if it has happened, it should be able to detect some current, because that injury we created between the forelimb and hind limb. So again, with the help of bioengineering guys, we devised an instrument actually where actually we give a pulse of about 15 milliamps for pulse width of about 200 microsecond, and see the, now we know how much current we gave at the head area and how much current has passed from the forelimb and how much current has actually passed in the hind limb. So we can calculate the amount of current as well as the time it took from the forelimb to come here. Okay, so those amplitude as well as the this thing latency, both we can calculate from this computer aided software. As you can see, we could calculate this, and then there was a very nice peak in the normal control, and then both the cell therapy group has shown the positive effect. As you can see, we can even calculate the latency as well as the amplitude. Both were very high in the human placenta derived MHCs. Okay, so clearly means all the assays that I have shown you, there is a big potential for stem cell therapy in a spinal cord injury if done in the right time. Okay. So then actually we had some tissue sample actually which we could do the histology. As you can see, this is we use the astrogliosis to using GFAP antibody, and then astrogliosis has clearly reduced with time in these mice after the cell transplantation in comparison to the controls. And one more thing that we observed is that many a time the neurons which were not damaged, and if you protect them, which actually from the by modeling the stem cell niche in that injury area, and that actually is also therapeutic because they may be able to actually make their natural connection if you don't allow them to spar, and that actually gave the therapy in our mice. There were different scoring system that we made for the bladder score, demyelination and inflammation, and also the body weight. In every assay, the cell therapy has clearly shown the good result for us. So this was the cell therapy part. And by this time only, we got across one paper actually where actually they have done a spinal cord injury in a knockout mouse where they have knocked out the PTN gene. Okay. So this was a transgenic mouse, and if they create an spinal cord injury in this mouse, it's spontaneously healed. So again, when we read this paper, this was very good to us, and then we thought maybe, is there any way, because many a time whenever we think about the clinical translation, it's good to have minimal manipulation that actually we do it. So we thought maybe let's try some on this agenda also, because we, our center also is very good in making these viral vectors and this. So we actually, I put one group here for putting the PTEN modulation, and we thought maybe let's devise some strategy to see if we can regulate the PTN also and this. So then question that we asked regarding this project is the PTN modulation by AAV-based shRNA vectors actually in the injured axon will actually make the axonal conduction and regrow the microenvironment in this. But again, there was a concern because PTN generally is deleted in many of the cancers. So we thought maybe if we don't take care of the safety component of this regulation very well, then we will find it. By this time, few other papers came where actually first we thought that it is only tumor suppressor and we should not be fooling around with this tumor suppressor. But there was some opposite function also in the literature. So we thought maybe if we make safe intervention and then we do it transiently, only for maybe about a week to 2 weeks, and that actually will create a microenvironment where the cells from the natural niche will take over, and these cells even after a week or 2 weeks they don't survive. It doesn't matter because by the time the stem cells will be already activated and they will do the job. So that was our idea, and these are some of the things that is currently in clinics, how they actually do for spinal cord injury. So I will not go into detail. So what we try to do is we try to knock down this to show in a proof of concept study. So we designed the shRNA with the help of Saji, and then we created different algorithm to make sure that these algorithm are able to give us good backbone actually where we can achieve the PTN modulation. And then so we tried several vectors and we validated them by cloning them in a different backbones, and then making sure that the clone is all right by matching them. And then once we have the clones ready, we did in vitro transfection to make sure that they are actually able to reduce the PTN expression, and clearly they were able to reduce. So one backbone that worked for us were the NIR, and that actually we tested them, and So then, since I told you we needed to put in a safety background here, so again we thought maybe let's make it inducible actually, where actually we will express this only to a point where actually we need them, and after that we'll switch it off, because just to put a safety block there. So we use a strategy to use a doxycycline inducible construct, where actually we will put the doxycycline in the culture to induce this shRNA for a period of time, and then we'll withdraw the doxycycline to stop this expression. And clearly, actually, we were able to achieve this in a cell line in vitro. So once we had, just to establish the proof of concept study, we made some lentiviruses to choose a stable line in the human MSC. And here I'm going to show you is the, after the shRNA, there is a reporter, which is GFP. So if the GFP is expressed, that means the shRNA is also expressed, because both are in a single promoter driving the expression. And then they are actually, if the GFP is coming out, that means the shRNA is getting expressed. So we tried in a two base backbone, one is MIR30 and MIR-E, and actually knocked down, and HCC showed that after week one induction, we are able to knock down, and we withdraw the doxycycline, it again goes up. So we were clearly able to actually see the biological effect of doxycycline induction and withdrawal both. So now, since we made a stable line, we have to absolutely make sure that these stable lines do not actually change the intrinsic feature of the MSCs. As you can see, the phenotype is normal. The differentiation, they are able to differentiate. So then actually now the challenge was, how do we actually create a in vivo condition actually where actually we are able to modulate this directly inside the mouse. This was a little challenging task, but one company came forward. It is Nepagene from the Japan, and we asked them to help us in designing the experiment. So they actually were gracious enough to bring the system to our lab, and actually we tried directly electroporating these construct following the spinal cord injury in the niche area, and electroporating them directly into the spinal cord injury into the live mouse. Okay. So we tried two different settings, which were not deleterious enough to actually do a lot of damage in the mouse, but sufficient enough to take the nucleic acid and actually transfer it into the surrounding stem cell niche area. And that actually we thought maybe allow these mice to see if the modulating this for a transient period of time by putting the doxycycline in the mouse drinking water, and allow for about a week or 10 days to express and this promoter and down the P10. And then once the P10 actually gets down, what happens actually? That was the idea behind this. So since I told you there is a GFP, we can actually monitor that the transfection has actually worked in this mouse. And we did the electroporation into the mouse, and then we followed this mouse by again the motor evoked potential by stimulating into the cranial area and seeing how much actually current actually passes through the spinal cord injury site. And we were able to see some spike, and we tried to quantitate them. As you can see in this mouse, we in the forelimb and the hind limb, we actually got some amplitude and latency. So we had some data following up in the mouse. Clearly, there was some level of therapy into the doxycycline positive mouse compared to the doxycycline negative mouse. Now the issue was, how do we actually prove from different systems? Because again, anytime you isolate this 3D dimensional tissue, we have to actually make sure that in 3D, how do you represent your data? So we tried a strategy to take different sections in sagittal as well as the cross and transverse sections, and make sure that all these actually contains the complete niche area, so that convincing the reviewer to publish this, or any other people who is trying to evaluate the data, will be good for us. So we defined a strategy, and we followed this to show the different path. As you can see, we first tried to show that the stem cells were actually did get transferred with the construct that we did by getting the GFP expression. As you can see, we were successfully able to electroporate into the area, and we could see the GFP expression. As you can see, it was successful. And then actually by modulating this, we were clearly able to control the secondary influx of event that happens. As you can see, it has dramatically reduced the stereogliosis compared to the control, where actually we have high amount of astroglia. Here the astroglial is minimally present there. Okay. So then also the tissues sparring and the lesions and the cavity that is got formed after the spinal cord injury is also was minimal in the control this mouse. Also, we try to see that what is the level of fibrosis, because I told you fibrosis is okay to initiate the regenerative process, but it should not take over the entire niche area where actually completely blocking the connection between the different neurons. That is very, very important for activity following physiological activity following the healing process. As you can see, the less amount of fibrotic tissue can be detected in the doxycycline positive mouse. Okay, so this was very, very interesting and encouraging. So we did again different staining to make sure that the neuronal beta 3 is also expressed in the niche area actually where it did. And this is again to show that astroglia were minimal, and then the fibrillar acidic proteins also got reduced because the therapy actually has happened because of the electroporation and then niche engineering that we try to do by modulating the P10 into the injured spinal cord area. Again, it's very important for us to actually show that the neurons which did get demyelinated also start the myelinating itself, because that is very important step to regenerate the electrical connection, and the electrical connection only will actually restore the physiological function in this mouse. As you can see, again, doxycycline has actually increased, and all these were actually we have shown to clinical pathologists. So I talked to one pathologist in the hospital, and actually he only scored all these histological slides, so that he actually is completely unbiased opinion is obtained from a person which is not actually involved. Okay, this was very, very important for us to actually have the unbiased opinion from this. Again, we try to see the myelination by Luxol blue and crescile violet staining. As you can see, the doxycycline positive mouse actually clearly showed high amount of Luxol fast blue positive crescile violet stained area. And again, because anytime you do one assay is not sufficient, so you try to corroborate with multiple different assays to make sure that whatever statement you are making is corroborated not only by one assay, but done by multiple different assays, which are which each one of them is complementary to this one. Again, this is the immunohistochemistry where actually we have used the myelin basic protein to actually stain that mouse spinal cord injury area, and clearly there are a lot more myelin basic protein positive cells. So clearly that means the myelin, we have achieved the myelination also in these mice, and this actually has also protected a lot of neuronal and oligodendrocytes. As you can see, only the positive doxycycline positive mouse has all this positive stain, not in the negative mouse. So this was also important for us to actually show. This again very important for us to actually show that in vivo in the mouse we can achieve the targeted niche modulation by electroporating a construct directly into the mouse in a niche area where actually we would like it to get it done. And this is work in progress. Actually, we have not published it, and there are a lot of questions that we are trying to work on right now. And also, it is of our interest to actually see what actually has changed from the control into this mouse by taking the genomic and proteomic approach. And this work is underway right now. We are trying to answer this question, and once we have all these things, we are trying to prepare one manuscript and communicate this. So this is our ongoing study. But since I invoked a point where actually where the culture condition of this MSC culture have a profound effect, actually what will be the final product. And anytime we talk about the product, it's very, very important that how the product was developed by consistent process. Okay, again, and this is very, very important topic for actually a student to follow. As you can see, I told you that immediately we realized that the three-dimensional culture that we tried to do on a bone dentine chip was completely different than what actually we have been doing in two-dimensional culture. So what we try to do is we try to make a three-dimensional tissue in our lab by culturing this MSC and using ascorbic acid into the media and making sure that they release a lot of ECM. And then decellularizing by a protocol where actually we take care of the nuclear part and cellular component, completely wash it off, and leave the matrix in a aligned manner. This is again very, very important because the ECM and how stem cell relayed the ECM do not disturb that one, and that actually is very, very important to see the fate of the stem cell when actually we are trying to culture. So this is a decellularized, as you can see, after the decellularization, nuclear stain is completely missing, and then cellular ECM alignment is actually retained, and this actually we use as a three-dimensional culture to culture the cells. So this we actually validated by two different markers, one by fibronectin and one by collagen 1. And then both of these clearly established that we can actually make them the 3D culture in 3D natural component as a mark. The idea here was to use this naturally this as a benchmark where actually we will screen many of the artificial polymers to make sure that we make a reproducible level of three-dimensional structure, at least achieve the natural which is actually we are making from the human water jelly, and see actually what is the best condition. So when we created the lab in the 3D, there were 4 possible culture conditions. One, that 2D plus normoxia, that routinely we do it. One, 2D plus controlling the oxygen. So we bought one hypoxia incubator where we pump the nitrogen gas and take out the oxygen, and then actually we have an oxygen sensor which controls the oxygen inside the incubator. Okay, so this was this system we bought it, and then we control the oxygen now only up to 3%. And then next was the decellularized 3D matrix, which we can put them in a 2 dimension, and then the 3D plus controlling the oxygen. Again, we had established the set of assays, so we go through each one of them and make sure that the cells, we culture them, and all different 4 possible conditions are actually retaining the phenotype. So as you can see, the phenotype is maintained. This is the CD29, 73, 90 in all 4 possible culture condition: normoxia, 2D hypoxia, 3D normoxia, and 3D hypoxia. So these are the 4 possible conditions, and they have positive markers and negative markers, and they retain the different positive and negative markers. This is the quantitation of n is equal to 3. So we actually tried at least in 3 samples and made sure that they actually retain the many native immunophenotypic features. And these was very, very important for us to actually show that very important for us to show that they retain this. And also the cell cycle was comparable. As you can see, the n is equal to 3 quantities and has shown that they have, and the cell cycle is not dramatically changed. And then important thing was that they are able to retain many of the important growth factors in cytokines. As you can see, the many of the from the literature we pulled many of these primers and showed them that the GPX, CAT, SOD1, SOD2 expression is maintained. Also the TGF-beta, TGS6, PGE2, IDO, galactin, human growth factors, all of these things are very high in the ECM hypoxia. And this was important to show that also they retain the many of the important migratory molecules like CXCL12 or another thing that will be important for us to show them in vivo. Also important to show that they do retain the differentiation potential. As you can see, this is the same amount of cells, seed them in 4 different culture conditions. So after 21 days, the highest amount of adipocyte labeled in the 3D and hypoxia, which is physiological oxygen. And the same amount of cells is giving highest amount of adipocytes. So clearly that means this is the way forward in the future. So we should definitely go ahead and do this. And this is the differentiation of the chondrocyte. As you can see, there are 2 different stains. One is also in blue, safranin O, and Picro Sirius red, and all the different stains. They are able to show that chondrocyte differentiation. The amount of osteoblasts done by Boncosa as well as Alizarin red were highest in the ECM 3D. So clearly that means this is the way forward for us to, in future, to produce the cells which will be pharmaceutical grade. Also, just to show that they do not change their chromosomal characteristic, we did the karyotyping. Karyotyping was normal. They were able to actually maintain the different pluripotent gene expression. They were also able to maintain the pluripotency into the in vitro assay. So by the time actually we collaborated with Dr. Anandi from the Chennai, and actually she actually was very helpful in us to profile little further than what actually we had in our lab. So she runs a proteomic lab, and she was gracious enough to help us in this project. So what we try to do is we try to collect these cells, and then she ran them on a first in a IEF, and then use this IEF strip to run SDS page and differentially segregate these different bands and cut these bands which were in a different culture condition, and we will do MS and actually identify some of the key molecules that were different in this different culture condition. And see this again, we are trying to resolve this with Dr. Anandi, and we will be able to produce one manuscript on this. This is again very important to actually take little further than what actually we routinely do in the lab, in our lab, and actually show them rigorously enough to show that what are the different changes which actually retain the characteristic of these cells like in intrinsic MSCs. So we are working on this, so it will come out maybe in a few months. We are working on this project. Again, I told you many a time that whenever we do the cell therapy, much of the cells do not survive for a long period of time, and this has been a constant problem. So actually, if the cells don't survive, but always we see the therapeutic benefit. So the question comes: if the cells don't survive, then how do actually we see the therapy? And many times this has been proposed that the paracrine factors that secreted by these cells for the time they survive is sufficient enough to take and modulate that microenvironment in a positive manner, where the residual stem cell from the host will take over. So if we thought if that is a scenario, then can we also make an off-the-cell product? So that also is our agenda in our lab. So what we do is see and make an attempt to make cell therapy alternative, where actually we culture these cells and make cell-derived product, and then see if these actually will be therapeutic. So the rationale here is the cell-free product has a number of advantages in cell transplantation, because actually we can optimize by like a normal pharmacokinetics actually how much actually is there, and they are quite stable enough at -20 degrees almost for 6 months. So we will see if we can do this. So immediately we did the literature survey, and we found out that the MSCs are actually profound producer of the exosome. As you can see, these are the cultured MSC, and see the level of budding that is coming out from the one cell. So they have been profound secretor of these exosomes, and if you compare them with any other cells, and they are significantly higher. So clearly the MSCs have the intrinsic propensity to actually secrete these biotherapeutics. And if we do the engineering in a calculated manner, actually we should be able to actually model this to actually target one particular tissue and achieve the targeted therapy, and that is very, very important. So just to say that how do these exosomes and microvesicles, so there are a biogenesis protocol. If someone want, actually they may have to read some of the literature. So but there is a clearly a intrinsic mechanism where actually they sense and then they regulate the many of the biological system. So just to give you an analogy, many times we connect through the Ethernet, which is a direct connection, but many times we also connect through the Wi-Fi. So if many a time the molecules which are segregated at one place, but it will go and migrate and do the effective job in other place. So if you think in that analogy, many times these exosomes and then cell-derived product actually modulate the stem cell niche by going far, working like a Wi-Fi and doing the job in remote places other than the niche also. Okay, so this is how actually we can many times achieve the therapy. So even if we isolate these biotherapeutics and put through the systemic routes, even though they will go to the different places, they know where to do what kind of job, and depending on the demand that actually one particular niche area has, they will do the therapy. So, but there are limitations in the field. I don't want to say that this is already ready and ready to go to the clinics. We have difficulty in making the product consistent, because we don't know which protocol will actually produce the consistent level of biotherapeutics. Also, we have the limitations in making the genetic background different, because every patient will have different level of biotherapeutics. So we don't know which particular cells actually we should make the off-the-cell product. So these are some of the challenges in the field, and the research need to be done to overcome this challenges and actually make a biotherapeutic which will have the off-the-cell product. Because many a time now, clearly from the day one we have been listening, there are many different people talking about using them in a context where actually they have very good in modulating the niche area, and this is very, very important for us to take this forward and make some biotherapeutics which will have off the cell value. So immediately what we try to isolate from the human Wharton jelly, and we put through the nanoparticle tracking system. We could see a size range between somewhere between 50 to 150 nanometer, and this was acceptable for us to actually show that by TEM that they are bona fide vesicles, and they have a definite structure, and which are actually retained in this one. So again, we try to characterize this by flow cytometry. It was again challenging because being a very small particle, it was challenging for us to actually do it in the flow cytometry. So we tried to conjugate them with latex beads to increase the size, and then actually we could detect it. As you can see, they were positive for CD63 and CD81. Also, we had to show that since we isolated from the human MSC, they should also be positive for CD90, and they were CD90 positive. So clearly now we know that we were able to purify the bona fide exosomes from the human MSC, and it's very well characterized by CD63, 81, and CD90 expression. Right now we're testing them on a wound healing model, but literature also have clearly established the safety and efficacy of all these things, and we are also working on this. But again, simultaneously, we put one more project to show that can we actually achieve the targeted killing by engineering these stem cells, and then ask them to do a particular job by arming them with one particular suicide gene. In this case, we use thymidine kinase, and we use this thymidine kinase, and then try to do an in vitro assay and to show that we ask them to kill cancer cells, and are they able to do it? Here, what we try to do, we make a stable line with green fluorescent protein, and we used a suicide gene here in this MHCs, and we label the cancer cells with a DS red, and then we put them in a co-culture condition, and we did a time-lapse video in a confocal microscope. As you can see, with the time, the red fluorescence is going down, and only fluorescence that retains is the green fluorescence at the end of the experiment. And I'm going to play one video, and I would like you to focus on this particular cells. As you can see, this green cells is attaching to one red cells, inducing apoptosis because it has a suicide gene, and it's inducing apoptosis and moving on to another red cells. Okay, and this phenomenon will go on and on and on for a period of time as we monitored, and then the net result is the killing of these cells, and then only thing that retain is the green cells. Now, when I show this result to anyone will ask that how sure are you that they are actually doing this job with the manner that you actually say. As you can see, this is the again confocal micrograph. Actually, we will stain them with the CD63. So only thing that is labeled is the exosome, which were labeled by the GFP, where the CD63 expression actually is followed by the GFP expression, because they are both in a one reading frame. They come as a fusion protein. So if CD63 is expressed, GFP is expressed. As you can see, these green dots are actually moving to the red cells, and that in turn actually has reduced the life of these red cells, and in turn has actually reduce the red fluorescence from the co-culture condition. As you can see, the clear migration on this is again photograph of there where actually we do the DIC with this and show them that this is actually happening. The green dots are moving to the red cells, and that's how these red cells go under apoptosis and reduce the therapy. So clearly that means if you do the actually educated engineering of the stem cell and ask them to do a job, they will do a job. So and if we do and maintain the culture conditions also, that also is very, very important to retain the intrinsic features. So clearly I have shown you from the data that by making educated engineering and then asking to do a targeted killing or doing a targeted job in a tissue targeted manner also can be achieved. So okay, these are some of the things I did. So when I showed all of you data, I don't want to put in a condition. And again, I'm optimistic, but again, there are limitations in the field. So I must tell you that what are the different limitations in the field also, so that you are aware, at least for the students, so that they are aware that what are the challenge in the field and how we can address one challenge at a time and not get bogged down and then try to see. So resolving one problem at a time and making them in a public so that the people who are following us will actually do not repeat the same thing and they will move on. So the field moves on. Okay. So there are many challenges. There are many unanswered questions that we have to resolve. Is the question that I'm invoking is what is the best cell source and what is their culture condition for the therapeutic application? That still need to be resolved. Okay. Now the second question is how many cells are to be used for what particular application? This is again a big question. Okay, right now we take some empirical number 1 million, 10 million per kg and inject them in a one particular application. But the question is that actually necessary or actually what is the best one? So that also need to be resolved. Now the third question is where should we inject the cells actually? Should we inject them in a systemic? Should we inject them in a local? Or what is the best site for the injection? And now the important question is when should we inject the cells? Like suppose I told you about the spinal cord injury. So if someone comes after 1 month where by the time the fibrosis already happened, and then how much can you remodel and how much the cell therapy will do, that is important issue to be resolved. So timing is extremely critical. Okay. And how could actually we increase the transplanted cell survival to maximize the tissue integration? And then again, the culture condition is the single cell suspension is good enough, or actually we can make some 3D culture graft, engineering the tissue in a dish and then transplant. So these are some of the challenges in the field, and then we may have to tackle these one at a time and tackle them head on to actually resolve the many of the potential that cell therapy gives in front of us. So on a positive note, there are a lot of potential, and we must take many of these on a somber note and try to resolve this one by one. Okay. So thank you for listening, and if I have any question, I will be happy to answer.
Thank you, Dr. Sanjay Kumar. It's a very informative talk. I now hand over the session to Dr. Ramesh N. To take over.
Thank you, sir. Thank you so much. And thank you for your excellent informative presentation and data shared with us, doing a wonderful job in this field. Now the participant, if you have any questions, you can ask to Dr. Sanjay, sir.
No, the way the Q&A is handled is they have to send their questions via the chat box. And then if they have any questions, then I'll pose them to the speaker. Someone said, thanks, Sangu Industry, NRI, Biotech. Thanks for informative on stem cell. That person is actually thanked. Sir, from my side, your last slide, in vitro 3D cultures, culture in physiological conditions. So are we envisioning a situation wherein you grow them on demand and then supply, or are we envisioning situations where you grow them and you can store them in a viable condition?
Yeah, so to answer this, Dr. Suresh, what I envision is, because I told you tens to hundreds of millions of cells is needed for one patient, okay? And suppose we are doing for any particular replication, where do we actually generate that kind of cells in a any industry setup, okay? So the way I envision is there is a company in Israel which is called Pluristem. They have been doing this in a bioreactor. Okay, so what they use is 3D beads actually, where actually they have made these polymers coated on a 3D beads and culture them in a big bioreactors, which is about 2,000 liters. Okay. 2,000 liters bioreactors, and put some seed cells and culture them to a particular number, and actually harvest these cells and make the vials and store them. So they have got a big grant from US Army actually to actually seed this human placenta derived MSC for radiation control, because what they think that if some terrorist or somebody just blast a bomb somewhere, radionuclide dirty bomb, in suppose in New York or somewhere in US city, then what will this? So what people have actually shown that if they transplant this MSC is actually they control this niche for a regenerative purpose. So they are banking them. So they have got 400,000 vials of these cells stocked in liquid nitrogen. In future, if some kind of demand appears, so this is how they are actually doing. So I also envision in the similar manner, we can take one particular cell, characterize them well, and then culture them in a bioreactor and freeze them in a liquid nitrogen, where actually when the demand comes, we can just thaw them and inject them. Yeah.
Yeah, I think that's a great answer. Thank you. Dr. Tamil Selvi, madam, you have any questions?
Yes, yes, sir. So it was a wonderful presentation, and you have worked with the PTEN gene, right, sir? Why specifically you selected? You showed some article they've worked with PTEN, but why not any other gene? Why specifically PTEN was being selected?
Oh, I agree. So what happened, Ma, is that when we are reading this paper, so this was kind of the idea was because this is in the path of this therapeutic milieu that is actually written in the. So what they did is they have taken the PTEN knockout mouse and then created the injury. As soon as they created the injury, the healing started in this mouse. Okay. So this was a thing that maybe if the PTEN is regulated in the initial phase of the injury, that actually will create a therapeutic environment where actually the therapy will set in, and then that. So that's how I actually choose it, the PTEN, and we will try to see another some small molecules in the same cascade of molecular event that happens, and we will see if other molecules also will happen. But for the as a proof of principle, we chose PTEN to show that we can actually do the targeted tissue modulation in vivo in mice directly, and actually we can achieve the targeted therapy. So this is just to show as a proof of concept. We chose one gene and we are showing the effect. And if we can, similarly, we can choose any other molecules in the pathway and we can show them that this is also possible. For a proof of concept, we choose PTEN, right?
A more general question, MSCs versus exosomes, which would be better, sir?
So always there is a big question, Professor Suresh, is the cells. What is the long-term fate of the cells? What happens? Because there is no much data there, okay? Because much of 95% of the cells do not survive, but still few cells that might survive. What is the 10-year, 15-year, 20-year follow-up data? So those kind of data is not there, okay? So cell therapy, even though they are safe, hundreds of clinical trials have already happened, but always there is a question mark. So if the cell-derived product also can achieve the bulk of the therapeutic benefit that we get from the cells by cell-derived product, then actually we don't need to use cells. And cell-derived product is good because then we can actually engineer a cell of the cell product, which will be stable. So imagine a scenario where actually we have lyophilized exosome sitting on the pharmacy vial. Okay, just take it, put the this saline and inject into the people, that will be the ideal scenario.
Any work along the lines of this CAR therapy, because we are talking about the chimeric antigen receptor, not related to this topic, but anyway, we can introduce it and they start proliferating endogenously?
Yeah, so we are already trying, Professor Suresh. So we have a team actually where we are trying to do the CAR cell therapy. We are trying to develop, but right now we are not trying on these cells. We are going to isolate the human HSCs and engineer the CAR on that, because it goes through that lineage actually where actually we can get those specific T cells which will kill the tumors, and because we need to actually develop specific T cells, right? So that's how actually we are trying to engineer this. But somehow if we engineer this in a manner, it is again definitely a potential. But right now we are trying to engineer the CAR on a HSCs, human HSCs.
Yeah, I think Dr. Biju George referred to that in his.
Yeah. Exactly, Dr. Suresh.
Thank you. Dr. Tamilselvi?
Yes, sir. So I have one more question. Like you have mentioned that in your unanswered questions, like when should we inject the cells? Like based on your experience with the MSc field, so what would be the right time to treat with MSCs?
Yeah, so that's what we observed, that because the mouse experiment that I said, because immediately means 24 hours within after the creating the injury into the spinal cord, when we injected these human stem cells, and the therapy was very good. But in a real life scenario, that actually is quite not possible, because many times we have seen many of the patients actually suppose they fall from a tree or they have a road accident, they come only a little late, many times by the time already fibrosis sinks in and then a lot of damage has been already done. So but if we do the therapy immediately, it's good, because we all know that the intrinsic feature of MSCs is immune modulation. And many times, if we don't allow these different macrophages and fibroblastic cells to go and create a fibrotic situation in any of the injury, either take over a spinal cord injury or bone healing or many of these conditions, then injecting early is the good idea. Whatever earliest that we can actually intervene, that is a good.
Okay, Dr. Sanjay Kumar, thank you for your wonderful presentation. And yeah, Professor Suresh, shall we?
Yes.
On to the next session.
Organizers, I once again thank Dr. Sanjay Kumar for taking time out to deliver a lecture and share some of his valuable thoughts, especially about the conditions that we routinely use in 2D and the conditions that actually need to be used to mimic the physiological situation. I hope it was informative, especially for the students. I would like to make a few announcements here. We are meeting again at 2 o'clock for the last session, the last two speeches. Okay, and then we have the concluding remarks that are made by me, as well as the organizing secretaries, and then we'll take feedback questions, a few select questions, maybe 5 or 6 from the registrants to find out what they thought about the speeches and the deliberations the last 2 days. So we'll meet again at 2 o'clock, and be reminded that you need to attend 5 sessions, including the inaugural, to be eligible for the certificate. You also need to fill out the feedback form. I will send the link in the afternoon. I would like to thank the chairperson, Dr. Rameshan, who was very busy with his NAC work and other academic commitments. He is a researcher involved in several activities, including phage therapy, and I'm thankful to Dr. Rameshan for having come here and chaired this session. Thank you.
Thank you, sir. Thank you so much, sir. Thanks for the opportunity. Thank you, ma'am.
Thank you, Dr. Suresh. Thank you, everybody in VIT.
Thank you.
Thank you, sir. Thank you, sir.
Dr. Tamilselvi, madam, we do not log out, madam. We do not log out.
Okay, sir. I'll stay.
So that YouTube will continue to be on. Otherwise, we need the support of CTS to come back and restart the YouTube. We won't avoid that.
Okay, sir. Sure, sir. I'll start.
Dr. Manjubala, madam, you have anything to say, madam? Dr. Tamisari, madam?
Yes, sir.
We'll meet at 2 o'clock.
Sure, sir. We'll meet at 2 o'clock.
All right. Good afternoon, Dr. Tamiselvi, madam.
Good afternoon, sir.
I've asked Dr. Devi Rajeshri, madam, to log in. She said she will do so.
Okay, how about Professor Bhaskar Rao?
He's already there. He's already there. He has been made the co-host. Dr. Bhaskar Rao.
Yes, sir. Good afternoon.
Good afternoon, sir. How are you? Had your lunch, sir?
Yes, just completed. What about you?
Yeah, I just went to the hostel and had
You are very busy from past 2-3 days, maybe. Not taking proper lunch.
Yeah, I mean, breakfast is a problem. Lunch is okay. Breakfast is very.
Yes. I noticed session starting 8 o'clock, 8:15.
Yes, sir. Yes. So now, Madam will be projecting the CV, and you will be.
Sure.
Dr. Devi Rajeshri, madam said she will log in.
She will take care of question and answer, sir, Devi Rajeshwari. So I will introduce the guest speaker, Shaji, Dr. Shaji.
Dr. Devi Rajeshwari, madam.
Yes, sir.
In the chat box, just send a note. I will also do so from my side.
Okay, sir.
Dear participants, please send your questions to me directly. That's all you need to do. And I will also send a message from my side.
Okay.
Please send your questions to Dr. V.
First you send me, sir, then I will send it to you.
All right.
Okay.
Not turned up, huh?
Madam, a message has been sent to everyone, and you can copy and paste it in your chat. So you can send a message from your side, madam. Dr. Shaji is there? Shaji has not joined yet.
Yes, Professor, he's yet to join.
Tamil Selvi, madam, I am not getting any screen.
Yet to share, sir. Shall I share it now itself, sir? Suresh, sir, shall I share the profile of Dr. Shaji?
Yes.
You can do so. There is no problem.
Okay, sir.
But we still have about 12 minutes left.
Yeah, that's what.
Yeah, this is good. Small letters.
Dr. Shaji? Hello. Your lecture in 10 minutes. All right. Thank you. I telephoned Dr. Shaji.
Yeah.
Yeah, hopefully he'll join. Maybe he was busy and he probably forgot. Yeah. Dr. Shaji is actually working very late and
he didn't attend the previous session, sir. Dr. Sanjay Kumar session. They both are from the same center, right?
we are in the same center, no doubt. But Dr. Shaji is more hematology. And,
okay, yeah.
More mesenchymal and bone related. So, yeah. Madam, after the sessions are over,
yes, sir.
Planning on having a few concluding remarks from my side. And then I will request the organizing secretary, one or the other, to say to say a few words. And then we call upon a couple of faculty members, a couple of research scholars, and perhaps a couple of registrants.
Okay, sir.
Not more than 5 to 6. And with that, we will close. The dean is
sure, sir.
Dean is quite busy. He asked us to
okay, sir.
So that's
yes, sir.
Suresh sir.
Yes. Tell
Someone has sent queries. There is no sound. Try to correct it.
Who has sent?
Isaias, I think so. Isaias. From Isaias.
Might be from his side, ma'am. We were all able to hear, right?
Yeah.
Something's wrong on his side, might be.
I think so. Okay, let's see, sir.
Dr. Devi Rajeshwari, madam, your chat box is working?
Yes, sir. Yes, it's working now.
Thank you. Good afternoon, everyone. I see here in the chat a few saying there are issues with the audio. Is everyone able to hear?
Yes, sir.
Yeah, we are able to hear. I hope the registrants are able to hear as well. Good afternoon, Dr. Shahji. Good afternoon, Dr. Shahji. Dr. Shahji, can you unmute yourself? Good afternoon, Dr. Shahji.
Hello, Dr. Suresh.
How are you?
Good.
I see you're coming directly from the lab.
Yeah.
Thank you once again for accepting our invitation. And, you have been around helping us out, conceptualizing the whole conference, helping out identify resource persons and so on and so forth. Just before your talk, Dr. Sanjay Kumar delivered a lecture. And yesterday, Dr. Viju George discussed about HSC transplantation related issues. So we will start at 2 o'clock. The person in charge, the session in charge is one of the organizing secretaries, Dr. R. Tamil Selvi. And the chairperson will be Dr. Bhaskar Rao, and the moderator will be Dr. V. Devi Rajeshwari. Now, Dr. Tamil Selvi, madam, you can take over.
I will all session, and yeah, this is the second of today's conference.
Madam, your voice is cracking. Dr. Tamil Selvi.
Sorry, the connection was unstable here, so I'll share the screen again, and I request
Can you see my slides?
Mr. Bhaskar Rao to
Dr.
so
Shahji,
one second, sir.
Dr. Shahji, first, Dr. Bhaskar Rao will read your profile. And Madam will share the screen, and then you stop sharing, and then you can start sharing yourself.
Sure.
Yeah, can you see the screen, sir?
Yes.
Yeah, I can.
Yeah, may I request Professor Bhaskar Rao to introduce Dr. Shahji?
Yeah. Good afternoon, one and all. Welcome to the afternoon session of virtual conference on stem cell. So, actually, it is very challenging for both the speakers as well as the audience to start post-lunch session. So immediately after the lunch, I hope today's speaker, Dr. Shahji, will enlighten us with his interesting talk on red cell diseases and therapy by stem cells. So it is my pleasure to introduce Dr. Shahji to the audience. So Dr. Shahji is a professor in the Department of Hematology and also working as an adjunct scientist at CMC in the Center of Stem Cell Research Center, Vellore. He completed his PhD from Basic Medical Sciences from the CMC College, Vellore. He started his journey as a junior lecturer in the Department of Hematology at CMC, Vellore. Later, he moved for his postdoctoral research to the University of Chicago, followed by a brief stint as a research assistant professor at the University of Chicago, USA. His areas of interest and also his expertise in the laboratory research work in the field of various type of stem cells like induced pluripotent stem cells as well as IMSC And apart from this, Dr. Shahji is also has done published various research as well as review articles in several peer-reviewed national and international journals. Apart from that, Dr. Shahji also got awarded with the various grants from government streams like Department of Biotechnology, DBT, and also Indian Council of Medical Research, ICMR. And continuing, he also received several awards like Welcome DBT Alliance Senior Research Fellowship in the year 2018, and also Reverend Lardu Yaddanapalli Award for Young Researcher in the year 2015, Bodway Endowed Postdoctoral Research Associate Fellowship at St. Jude Children's Research Hospital, Memphis, USA, from 2004 to 2006. And he also got awarded with a best paper for his presentation in the Christian Medical College, Vellore, in the year 2004. Apart from that, Dr. Shahji is also a member of prestigious scientific bodies like American Society of Gene and Cell Therapy and also International Society for Stem Cell Research. So with these few words, I welcome Dr. Shahji to start his lecture.
So you can share the screen and project your...
Yeah, can you see my slides?
Yes, sir, we can see. Thank you.
Yes, sir.
Okay, first, I would like to thank Dr. P.K. Suresh for organizing this meeting and inviting me to give a talk on this topic, red cell diseases, and focus on stem cell based therapy. I also thank Dr. Bhaskara, who gave a kind introduction about my research work that I carried out in the last few years. I'm a faculty in Department of Hematology, where I hold my primary position, and I'm also an adjunct scientist at Center for Stem Cell Research at CMC Vellore. As Dr. Bhaskar Rao said, it's going to be a task to keep everyone awake after lunch, and I will try my level best. But one of the ways to wake up from sleep, at least for the students, to stop me and ask questions, so maybe we can keep this session interactive. I just want to give you an introduction on, just want to move this slide to one corner. The area of my research is mainly on human erythropoiesis using different models. The first on the left side, what you see is using hematopoietic stem cells from normal individuals and patients with red cell diseases and differentiate them to erythroid cells. So these hematopoietic stem cells can be differentiated to red cells by doing ex vivo or in vitro erythropoiesis in the lab. And we do a lot of things here to know what exactly happens during erythropoiesis by taking the cells at different stages of erythropoiesis from culture and doing transcriptome analysis, studying epigenetic factors, and a lot of other things. And these were all achieved through my earlier grants. On the right side, we use induced pluripotent stem cells derived from fibroblasts or blood cells from patients and differentiate them into hematopoietic stem cells and differentiate further to erythroid cells. And the different reasons are establishing the technology and use this induced pluripotent stem cells, derived hematopoietic cells to study the disease modeling and whether you can mimic disease in a culture, and you can use this model for drug testing and also for using the cells for potential cell therapy. And I will just take you through some of this work that we did in the last few years, the last 5 years. And one of them is doing lentiviral gene therapy for hemoglobin diseases. Now I'm going to take you through some introduction on thalassemia's which are the major hemoglobinopathies. This you can see in this in the globe the distribution of thalassemias, which are different patches and colors that you see. And this disease is very common in some geographical regions where malaria was prevalent. And there are different reasons why it coexisted. And it's caused by quantitative or qualitative defects in hemoglobin synthesis. And the two major conditions are beta thalassemia major and sickle cell disease. This again to give you an idea of the different types of thalassemias that patients can have. As I said, thalassemia is specifically, it's a quantitative disorder where the globin chain levels are low. And the two major types, the beta thalassemia and alpha thalassemia. In beta thalassemia, the beta globin gene in the beta globin cluster is defective. And all the globin genes are present as a cluster, and all the globins are involved in making hemoglobin in our red cells. So when there is a mutation here in the beta globin gene, patients get beta thalassemia. And the disease becomes severe if the patient is homozygous. And very rarely there is alpha thalassemia in the population. And there are other different types which are rare, are delta beta thalassemia, and it is caused by mutations in delta and beta globin genes. And there's other conditions called hereditary persistence of fetal hemoglobin. There also delta and beta globin genes are deleted. And between delta beta thalassemia and hereditary persistence of fetal hemoglobin, there's a slight difference in the type of mutations. And what we will focus majorly on beta thalassemia in the beginning. What we did is to do a lentiviral gene therapy for patients with beta thalassemia and sickle cell disease. And sickle cell disease is like beta thalassemia. There, the problem is a qualitative disorder. The type of hemoglobin produced in the red cells is different, but it is not a quantitative disorder like we see in beta thalassemia. For both these patients, we have started a project to generate lentiviral vectors to express beta globin, because beta globin contains the mutation. So replace with a normal copy of beta globin in the patient cells, or express gamma globin. And gamma globin is expressed in the fetal stage in our life, and gamma globin can do the work of beta globin, and we can see whether patients can have a normal phenotype or not. The last one is BCL11A. It's a transcription factor that is responsible for reducing the gamma globin expression in adults. And if we reduce the level of BCL11A, then gamma globin level can go up. For doing these three different lentiviral projects, and we had three models. And the first one, is in ex vivo erythropoiesis, where we take CD34 positive hematopoietic stem cells and progenitor cells from normal donors and transduce them with these lentiviral vectors to express beta globin, gamma globin, or the shRNA for knocking down the expression of BCL11A. And these lentiviral vectors contained one of these constructs. Then subsequently, this gene modified hematopoietic stem and progenitor cells were expanded and subsequently differentiated to erythroid cells, and see what happens to these erythroid cells after putting back the defective gene, or expressing gamma globin gene, or increasing the gamma globin gene by reducing the BCL11A expression. Then for some of these lentiviral vectors, we did experiments in sickle cell disease mouse, where we took hematopoietic stem cells from a mouse which mimics human sickle cell disease, and transduced these cells with lentiviral vectors to express beta globin or gamma globin, then put them back into a normal mouse which was irradiated. And after irradiation, this recipient mice will not have hematopoietic stem cells, and this transduced hematopoietic stem cells will get into the recipient and reconstitute and differentiate into erythroid cells. The last experiment is transplantation in immunocompromised mice. Here, hematopoietic stem cells are taken and they're transduced with lentiviral vectors and transplanted in the immunocompromised mice. Here, hematopoietic stem cells will survive longer and they will become human erythroid cells in these mice. And these erythroid cells can be taken and they can be assessed and see whether there is a difference in the phenotype. So with this strategy, this is the generation and evaluation of beta globin gene addition vector. Here we, the lentiviral vectors contained beta globin gene, and we took this, 5 vectors were generated with different elements for getting efficient expression of beta globin. And then, as I said earlier, they were evaluated in the ex vivo erythropoiesis model where CD34 cells were transduced and differentiated to erythroid cells, and globin transcripts were seen, then subsequently transplanted into sickle cell mice. A lot of work done in a period of a year to achieve this much. And you can see here, there is a high level of hemoglobin A that is expressed in the mice, in the transplanted mice. And that clearly shows that the lentiviral vector, although we started with 5 vectors, we had 2 of them which could express high levels of hemoglobin A. These experiments need more mice, and therefore we thought, okay, now we will do this experiment differently, because we know that this lentiviral vector can express high levels of beta globin. We are planning to use this mice now. We started this experiment where we take CD34 cells and from a normal individual, transduce them with this vector and transplant into NSG mice or NBSCW mice. And these both are immunocompromised mice, and see what happens to this. Next stage, we have collected CD34 cells from patients with sickle cell disease. Now we are going to transduce them and transplant into these immunocompromised mice and see these red cells have phenotype correction. And this vector seems to be making high amount of hemoglobin A, and it may be therapeutically beneficial, but that has to be seen in the NBSCW mice after transplantation. In the next one, as I said, we can use beta globin or gamma globin. And gamma globin, although it is expressed in the treated stage, it can do a phenotype correction in the adult erythroid cells. And this is a construct. I'm not going into the details of this construct. And like all lentiviral vectors made for gene therapy for hemoglobinopathies, the vector is complex. It has to have all the elements for very high expressions of the globin transgene, and it has locus control region, selected promoter sequence, then and very carefully taken UTR sequences, and they are used for this experiment. And this viruses also were used for transplanting into the sickle cell disease mice model, and you can see very high level of hemoglobin F expression after secondary transplant. And this also shows that the same construct that was used for beta globin addition, we modified and added the gamma globin, and both of them have the same backbone, and this backbone helped in the expression of both beta and gamma globin expression. So now it's clear that this vector is an efficient lentiviral gamma globin gene addition vector. And what we are currently doing is, like we did planning in the beta globin gene addition vector, transducing the CD34 positive cells from a patient with a sickle cell disease and transplant into the NBSCW mouse and see whether these red cells have phenotype correction. And this is just to show you what happened in the sickle cell disease mouse. And you can see here there is a significant difference in the transplanted mice. You can see here the green color is after secondary transplant, its hemoglobin level is comparable or very close to the control mouse which was untreated. And in the mock transplantation, as a control transplantation, you can see here the hemoglobin is low. So in sickle cell disease mouse, what we found was there is increase in the hemoglobin levels. And this is another experiment looking at the red cell morphology. A parameter used is called elongation index. And using this, it's clearly shown that the transducer cells, they have a better elongation index, suggesting that these cells have phenotype correction after transplantation. While we were using these two methods, we also thought of using another strategy, which is by knocking down BCL11A, which is a transcription factor. Usually in the adult erythroid cells, it is responsible for the lower level of fetal gamma. The fetal globin is repressed by BCL11A. And the idea was using RNA interference technique, knock down the BCL11A levels so that the gamma globin expression will go up and the gamma globin will bind with alpha globin to make fetal hemoglobin. So this is the structure or the vector that we generated here at CSIR. And just to give you some of the important elements here, this HS2, HS3, HS4, they are erythroid specific enhancer sequences that are required for high level expression of beta globin gene. And it's a promoter, is a beta globin promoter, but beta globin gene is replaced by the shRNA against BCL11. And we constructed two of them, and there's a slight difference between them. The slight difference is the sequences of the locus control region, which is the enhancer, transcription enhancer. First, we tested transducing into HUDEP cells, and HUDEP2 cells are very famous, well-known erythroid progenitor cell lines, and many people use the cell lines to check the lentiviral vectors. And we got this from Riken, and we transduced with these lentiviral vectors. And you can see here, there is significant reduction in the expression of BCL11A protein after transducing with this, both the shRNAs. And then in the HUDEP cells, we looked at the expression of hemoglobin F. The control is a scrambled, which is an shRNA against a non-specific region, and shRNA against the BCL11A using the two lentiviral vectors. You can see here there is significant increase in the fetal hemoglobin, and that clearly shows that the shRNA that we used could decrease BCL11A significantly, and because of that, hemoglobin F levels increased in these HUDEP cells. And it was not that easy. The HUDEP cells had to be transduced and they had to be finely differentiated, then do a flow cytometry using hemoglobin F marker and assess the percentage of increase in the fetal hemoglobin. Now, we have generated more vectors looking at the expression, and using both the vectors, we transduce into CD34 cells. The previous experiment, it was done on the HUDEP cells. Now we took primary cells, which are CD34 cells from a normal individual, which are hematopoietic progenitors. They were transduced, and the transduced cells were flow sorted, and they can see here the GFA positive cells are transduced with shRNAs, and there's significant reduction in the BCL11A protein. And the transduced cells, you can see the hemoglobin gamma expression is going up and BCL11A expression is going down. And you can see here very high levels of HbF, and which is measured by flow cytometry. And previous experiment was done in HUDEP cells, and this was done with the primary cells got from a normal donor with CD34 cells. And this is further experiment using HPLC, And that clearly showed that there is increased levels of gamma globins, G gamma and A gamma. As I said earlier, gamma globin binds with alpha globin to make fetal hemoglobin, and this level is significantly high. So this one, it's clear that knocking down the BCL11A using this lentiviral vector can increase gamma globin levels. Because of that, fetal hemoglobin level goes up. Now we made a vector for therapeutic applications. Why we made it like this? Because the previous vector had GFP and that is not allowed. And there's a puromycin resistance gene. We removed all those. And this vector contains only the shRNA for BCL11A. And without any selection, you can see here the levels of BCL11A is decreased significantly after transducing with lentiviral vectors. And you can see here the gamma globin levels is going up. And this shows that there is very high levels of fetal hemoglobin after transducing with this particular vector. And HPLC analysis of gamma globin clearly showed that there is 20% of fetal hemoglobin F gamma globin that is expressed in the erythroid cells derived from these CD34 cells transduced with the lentiviral vector expressing the shRNA. So this experiment, after removing GFP and puromycin, which made a vector which can be used for therapeutic applications, clearly showed that it can increase gamma globin levels. And this experiment was carried out with a low vector copy number. And if we use a higher vector copy number, that means bombarding the cells with more number of lentiviruses, increasing the number of the lentiviral integrations within the cells, we will be able to achieve even more hemoglobin F. And what allowed now is that you can go up to 3 vector copy number. And here we have only 1 vector copy number. So if we achieve 3 vector copy number, we'll be able to get even more fetal hemoglobin. We modified this vector. We became very ambitious. We were very excited with this vector. And you can see here, it's a complete vector for high titer expression. And we incorporated 2 restriction sites here to clone any shRNA into that site. It's not only shRNA for BCL11A to knock down the expression of BCL11A only. Now I can clone shRNA for gene A. I can clone shRNA for gene C. Any genes I can clone into this very, very easily into this vector. And this, you can see that BCL11A in this modified vector, just cloning into these restriction sites without any Gibson assembly, you can just clone into this ZO1 ECOR1 site. You can get significant knockdown, and it could be transduced within the cells with a high titer. And we have tested this vector and with and without a cyclosporin H, and cyclosporin H is known to increase the transduction efficiency. And you can see here, after adding cyclosporin H, we are able to get 54% of GFP positive cells, and that is very good. That clearly shows that when you have to do a gene therapy at a clinical trial, you do not have to have very large number of CD34 positive cells if you use cyclosporin H, which can increase the transduction efficiency significantly. So the message here is this vector, which has the ability to clone any shRNA vector. It can downregulate any target gene that anyone is interested in. And the newer genes like LRF1 or many other transcription factors can be downregulated significantly. And we also found that cyclosporin H can increase the transduction efficiency significantly. And what we did was we used the cells and transplanted after transducing the CD34 cells. Like I said earlier, one of the methodology is to transplant into NSG mouse or NBSCW mouse. These are immunocompromised mice. And they, after transplantation, the cells were taken and we looked at the transplantation efficiency, that is engraftment, that shows a high number of CD45 cells were engrafted. And then you can see here, when we took these cells and did erythropoiesis, we could see very high level of GFP that is expressed. And that clearly shows that GFP, which is there in the vector, is not expressed in the CD34 cells, which are non-erythroid cells, the early progenitors. And when they differentiated to erythroid cells, they expressed GFP. So that is an important information, because it clearly shows that the beta globin vector that we have with the locus control region, which is the enhancer and transcription enhancer and beta globin promoter, will provide erythroid specific expression of shRNAs. And that was very, very important for us to achieve, because knocking down the BCL11A in hematopoietic stem cells, even the early stage, is not good, because it has been shown that if BCL11A is knocked down, it affects the aging of hematopoietic stem cells. So this vector, after differentiating into erythroid cells, the promoter becomes active, and it will knock down BCL11A only in the erythroid cells. And this we could achieve. Now, this is very similar to a vector that was generated by David Williams using very complicated lentiviral vectors. He had shown, this is not a very, very original study. Our study is not a very original study. This has been shown by David Williams that using lentiviral vectors, you can knock down BCL11A transcription factor, and gamma globin expression can be increased. And he has got several patients with the sickle cell disease they have been treated, and they are all doing very well the past 2 to 3 years, and the hemoglobin levels went up significantly. And this is very, very important achievement in gene therapy for hemoglobinopathies. Our vector has got a different backbone. It is not an original idea. Our idea was not original. We just increased the efficiency by adding several factors to make it erythroid specific, with very high knockdown of BCL11A and increase in the hemoglobin F levels significantly. And we think that it has to be checked again in different cells, and we seriously think that our vector is more robust in increasing fetal hemoglobin. And the sequences that we have is original, is different from Dr. David Williams but the concept of knocking down was originally described by David Williams. And we are trying to do in more mice and trying to patent this vector before taking them for clinical trial. So are you all awake? Can I continue?
Yes, Professor, you can continue. Yes, sir.
Okay, thank you. So that was one strategy by down-regulating a transcription repressor and increasing the levels of gamma globin and increasing the level of fetal hemoglobin. That was one strategy. While this is one of the strategies has been established and found to be beneficial for patients with sickle cell disease and beta thalassemia, we thought we will also do another approach by gene editing. And this is an introduction for a type of mutation that is present in humans. In the beta globin cluster, I told you in one of the first slides that when the beta globin gene is defective, patients can get beta thalassemia. But if there are large deletions there, which delete delta globin and beta globin, and sometimes a part of pseudo beta, and sometimes A gamma, but G gamma will not be deleted. G gamma is the second gamma globin. When such deletions exist in adults, hemoglobin F, the fetal hemoglobin F, persists, which is supposed to be, I will have a hemoglobin F of 1 or 2%, and most of you there will have only 1 or 2% of fetal hemoglobin F. But if someone gets a mutation like this in a heterozygous state, we have 2 chromosomes, at least one is defective, will increase hemoglobin F. So many scientists, what they're trying to do is to make such deletions in the beta globin cluster. Now, you know that there are gene editing strategies. You can create small deletions, small point mutations. These point mutations can be insertions or deletions of a few bases, and large deletions with less efficiency also can be created. And at least 2 or 3 groups have shown that the large deletions can be created in the beta globin cluster to mimic this hereditary persistence of fetal hemoglobin. The idea is that if there's a patient with sickle cell disease or homozygous beta thalassemia, where beta globin gene is bad, it has mutations, when these large deletions occur in the beta globin cluster, gamma globin levels can go up, and when fetal hemoglobin is high, the disease phenotype becomes milder. And your anyway adult globin is defective, so increase fetal hemoglobin in the adults by creating deletions like that. In addition to these deletions, there are several point mutations that can occur in the globin, in the gamma globin promoter. HBG1 and HBG2 are the 2 gamma globins that we have. And we have totally 4 copies of gamma globin. This is in chromosome 11, 1 chromosome. Similarly, we have another copy. And what in large populations been found is that if there are point mutations that can occur in the promoters of these gamma globins, and that can activate gamma globin. The reason is that in the adults, these promoters have transcription repressors binding there. If mutations occur in an individual, in those promoters, transcription repression goes away and transcription activation can occur. And these are the different types of mutations that have been seen, naturally occurring mutations that have been seen in different populations. And you can see here that this particular mutation can increase fetal hemoglobin levels to 40% in an adult. So now, using CRISPR-Cas9 gene editing methods, it's possible to incorporate point mutations in these regions. And these point mutations, if created successfully, they can increase fetal hemoglobin in adults. So generation of these mutations can increase HbF in the patients with homozygous beta thalassemia and sickle cell disease. So several groups have tried to make these deletions and non-deletions. Creating large deletions is very, very difficult because CRISPR-Cas9, there has to be 2 guide RNAs, and these guide RNAs have to simultaneously act on the gene, and it is cell cycle, cell division dependent. So it is very difficult to have large deletions to mimic hereditary persistence fetal hemoglobin deletion type. However, the non-deletion type are point mutations that are created. What the current approach is using a donor and doing a homologous recombination, replacing the sequence in the gamma globin gene with a mutation that can cause HPFH. So there has to be cutting and also pasting. Because of the cutting and pasting, both are involved, this approach is very, very inefficient. And you can get maybe in a very bad CRISPR gene editing using this cutting and pasting, the efficiency may be 1% or so, and it can be increased by using gene editing boosters, the efficiencies to 10 or 20 or 30%. And they all happened in very big labs where they tried different donors and different vectors and using RNP, that is ribonuclease protein. The gRNAs and Cas9 was given as a protein, and a lot of standardization is required to get very high efficiency. So what we thought was, this is the promoter of gamma globin. We thought that we will do a very inexpensive experiment by just do NHAJ. NHAJ is without a donor. The guide RNA will go and cut at the site where it binds. And we thought we designed some 16 gRNAs in gamma globin has 2 promoters. We took one promoter where BCL11A transcription repressor binds. And we made a library of the 6 gRNAs and cloned into a lentivirus vector. We made lentiviruses and then transduced into Hudub cells. There's a lot of work. 16 gRNAs had to be cloned, then they all had to be sequenced, and they all had to be used for making lentivirus vectors, then transduce them into the Hudub cells, then sort the GFP positive cells, then differentiate them to get later stages of erythropoiesis to get maximum level of gamma globin, and do a real-time PCR and see the expression of gamma globin gene. So this is the representation of the promoter, and these orange arrows, they are all the different guides that we use for creating mutations here. I hope it's clear that we are just creating insertion deletion point mutations. We are not creating point mutations using a donor to replace C with T or G with A. We are not creating any specific mutation here. We are just disrupting the promoter sequence here. And surprisingly, what we found was that a region near here, when we did real-time PCR, the significant level of gamma globin expression when we disturb the promoter sequences just by doing NHAJ. And that clearly showed that without doing HDR, that is using a donor to create a very specific mutation, which is very, very inefficient. If you use NHAJ by disturbing the promoter sequence, we can get very high levels of gamma globin. This experiment was recently done. We are in the process of completing this paper with the experiments that we are doing currently with human CD34 cells. This experiment is done in Hudub cells. We are doing it with CD34 cells and transducing them and differentiating them to erythroid cells and see what exactly we are getting. We also made another library for 14 more gRNAs to increase the promoter length, and we have identified 4 more target regions where, when disturbed, they can increase gamma globin expression. We are very, very excited with this data because it's a very highly efficient method. Although we use lentivirus vectors in this strategy by transducing into Hudub cells, we can use, after identifying the specific guide RNAs, we can do RNP by editing human CD34 positive cells, then differentiate them to erythroid cells. And if it's all well, and this is a very good strategy for increasing fetal hemoglobin F, it's very, very efficient. So I'm switching gear here to talk about iPSC-based disease modeling for hematological disorders and for disease modeling and cell and gene therapy. And if you know that I understand there were 2 talks, sorry, I could not attend those talks, and because I had some meetings, I understand there were 2 talks on iPSCs and how they are made and how they work, and for what reasons they can be used in the lab, and also for disease modeling and for cell and gene therapy at the bedside. And I have a lot of collaborators here to mention Dr. Biju George from the clinical side, and Dr. Fauzia, Dr. Anup, and Dr. Alok Srivastava. And on the lab, I have Dr. Mohan and Dr. Sarana Bhavan as collaborators. This just to give you an overview of disease modeling using iPSCs. As you know, that patients' cells can be taken, they can be converted into iPSCs by for transferring 4 transcription factors into these cells, and they can be differentiated to different cell types, and these differentiated cells can be used for studying disease mechanisms and development in biology one can do. And once you get the differentiated cells, they can be used for drug testing, and you can use it for the drug development. And if everything goes on well at cell therapy side, if these iPSCs can be used for gene correction by the CRISPR-Cas9 method, which I said that we are doing it in the hematopoietic stem cells, and the healthy cells that are derived can be transplanted into the mice for into the patient for cell replacement therapy. And I'm not saying that this is therapy that is going successfully for all diseases. For a few diseases, which include some diseases that affect our eye, this method of cell therapy is going on very well. And I'm going to talk about how we are using the iPSC-based disease modeling for cell and gene therapy for erythroid diseases, and also for one of the diseases that affect our bone marrow, that's called Fanconi anemia. And why iPSCs are important for hematological diseases? It's the iPSCs, they give unlimited supply of patient-specific and specific normal and malignant hematopoietic cells. And if a patient has a tumor, the collection of both normal and the malignant cells can be obtained, and they can be converted to iPSCs. And you can have isogenic cells from a patient with a patient's normal cells and malignant cells, which can be used for the comparison. And if iPSCs and differentiated cells, if you know how they're different, it's possible to design drugs, and cell therapy can be advanced. And this is the current hypothesis, the notion that we have in our lab, which is if we take a healthy individual, make an iPSC and differentiate and compare with a patient, take iPSC and differentiate, and you can see the cellular phenotype. And the differentiated cells can be used for transcriptome, proteome, and many other assays. And subsequently, the gene correction, and also we can use them for drug screening. And finally, we'll have cell therapy products. However, one of the biggest problem in using iPSCs for disease modeling is that it's important to have isogenic lines. And you need to have the cells with the same genetic background. If I have an iPSC as a normal control, which was made 2 years back, and then now I make an iPSC from a patient, I cannot use them successfully always for disease modeling, because iPSC to iPSC, there'll be a subtle difference in their phenotypes. And it's possible for some diseases, but it's not possible for many diseases, because there will be subtle difference in the phenotypes. So the current approach in many labs is that make isogenic lines. That is, take a normal iPSC and create a mutation of the gene when defective can cause a disease. Then you have a normal iPSC and a mutant iPSC, then see the phenotype of the differentiated cells. And this is something very, very important to be achieved for using the cells for cell therapy applications, and to study the disease mechanism, to take it forward to cell therapy and drug screening. And other ways is to take the patient's iPSCs and correct it and make it normal. And then you have the isogenic lines with patients' genetic background, and corrected only one place that you corrected, remaining all the sequences, all the mutations, all same. Therefore, the comparison is very, very easy. And these iPSCs, they can be cultured in the hematopoietic medium, and they can be differentiated to hematopoietic stem cell and progenitor cells, and they can be subsequently differentiated to erythroid cells. In the red cell diseases, my lab is interested in diamond blackfan anemia, It's a ribosome biogenesis disorder that affects erythropoiesis, and congenital dyserythropoietic anemia that also affects erythropoiesis. Then also on Fanconi anemia, that is a bone marrow failure disease with pancytopenia. All the lineages, red cells, white cells, and all of them are defective in the patients with Fanconi anemia. So overall, this figure shows that if you take patients PBMCs, that is blood cells and fibroblasts, convert them into induced pluripotent stem cells, then subsequently differentiate them into hematopoietic stem cells. I'm cautiously saying that we get hematopoietic progenitors, we don't get true hematopoietic stem cells from iPSCs. Then they can be differentiated, and this can be used for modeling the disease, and then we can use this differentiated cells for disease mechanism, and we can establish very good protocol for gene correction. Why I'm saying that is because iPSCs grow as colonies. Once it is gene corrected and you seed the cells on a plate, you can pick up the colony, and you can pick up the colony in which gene correction occurred, and you will have 100% gene corrected cells versus any other methods that are used where gene correction to occur in all the cells is absolutely difficult if iPSCs are not used. And when iPSCs are made from the patients, we take the patients and make iPSCs in the lab and bank them, and we fully characterize them to make sure that they all have the real properties of iPSCs. And we make the iPSCs from erythroid progenitors. We take peripheral blood mononuclear cells and differentiate them to get early erythroid progenitors. Then we add 4 transcription factors into this erythroid progenitors. They're episomal vectors, they do not integrate, and finally get induced pluripotent stem cells. And as I said earlier, if we make isogenic lines, that the previous slide which is about how to make iPSCs from a patient with a hematological disease. Here, if you have a normal cell line and it's possible to make mutant iPSCs by gene editing, then you can isolate homozygous mutant lines. And this method is much better than going to the clinic to get the patient, catch hold of the patients, then identify the mutations and find out which gene is defective, then phenotype characterization in cells to show that this particular mutation was causing the phenotype. And that is going to take years if one tries to make mutant iPSCs that way. However, if you create a mutation in the gene of interest, and that gene, if you know that that's involved in disease pathogenesis, then you can pick up the clone and you can make an iPSC. And it's possible to make 10 mutant iPSCs every year for a lab that has an established facility for an iPSC, gene editing and picking up the colonies and making clones. And subsequently, these iPSCs can be differentiated to hematopoietic cells and further differentiated to erythroid cells and see the phenotype. And for this, it's all part of gene therapy and cell therapy. I also have interest in studying the disease mechanisms by creating these iPSCs. We established a battery of techniques where we standardized the gene editing in iPSCs, which was very, very hard, and we could create large number of cells in which they're edited. We standardized the protocol for differentiating iPSCs to hematopoietic cells, then differentiating them into erythroid cells. Then we have also established a very robust method. It's called FACE, fax-assisted cell editing, and using which it's possible to create the mutant iPSCs much faster. And this is to say that a lot of techniques had to be established for disease modeling and for using this iPSCs for efficient gene editing for cell and gene therapy. And for disease modeling, one of the technique that, or the reagent that we developed in the lab was to express the Cas9 protein that helps in the gene editing from the AAVS1 safe harbor site. And we made a line in which the Cas9 is expressed from the AAVS1 site. When you add doxycycline, the Cas9 is expressed within the cells. So when dox is not added, doxycycline is not added, Cas9 is not expressed. So it does the gene editing, and when the doxycycline is withdrawn from the medium, Cas9 expression disappears, and gene edited cells will survive without the Cas9 expression in the cells. And it's very robust. You can see here in the different clones of these lines that we made. When doxycycline is not added, there is no Cas9 expression. And doxycycline is added, we can see a robust expression. All the 3 clones, this is what we found. And every clone, we did a immunofluorescence and looked under the confocal microscopy. We could see that all the cells are expressing Cas9. And this immunofluorescence was done with an antibody against Cas9 protein. And we can see the result here that when a target gene in MIR182 was targeted using a gRNA that creates a mutation in the 182 region and 183 region, you can see it's a complete mutation creation at these 2 sites using Cas9 when it is expressed in the safe harbor site. So currently we're using this line to create these mutations in many, many genes so that we'll be able to create a lot of disease models in the lab. And these disease models, iPSCs, can be differentiated and they can be used for studying the disease mechanism. Subsequently, that leads to drug screening and cell therapy. And this is one of the diseases. I think we're going to run short of time, and I'm not going to the basis of this disease. And it's a very important red cell disease that we chose. And currently we do not know the exact mechanism through which this disease happens in the patients. And it happens in a protein called SEDAN1, and we do not know the exact function. But when the mutations are present in this gene, the patient gets erythroid disease and no other cells are defective. Similarly, there's congenital dyserythropoietic anemia type 2. It occurs in the protein secretory pathway between ER and Golgi, and it's a very important gene with its mutations. When it occurs, it affects only the erythroid cells. No other cells are defective, and therefore it's very, very important to study. This is a method, as I said, the PHASE method, which we created to study the congenital dyserythropoietic anemia by creating mutations in codanin gene and Sec23b gene. This is a very efficient method from where we clone a donor which has got homologous arms to target into codanin gene, and the mutation will be created into the donor sequence. Because the donor sequence carries fluorescent protein, and you can do flow cytometry and you can create the double positive cells which express GFP and D tomato. Then you get homozygous. Then remove this cassette by using transport skills, and it's a very efficient and faster method. This is just show you that we got large number of iPSCs in which D tomato targeting one copy of codanin and GFP targeting the other copy of codanin, making homozygous mutant lines, and they've been characterized, and we are doing hematopoietic differentiation and erythroid differentiation to study this disease better. And it is very, very important to study this particular disease because we do not get enough number of erythroid cells in these patients. Using iPSCs, we may be able to get enough number of erythroid cells to understand the disease mechanism. And this other disease that we try to study is Diamond-Blackfan anemia, which disease that affects the ribosome biogenesis, and ribosomes are important for protein translation. The genes that are involved are most of the mutations for Diamond-Blackfan anemia occurs in the ribosome proteins, and you can the RPS19 is the most effective one. And when the disease occurs, the patients have severe anemia. Again, only red cells are defective and none of the other cell types are defective, and the patients may have other phenotypes. But the patient's major problem is anemia right from the birth. And this is normal erythropoiesis, the erythroid differentiation that happens. In the patients with the DBA, there's a significant arrest here. And beyond blast forming unit, BFUE cells do not differentiate. And that is a typical feature of diamond-blackfan anemia. And as I said earlier, why the mutations when they're present in the ribosome protein, ribosome biogenesis proteins, when they're present in the ribosome biogenesis proteins, why only erythropoiesis is defective? And we did a lot of studies on this, and we realized that when we tried to make isogenic lines by creating mutations in the ribosome biogenesis genes. Hello? It's time to stop?
No, you continue, sir. Please continue.
Yeah. So we had a severe, we had a problem. That was when we tried to create heterozygous or homozygous mutations in the iPSCs, we could not make. Unlike the mutation, when we tried to make mutations in the other target genes, that clearly showed that mutations, haploinsufficiency, that means when the heterozygous mutations cannot be tolerated by iPSCs also. And not only erythroid cells, even iPSCs also cannot create heterozygous. We tried different methods using RNP, we're using lentiviral vectors, different methods. In all methods, we could not make mutations in the iPSCs for targeting the genes associated with the diamond-blackfan anemia. And that we realized because we should not target the genes that are important for the iPSC cells to survive. And that was a mistake. But however, in the congenital dyserythropoietic anemia, the few slides that I showed earlier, we could make mutations, but in DBA, we could not. Therefore, we went to a patient that we had to go back to strategy 1, that is taking cells from the patients and converting into iPSCs, and we could make iPSCs from a patient with DBA. A lot of interesting observations we had from these experiments. One of them we found was it's very difficult to get enough number of iPSCs from patients with DBA. We had only 2 clones, and they had a lot of problem in survival that was correlating with the previous finding. And we have a lot of data on it by small molecule screening that clearly showed that these iPSCs can survive better in the presence of one of the small molecules that affect signaling pathways. And these iPSCs from DBA have taught us many important findings, important messages, and we learned one of them is that we should not target a gene that is important for iPSCs to grow, and 2, haploinsufficiency of ribosomal biogenesis genes, and that can affect not only erythroid cells, also iPSCs. And when we made iPSCs from a patient, strategy 2, strategy 1, that is starting from the patient, we found that they do not grow very well unless we add one particular small molecule that we identified in the lab. And that particular small molecule, we are currently using them for in differentiating, for culturing CD34 positive cells, hematopoietic stem cells from the patients with DBA. So the last part, which I'll rush through, is how we made HSPCs, that hematopoietic stem and progenitor cells from iPSCs. It's a very important technique to study. It's to establish, because we want to study red cells. Therefore, iPSCs should be differentiated to hematopoietic stem and progenitor cells, and subsequently differentiated to erythroid cells. This is to give you an idea. The last figure, you can see the lot of round cells, which is coming from the iPSC, saying that we can make had large number of HSPCs in the lab. And we had very interesting findings from here, 2 different populations of HSPCs we found. And when we did RNA sequencing and showed that they have different properties, this is an important finding which we'll be publishing soon. And in the clinical, in the cell therapy and the drug screening, it was important to get this message that how many different types of progenitors are can be produced from the iPSCs. Transcriptionally, these HSPCs are different. And when we try to make this HSPCs from a patient with the DBA, iPSC from a patient with the DBA, there's significant reduction in the number of HSPCs that are produced from a patient with DBA. When this particular small molecule that I said that can increase the reprogramming efficiency, also increase the percentage of the hematopoietic stem and progenitor cells. It clearly indicates that this small molecules, which is currently being used for treatment of some other disease and may be used for treatment with DBA. And we improved this method by adding 5 more transcription factors to get much more robust hematopoietic stem and progenitor cells from the iPSCs. Now, this is based on a publication from George Daly's lab, where 5 more transcription factors when they're added, and they can get hematopoietic stem cells instead of hematopoietic stem and progenitor cells. Now, these cells can be transplanted into mice. We modified this protocol. We had to modify it because we are trying to make a lot of iPSCs for disease modeling. We transduce iPSCs instead of hematopoietic stem and progenitor. I know I'm talking a little faster, but if you have some questions, I will answer that later. And what we found was this very high proliferation of hematopoietic stem cells from the iPSCs now. And you can see here that after adding the 5 factors, when doxycycline is added in the medium to induce the expression of these 5 factors, we get large number of colonies. And this is an important experiment. Those who are working in hematopoietic stems will know, if different colonies are formed, that means they are getting stemness. So you can see here, after adding it, you can get large number of colonies being formed. I will stop here because I have few more slides to go, and it is 3 o'clock. Yeah, thank you.
Thank you, Dr. Shaji. I have a question about that iPSCs. When you introduce a mutation, it's not able to be viable. Heterozygous. So it's a dominant negative. Is that what it is?
Yeah. So we say haploinsufficiency when the mutation is there in one gene that can cause the disease. Right.
Okay. Okay. So the cell will die.
Correct. Only for some genes. I'm not saying it occurs for all the genes. This is our observation for the ribosome biogenesis genes.
Okay. Okay. Dr. Thamishari, madam?
Yes, sir. Thank you, Professor. Large amount of data you've discussed about the viral vectors and about induced pluripotent stem cells. I think it can prove helpful as well as beneficial to the people working in this area. So if there is any question, Dr. Devi Rajeshwari?
Yes, madam. Yes, madam. Yeah. Dr. Shaji sir, thank you, sir. Your presentation was very nice. So one question from Ravi Shankar. Tell about importance of stem cell donation, particularly treating blood-related disorders.
I think Dr. Biju had extensively covered about hematopoietic stem cell transplantation yesterday. And there are donor registries now for hematopoietic stem cells. And if you give your buccal cells, and that will be taken and HLA will be determined, and your HLA will be matched with the patient anywhere in the world, and you may become a donor. If that answers your question. Okay, so stem cells can be donated for hematopoietic stem cells. Yes.
Right, madam. Next question, madam.
Any other question, madam?
I think sir, it's not come. Any other questions from participants?
Okay. Dr. Shaji, with iPSC technology, you missed yesterday's talk by Dr. Deepa Bhartiya.
Okay.
He, in fact, actually is questioning this whole the Nobel Prize work from Yamanaka. She opines that when the fibroblasts were de-differentiated, she feels there are some VSELs which are contaminants of the fibroblasts. You want to comment on that? Because I'm sure you'll be going through the cleanup when you have the starting population of fibroblasts. She opined that when Yamanaka started off with the fibroblasts, she opines that there may be some contaminants of very small embryonic-like stem cells.
Right. So, Dr. Deepa may be right, and she is a very experienced scientist. However, when we try to make iPSCs from fibroblasts or blood cells, and when we make iPSCs from any part, liver cells, it may not be possible that VSELs present in all these cell types are responsible for reprogramming to occur. And there are a lot of studies done in many groups clearly shown that when after transducing the fibroblasts, they have seen the markers that these cells acquire before becoming iPSCs. Cells are taken at different stages and confirmed that these transcription factors are going up, and embryonic stem cell transcriptome is going up, and it's clearly shown that. So she may be having a scientific reason for it, but that is not what many people find, and that's not what we also find.
Oh, yeah. Thank you. Because we routinely teach our students about iPSCs and about Yamanaka's groundbreaking work. And the concepts presented by Dr. Deepa Bhartiya maybe like revolutionizing the whole thought process and to make the academicians rethink this through before imparting knowledge about iPSCs. So I think I want to thank you for the clarification.
Yeah, just to add on that, there was a paper which came from a big scientist in hematopoietic stem cells. He thought that VSELs existed, and subsequently he proved that they do not exist. So there is a lot of controversy here, but I know that Dr. Deepa Bhartiya has done a lot of studies to prove that they do exist.
All right. Thank you, Dr. Shaji. If there are no other questions, I want to, on the behalf of the organizers, I want to thank Dr. Shaji once again, not only for this talk, but also helping out in terms of conceptualizing this whole two-day event, helping out with identifying resource persons. And I know you've been extremely busy. We have been in touch via WhatsApp. And thank you, Dr. Shaji.
One more question has come, sir, now.
Okay.
So,
Go ahead.
Considering the HLA ethnicity in our country and limited in finding an unrelated donor, either bone marrow or through cord blood, do we need go to further on haploblocking and by identify the HLA haploids and also HLA locus frequencies?
Okay, that is a very important question. I think I had given a couple of talks on this haplobanking at BIT when Dr. Suresh invited last 2 times. So I will just tell that you are right, that it's very difficult to get a matched donor, relatively more difficult to get a matched donor, so matched unrelated donor. Okay, in the family, it is easier because in India, the frequency of these HLA types are diverse, unlike what we observe in Japan and many other countries. In Japan, it's 5, 6, or 10% of the HLA haplotypes will constitute more than 80% of individuals. So in India, it is difficult. However, it is not impossible, and we do not have any option there. And I cannot give a talk on cord blood here because there are several reasons for the misuse of cord blood that happened a couple of instances. And I'm not a clinician, I'm I'm PhD, so I do not want to talk about that part of cord blood and its transplantation.
Thank you, Dr. Shaji. We'd like to end by thanking our chairperson, Dr. K.V. Bhaskar Rao. Amidst his busy academic schedule, he found time to be with us and chair the session. Thank you, Dr. Bhaskar Rao.
Thank you, sir.
And also our thanks to Dr. Devi Rajeshwari for taking care of the Q&A.
Thank you.
Thank you. Thank you. Now, Dr. Tamil Selvi, madam.
Thank you, sir. So shall we move on to the next session? And
yes, now it's about 3:10. Our session is scheduled to start by 3:15. If you wish, you can start right away. Dr. Ramesh is here, and Dr.
Yes.
Mohan Srinivasan is also here. Okay. Good afternoon once again. This is actually the last talk for this conference, after which we'll have a session on concluding remarks made by the organizers, and then we request for feedback from selected participants.
So your voice is not audible.
Voice is not audible, sir. Now is it audible?
Yeah, it's fine. It's clear.
Yes, sir. I warmly welcome the chairperson for today's session, Dr. Mohan Srinivasan. Welcome, sir.
Hi, sir.
And I also welcome Dr. Ramesh Pati, who will be taking care of the Q&A. Dr. Ramesh Pati?
Yes, sir.
Very good.
Very good.
Now over to Dr. Mohan Srinivasan. He will be talking about the profile of Dr. Arts Tamil Selvi. She is faculty from VIT. She is also an organizing secretary in this conference. Over to Dr. Mohan Srinivasan.
Thank you, sir. Good afternoon to one and all present here. I welcome you all for this final session of the two-day virtual international conference on update on stem cells and industrial perspective future challenges. With immense pleasure, I would like to introduce the speaker of the session, Dr. Tamil Selvi. She completed her PhD at the Department of Biochemistry in University of Madras, Guindy campus. She started her career as a lecturer in Ethiraj College for Women and Savita Dental College in Chennai. Following this, she worked as a research associate in the National Institute of Immunology, New Delhi, where she worked on beta HCG vaccines. She then moved to National University of Singapore for postdoctoral research. She got into inflammation research group and studied the molecular mechanism involved in the inflammatory diseases such as acute pancreatitis, sepsis, and burns. She received grants from ICMR and DST. She also received FAO BMB Young Scientist Award and Research Fellowship Award from R.D. Birla, Kush, Mumbai, India. She also has the stem cell experience by developing stem cell therapy approaches for acute pancreatitis. Her research has been published in several impactful journals. She has also published several book chapters and review articles and presented in several national and international conferences for oral paper and poster presentations, and some of which have won the Best Paper Awards. With this short introduction, I would like to invite Dr. Tamil Selvi to speak on the stem cells and acute pancreatitis. Over to you, ma'am.
Yeah. Thank you, Professor Mohan Srinivasan, for that introduction. And I would like to thank Professor Suresh for giving me an opportunity to present in this stem cell conference. Yeah, I'm mainly working on acute pancreatitis. So acute pancreatitis is an inflammatory condition of pancreas. So we are using in vivo and in vitro animal models to study the molecular mechanism involved in this inflammation and to improve the therapeutic efficacy. Right, so mainly I'm focusing on the molecular mechanisms of acute pancreatitis, right? So it's an inflammatory condition of pancreas. So we'll see what is the inflammation. So if the tissue it has been explained in 6 steps. So the inflammation is, if the tissue is compromised, then the homeostatic state has been disturbed and leads to inflammatory cues. The damaged cues have been activated. The signaling mechanism has been activated. So when the signaling mechanism is activated and while breaching off the homeostasis, so the resident macrophages will be activated. Both morphologically and also functionally, they'll be activated. So these resident macrophages, they'll release the pro-inflammatory mediators like TNF-alpha, IL-1 beta, TGF, and IL-6. Even the chemokines like MCP1 and RANTES will be released. So this is also activates the complement system, which will call in the peripheral immune cells. So these immune cells like neutrophils and monocytes, so they also release additional pro-inflammatory mediators into the microenvironment. So they also partake in the resolution of inflammation by releasing the anti-inflammatory mediators. Okay. So these pro-inflammatory mediators and then the anti-inflammatory mediators, they influence the stem cell and also the progenitor cells. So all the intrinsic signals and the extrinsic cues will activate this or regulate the stem cells and the progenitor cells. So these cues, they decide whether the stem cells has to differentiate or they have to self-renew. So the interplay between the inflammation and then the stem cells is very important.
Madam, there's some dragging of
stem cell mechanism is very important.
There's some.
Is it clear now, sir?
Yeah. Now you please go ahead, madam.
Can you hear me now, sir? Is it clear?
Maybe switch off the video, ma, and the bandwidth is pulling.
Okay.
So if switch off the video, the bandwidth may be okay.
Okay, sir.
Now, okay, ma. Go ahead, please.
Okay, can you hear me? Okay. So there is an interplay between the stem cells and the inflammation. So the molecular mechanism of the stem cells in the inflammatory condition is very important for the regenerative therapies. Okay, pancreas is also a vital organ. Often it is being overlooked. See, if the inflammatory condition in pancreas is not being cured, then your blood sugar level won't be under control and the digestive system will be affected. As this pancreas has 2 parts. One is the exocrine part, the other one is the endocrine part. So the endocrine part where the beta cells will secrete insulin and it is involved in regulating the blood sugar level. Whereas the exocrine part, which has the acina cells, and these acina cells express the digestive enzymes like lipase, amylase, and proteases. So these enzymes are released into the intestine and helps in the digestion of the food. Okay. So if this is being affected, like if the enzymes premature in the pancreas, then it will digest the pancreas. So when these enzymes are released inside the pancreas at the premature state, it could be because of different initiating factors. One could be because of the very common cause is because of the gallstones in the gallbladder, and another common chemicals present in the cigarette and hereditary disease, where if there is any mutation in the trypsinogen gene or the trypsin inhibitor SPINK can also lead to acute pancreatitis. So when these enzymes are prematurely activated inside the acinar cell, then it will, if this attack is being repeated several times, eventually it will end up with the inflammation in the pancreas. So this will lead to a spillage of these immune cells into the circulatory system, and then it can lead to systemic inflammatory response syndrome. And that leads to multiple organ dysfunction syndrome and mortality and regeneration where the stem cells are being involved. And usually it is with the severe upper abdominal pain associated with fever and vomiting. And this acute pancreatitis is being commonly associated with acute lung injury. And sometimes also kidney failure, and even it affects the intestine. So currently there are no therapeutic remedies for this disease. So it can only be managed, the symptoms can be managed. So the severe acute pain can be relieved by non-steroidal anti-inflammatory drugs, and by giving antibiotics, the infection can be prevented. And like supplementary therapies like digestive enzymes and multivitamins have been supplemented for this disease. And sometimes surgeries were undergone to remove the bile duct obstruction and also remove the fluid accumulation and also the scar in the pancreas. So as a curative therapy, as the mortality rate has been very high, so all of these urgently need use to find a new direction or a research idea. So at present, mesenchymal stem cells have been used in the animal models, and it is yet to reach the clinical trials. And only very few animal models have been done with the mesenchymal stem cells. So in exocrine pancreas, a study has reported in 2007 that there are no stem cells or rare stem cells in the pancreas. So this was being mentioned, I think, by Dr. Bhatia. She said that the pancreas has VSCLs, that is very small embryonic-like stem cells. Maybe the pancreas might be having this. Yeah, still it's been controversial. But according to this report, they say there is no stem cells in the pancreas. And another study also reported that there is no, it was done in 2010, and he also reported there are no stem cells in the pancreas. And they identified that the pancreas stem cell-like cells in the adult pancreas, and these stem cells they were been expressing OCT4 and SOX2. And might be these stem cells have been originating from the bone marrow, and they participate in the repair of the pancreatic injury. And interestingly, another study also reported that biliary tree could be a reservoir. So actually, there is a network between the biliary tree and the pancreas, both anatomically and also functionally, and they have the it comprises the lineages that helps in the formation of pancreatic organogenesis. It is involved in the pancreatic organogenesis. And they identified that the pancreatic progenitor cells, that is the centroacinar cells, and the terminal ductal cells are from these biliary tree. So these centroacinar cells and then the pancreatic ductal cells, they express SOX9, STF, and nestin, and also notch signaling mechanism is involved. When they isolated these cells, and these are identified as the candidate pancreatic progenitor cells that can get differentiated into exocrine And about mesenchymal stem cells, like other speakers were also been discussing about this mesenchymal stem cells. Are they the stem cells, or they are the paracrine providers, right? So these mesenchymal stem cells were being rich sources, and they can be isolated from bone marrow, adipose tissue, placenta, and also amniotic fluid. They can self-renew, and they are multipotent cells. They can differentiate it into many type of cells, but not to all type of cells. And they can be mobilized from the bone marrow to the injured site. And they have the immunomodulation and tissue repair properties. The immunomodulatory effect of this mesenchymal stem cells on the secretion of various anti-inflammatory molecules. And these anti-inflammatory property of mesenchymal cell was being considered to be effective in the treatment of acute pancreatitis and also in chronic pancreatitis. So, since cell therapy for stem cell therapy for treating acute pancreatitis, they've used the experimental models, like serine-induced experimental models have been used to treat, to study the effect of stem cells in acute pancreatitis. So mesenchymal stem cells were being isolated from bone marrow, human bone marrow, and also mouse bone marrow was also being used, and also the mesenchymal stem cells which has been isolated from umbilical cord and also from adipose tissue were being used. So this mesenchymal stem cells were being labeled with the CM11 dicodecyl, and it is called a CM-DIL labeled mesenchymal stem cells. So first the animals were being injected with cerulin to induce acute pancreatitis. So it was a 2-hour interval model which has been used to induce acute pancreatitis. And then this mesenchymal stem cells were labeled mesenchymal stem cells were being injected in the tail of the mice. And animals were being divided into 3 groups. One is control, the other one is the AP group, the other one is AP group, which is being treated with human clonal mesenchymal stem cells. And then they did all the markers, like I haven't shown those figures here. They did the histopathological studies for the pancreas, and they checked all the markers, that is AP markers like amylase, lipase, and protease were being checked. So in AP mice, all these markers have been upregulated that confirm that acute pancreatitis, that is inflammation in pancreas, has been induced. And when it is being treated with HSC mesenchymal stem cells, all these markers have been downregulated. And even in the histopathological studies, sorry, I think, yeah. In the histopathological studies, you can see there is increased edema formation and infiltration of the neutrophils and necrosis of the acinar cells. These have been reduced in the MSC treated AP mice. And they also tracked the mesenchymal stem cells, and they identified that more of the mesenchymal stem cells were being mobilized to the pancreas, both in the mild pancreas and also in the severe acute pancreatic condition. So when the distribution of this mesenchymal stem cell in various tissues were also being studied. So the most of these stem cells has mobilized to the pancreas when compared to lung, liver, spleen, and kidney. The cells have mobilized to other tissues, but most of the MSCs were being identified only in the pancreas. So they elevated the disease severity by decreasing the infiltration of the neutrophils into the pancreas. And they also downregulated the anti-inflammatory markers like TNF-alpha, IL-1 beta, IL-6, and IL-4 when compared with the mild and severe acute pancreatitis mice. And IL-10, which is an anti-inflammatory marker, which was being downregulated in AP mice when treated with mesenchymal stem cells, were found to be upregulated. So this shows that the inflammatory response is being downregulated by the mesenchymal stem cells. And the T cell expression, so it inhibited the infiltration of with this immunohistochemistry shows that more AP mice pancreas, but whereas when treated with mesenchymal stem cells, you can see that CD3 plus cells, that is T cell infiltration, has reduced in the mesenchymal stem cell treated pancreas. And the expression of FOXP3, which is a regulator of T cell, so which downregulates the T cell infiltration, was found to be less in AP mice pancreas, whereas it has been increased in MSC treated pancreas. And another study, they reported that the antioxidant level, like superoxide dismutase and also malondialdehyde level, malondialdehyde is a lipid peroxidation marker. So when there is a inflammation, the lipid peroxidation level increases. So in the SDOC group, that is in the AP group, this malondialdehyde level increased after 1 hour, 4 hour, and 10 hour. But whereas when it is being treated with mesenchymal stem cells, this MDA level has decreased. And even superoxide dismutase, which is an antioxidant, level has decreased in the AP mice, but when it is being treated with MSCs, all these antioxidant level have been increased. So actually the mesenchymal stem cells has improved the microenvironment. It is regulating the microenvironment. It is releasing more of the anti-inflammatory mediators and also the antioxidants that could help in the regulate the regeneration of stem cells. And here the apoptosis, they've done an annexin 5 binding study to show the apoptosis of the acina cells. So these are the control cells where there is no apoptotic cells, but when it is been on the day 1, day 3, and day 5 in the AP mice, you can see increased number of apoptotic cells. But when it is being treated with mesenchymal stem cells, these apoptotic stem cells were being, these apoptotic cells, acina cells, were being reduced from day 1, 3, and then 5. And they also checked the STF1 protein role when the animals have been treated with mesenchymal stem cells. So this STF1 alpha is a chemokine, and it regulates the CXCR4, which is a chemokine, and the CXCR4 receptor. They both are involved in the migration of the stem cells from the bone marrow. So when they were being treated with the STF1, the cells are treated with STF1, the STF alpha expression, you can see the expression of CXCR4 when treated with STF1 with different concentration, that is 10 nanogram per ml and 100 nanogram per ml. So when treated with the STF1 alpha, the CXCR4 expression was increased. But when CXCR4 antagonist AMD310 was used, then the so this shows that there is an association between STF1 alpha and CXCR4 receptor. And so this is also associated with STF1 alpha is also been associated with angiopoietin and VEGF, which is involved in the formation of blood vessels. So when the pancreatic tissue, the acina cells are being damaged, hypoxia-inducing alpha-1 alpha has been overexpressed. So that will activate STF1 alpha. So this activation of STF1 alpha will overexpress angiopoietin 1 and also VEGF in association with CXCR4. So here you can see the upregulation of angiopoietin 1 and VEGF in the presence of SDF1 at 10 nanogram and with 100 nanogram per ml. But when it is being treated with the CXCR4 antagonist, so there is a downregulation of this angiopoietin 1 and VEGF. So this is the Western blot study for CXCR4, angiopoietin and VEGF. And even the tube formation has also been studied. Here you can see that when it has been treated with SDF1, so the tube formation is being increased, and with 100 nanogram per ml also it is being increased. But when it is being inhibited by using angiopoietin 1 siRNA and VEGF siRNA, the tube formation has been reduced. Yeah, this slide shows the, this is another study where they have labeled the mesenchymal bone marrow mesenchymal stem cells with superparamagnetic iron oxide nanoparticles. So when they have been labeled with this, it further increased the proliferation of the mesenchymal stem cells. So this figure shows the increased proliferation of the mesenchymal stem cells when treated with SPION labeled bone marrow mesenchymal stem cells. And here, the CXC4 expression was detected by immunofluorescence and then with Western blotting. So with the CXCR4 expression was detected both in the unlabeled BMSCs and also with the labeled BMSCs, but there is no difference. So both of them, they express equally the CXCR4 gene. And even Western blot also, there is no significant change between the CXCR4 expression both in the bone marrow stem cells and also SPION labeled bone marrow stem cells. So this labeling has helped to find the migration of the bone marrow stem cells into the pancreas and also into the lung. So from day 1 to day 10, it has been shown here. So the migration of the mesenchymal stem cell, that is SPION labeled mesenchymal stem cell, increased from day 5 to day 7 and then day 10. When antagonist is being used, for CXCR antagonist is being used, so the migration when compared to day 7 and day 10 has been decreased when an antagonist is used both in the pancreas and also in the lung. So this mesenchymal stem cells also alleviated the extra pancreatic damage, like it alleviated the injury in the small intestinal mucosa. So you can see the intestinal mucosa injury score in the SAP group, and then the proliferating cell numbers in the severe acute pancreatitis group on day 6, at 6 hours, 24 hours, and 72 hours. So the injury has been increasing from 6 hour, 24 hour, and then it's decreasing at the 72 hours, and proliferating cells were also been increasing. Whereas when it is being treated with mesenchymal stem cells, see the injury score has decreased when compared to the SAP group, and then the cell proliferating number of cells have been increasing from 6 hours to the 72 hours. So it helps the mesenchymal stem cells. It's not only migrating to the pancreas, but it is also migrating to the small intestine, and it helps to alleviate the damage in the intestine. Yeah, mostly acute pancreatitis has been associated with lung injury, and this is the first organ to get affected with in acute pancreatitis. Here you can see the infiltration of the neutrophils, edema of the and this is severe acute pancreatitis after 3 hours, 6 hours, and after 12 hours. So when treated with mesenchymal stem cells, you can see that the condition has been improving from 3, 6, and also in the 12 hours. And they checked through pro-inflammatory mediators like TNF-alpha, pulmonary TNF-alpha, and also substance P. So you'll know TNF-alpha is a major pro-inflammatory mediator which is involved in lung inflammation. And substance P is a preprotokinin. So the substance P is a neurotransmitter which plays an important role in the pancreatic and also lung inflammation, which is normally overexpressed in acute pancreatitis. So this mesenchymal stem cells, when migration of these mesenchymal stem cells to the lung has reduced the expression of TNF-alpha and also substance P, so that by alleviating the injury in the lung. So these are the studies which have been done in acute pancreatitis. Only animal models have been done in acute pancreatitis by isolating the mesenchymal stem cells from bone marrow, umbilical cord, and adipose tissue. So MSC can be used as a candidate for severe acute pancreatitis therapy. So it has decreased when treated with bone marrow derived mesenchymal stem cells. It decreased the mortality rate and the serum level of amylase, lipase, and proteases. And it promotes apoptosis of CD+4 T cells, and it downregulated the CD3+ T cells and increased the expression of FOX3+ regulator of T cells in the pancreas. And also it protected the pancreatic acinar cell by inhibiting the necrosis, and also the injury to the small intestinal epithelium and renal interstitial capillary endothelial barrier damage. And it downregulated the pulmonary edema by downregulating TNF-alpha expression. And also it overexpress the anti-inflammatory markers like IL-10 and TGF-beta, and also the antioxidants like superoxide dismutase and glutathione S-transferase. Umbilical cord-derived mesenchymal stem cells. The serum amylase level, again, the markers of acute pancreatitis were being downregulated, and also the pancreatic and pulmonary tissue injury were being markedly elevated, and even the histological score of fibrosis. And adipose-derived mesenchymal stem cells, they release the pro-inflammatory cytokines, and it inhibited the release of the pro-inflammatory cytokines, whereas it increased the release of the anti-inflammatory cytokines and elevated the inflammatory condition. Yeah, next, we are mainly focusing on hydrogen sulfide, the role of hydrogen sulfide in acute pancreatitis in our lab. So H2S has been, it is a gaseous mediator. So this gaseous mediator is being synthesized from L-cysteine by cystathionine beta synthase and cystathionine gamma lyase. H2S in the pancreas is being synthesized by cystathionine gamma lyase. So this H2S during the acute pancreatitis, this H2S is being overexpressed, and it acts as a pro-inflammatory mediator. But when H2S has been given exogenous, this is endogenous H2S, and it has been given exogenously, it protects the inflammatory condition. It alleviates the inflammatory condition. So that could be due through the transsulfuration pathway. It is producing the antioxidants and it is protecting the tissues. So the role of H2S is being studied in several inflammatory conditions, and also in bone marrow mesenchymal stem cells, they produce H2S in order to regulate the self-renewal and also the osteogenic differentiation, and H2S deficiency results in the defect of bone marrow mesenchymal stem cell differentiation. And increased proliferation of neural stem cells in the subventricular zone in the mouse model of Parkinson's disease has been reported. And enhanced murine hematopoietic stem and progenitor cell migration, homing and proliferation is also reported. And it is a paracrine mediator that is resulted from mesenchymal stem cell to facilitate both angiogenesis and also vasodilatation. And by using natural donors, H2S donors, the biochemical factors that promote mesenchymal stem cells, and they also increase the safety profile and efficacy after transplantation. So this work where we use the cerulean-induced mice model, divided the animals into 3 groups. One is the control, and AP-induced mice, and AP-induced mice which is being treated with the H2S donor methyl sulfonyl methane. And elevated the disease condition, it reduced the inflammatory markers like TNF-alpha, IL-1 beta, so it overexpresses IL-10 when treated with H2S donor. And even the hepatic markers like amylase, lipase have been decreased when treated with the H2S donor. So here the CD34, we check the CD34 cell expression. So this is the marker CD34 cell expression, is a marker for hematopoietic stem cells and the progenitor cells. So when we did immunohistochemistry, both in the pancreas and the lungs, so in the control pancreas and lungs, there was no CD34 expression, but in the AP mice, we can see the CD34 expression. You can see the red granules, brown granules in the pancreas and the lung. But when treated with the methyl sulfonyl methane, which is an H2S donor, there is increased expression of this CD34 expressing cells, both in the pancreas and also in the lung. So this H2S, which is involved in the mobilization of the CD34 expressing HSC or the progenitor cells from the bone marrow to the pancreas and also to the lungs. It's an in vitro study where we worked with the mesenchymal stem cell condition bone in a DMEM medium. And this medium was collected, MSC's grown medium, that is Wharton's jelly mesenchymal stem cell, grown medium was being collected. And this is the conditioned medium harvested from the cultured cell. And this medium contains the growth factors, extracellular matrix protein that is being secreted into the medium by the MSCs. And other cytokines and the growth factors were also being released into this conditioned medium. And we used this conditioned medium and treated the LPS-induced raw macrophages, which is an in vitro inflammatory condition treated with the conditioned medium. And then we thought propargyl glycine, which is an inhibitor of H2S, and also the expression of the pro-inflammatory mediators, and also the NF-kappa B level. So here in LPS treated macrophages, there is overexpression of TNF-alpha, the pro-inflammatory mediator, and then the downregulation of the anti-inflammatory. Treated with conditioned medium, the LPS-treated macrophages were being treated with the conditioned medium. So we took 1 ml, 2 ml, and 3 ml of the conditioned medium to treat the LPS-treated raw macrophages. So the results, what you have shown here is when the cells were treated with 1 ml of conditioned medium. And we also did the MTT assay to standardize the dosages for MSM and propargyl glycine. So when it has been treated with the conditioned medium, see this LPS TNF-alpha level has decreased when compared to the LPS group, and IL-10 level was increased when compared to the LPS group. And when treated with MSM also, it increased, and also with the H2S donor MSM and H2S inhibitor propargyl glycine, both increased the level of the anti-inflammatory mediator IL-10 and downregulated the TNF-alpha expression. When treated with conditioned medium and propargyl glycine, which is an inhibitor of H2S, so you can see the TNF-alpha level is increasing when compared to the conditioned medium treated cells. And again, the IL-10 level is also decreasing. Maybe this could be that the conditioned medium, if the H2S level in the conditioned medium is being blocked, then the protective effect of the conditioned medium is being decreasing. So this indicates that the protective effect of this conditioned medium could be through H2S. And when treated with MSM, again, it increased, but when treated with the H2S inhibitor pack, again, it has been downregulating the IL-10 level and increasing the TNF-alpha level, which further confirms that the protective effect of the conditionation of IL-10 and TNF-alpha. And we have done I-kappa B alpha and also NF-kappa B binding assay. So here also this MSC conditioned medium and MSM have an anti-inflammatory effect in LPS induced inflammation through I-kappa B and also NF-kappa B signaling pathway. So the overall relationship of mesenchymal stem cells therapy for acute pancreatitis could be due to the antioxidant capacity and immunoregulatory capacity and decreasing apoptosis and reducing the necrotic cells in the pancreas by increasing the anti-inflammatory cytokines like IL-4 and IL-10 and reducing the pro-inflammatory cytokines and activating the T regulatory cells, inhibiting the T cells, so it can decrease the necrotic inflammation induced by the prematurely activated enzymes in the pancreas, and it can also downregulate the pro-inflammatory cytokines released into the circulatory system, and it could inhibit systemic inflammatory syndrome and also multiple organ dysfunction syndrome. Although stem cell transplantation to patients with acute and chronic pancreatitis has not been performed, and it's in the initial stage, only the animal models have been done. So some problems are yet to be overcome in these studies. So there is still a distance from the animal research to the clinical application. And one is the necrotized pancreatitis has not been fully repaired. Only in the early phase, it shows a protective effect, but at the later stage, it doesn't show any protective effect. And also the safety of the bone marrow mesenchymal stem cell transplantation still needs to be tested. And then the occurrence of pulmonary embolism and venous thrombosis need to be further evaluated. And in vivo, the cell survival rate, the time still need to be improved for the bone marrow stem cell transplantation, and the safety should also be considered for the BMSC transplantation. But from these studies, it is clear that stem cell transplantation might be a promising therapeutic approach for both chronic and acute pancreatitis in the very near future. And with this, I stop here.
Thank you, Dr. Ramashelvi, madam, for a good talk. I request Dr. Mona Srinivasan to take over.
Yeah. Thank you, sir. Thank you, ma'am, for your such a wonderful and informative presentation. Now the session is open for discussion.
Dr. Ramesh Pati,
yeah,
handling the Q&A.
Yes, sir. There is no questions as of now. If there is something popping up, I will surely let you know, sir.
Okay. Madam, can I ask a question?
Yes, sir.
In one of the slides, I saw apoptosis of CD4 T cells following MSC. Would you want to comment on that?
Yes, sir. See, they are reducing the T cells T cell response, so that the they won't reject the mesenchymal, the cell transplantation. But by reducing this T cell, the FOX3, P3 regulatory cells have been overexpressed, so that it will regulate the immune rejection of the bone marrow stem cells. So that is why they are using mesenchymal stem cells for cell therapies.
More immunosuppressive phenotype.
Yes, sir. More immunosuppressive phenotype.
I mean, but that should not be a generalized phenomenon, because we need a robust immune system to ward off infectious agents.
Exactly, sir. More, but it's only in the initial stage. More work has to be done on this area.
Okay. So what would be the route of administration of these MSCs?
So here in this animal model, they've injected through the tail vein.
Any possibility? I mean, what about the cells getting lodged in the lung? Yeah, any studies on that?
Yes, the first side they move is to the lung, and then here in this study they've shown that more cells with the labeled VMSC. They've shown that more cells have mobilized to the pancreas when compared to the other tissues. But when we did a preliminary work in our lab, we found that more cells have mobilized to the lung. And also to the pancreas, even to the pancreas, as that is the injured site, more VMSCs have moved to the pancreas, but also more cells we found in the lungs as well.
Okay, thank you, madam. Any other questions, please?
Rameshwari sir, any questions?
Yeah, no, sir. There is one question. Okay. Good afternoon to everyone. Thanks for the information of VC on stem cell. Regards. So this is not a question, it's just to thank ma'am for the wonderful presentation.
Okay.
Yeah.
Okay. If there are no other questions,
shall we conclude the session, sir? If no more questions.
I just want to ask one question.
Yeah.
Hello.
Yes, sir. Yes, sir. Go ahead.
Has she compared with pancreatic cancer and acute pancreatitis? Is there a difference in the?
Yes, sir.
Have you looked at any data on pancreatic cancer?
They have done on pancreatic cancer, but I haven't reported here. They have used bone marrow mesenchymal.
No, not that I'm asking. What is the difference between acute pancreatitis, this thing? Because people are talking of cancer stem cells in pancreas. So that in that light, would you like to say something?
Yeah, see, when the Acinar cells, they get activated, when they get affected, the neighboring cells are the stellate cells, pancreatic stellate cells. So these cells are in the quiescent stage. But once these Acinar cells have been affected, then these stellate cells have been activated. And this cells which leads to fibrosis and also pancreatic cancer. So these stellate cells, they may get transformed into a cancer stem cell. Okay. Did I answer your question, sir? Or?
No. I just wanted to know. I mean, I have been just reading about pancreatic cancer. So since you are talking acute pancreatitis,
yeah, acute pancreatitis,
both are stress conditions. Both are stress conditions. So what gets activated is the question, because the cell doesn't know whether it is acute pancreatitis or cancer. Because cancer also you have acute pain.
Yes, we do have, but then in acute pancreatitis, we work with both acute and chronic pancreatitis. So even not only chronic pancreatitis can activate the stellate cells, but then acute pancreatitis can also activate the stellate cells, and it can lead to, because initially acute pancreatitis, I may think that it will be made for a few hours or few days, and it can be treated. But only chronic pancreatitis can lead to cancer. But we have shown in our lab that even acute pancreatitis can activate the stellate cells. Even at the initial stage also, it can activate the stellate cells and it can lead to pancreatic cancer.
Okay. There has been, lot of discussion on Deepa Bharatiya's paper discussion.
Yes, sir.
I didn't want to comment at that time, but I just want to say that what she has probably picked up is what we used to call those days a transit amplifying cells, because every organ has to maintain homeostasis and, things happening. So there'll be always transit amplifying cells. And what she calls as very small embryonic stem cells are probably just transit amplifying cells, which are present in all the cells for house function maintenance. So I think earlier we were very clear, that's why they were called progenitor cells. Yes. And so nobody, this is something well known before, but somehow with this modern research, old thoughts have been totally forgotten by people, what is a stem cell, what is a progenitor cell. So I have a strange feeling that Deepa Bhartiya is harping on something which we used to call earlier as transit amplifying cells. And they have all those properties what she was describing. So I just thought, I want people, because even the speaker before you, Shaji, also mentioned that. It is true that she has picked up something which exists in all. So you will say it is present in all the organ, but transit amplifying cells are always present because that's meant for house maintenance. So I think she has interpreted the result, because transit amplifying cells also will give you all the cells. So you will think it is a stem cell, and very small embryo. It is not that. It's just a, because when stem cell divides, one remains a stem cell and the other is what proliferating. And what she has picked up is the early stages of proliferation. That's my gut feeling. That's why people are not accepting probably her thought. I just thought, Dr. Suresh was asking this question again. So I thought today, let me clarify this point, that is my gut feeling. Thank you so much. I enjoyed thoroughly. Yeah.
Thank you, Dr.
Even when we use the Nestin marker, pancreatic marker also, there was no expression of this Nestin mesenchymal stem cell markers. So that also confirmed that there was no stem cells in the pancreas, but still it's controversial.
Exactly.
As she said,
There's both the school of thought.
Might be the transient. Yes, yeah, might be the transient amplifying cells could also be. Can also get differentiated. Yeah, could also be involved in the tissue.
That is the job, is to differentiate. So you might think you have picked up the thing. Yeah.
Yeah. Thank you, Dr. Krishnamurthy Kannan. Dr. Mohan Srinivasan, you want to close?
Yes, sir. Yes, sir. If no more questions, shall we conclude, sir?
Yes, please.
Yeah. Thank you, ma'am, for your wonderful presentation. Your presentation given a clear insight on molecular mechanism involved in the acute pancreatitis, the immunomodulatory effects of mesenchymal stem cells, how the mesenchymal stem cells are used to treat the acute pancreatitis, and moreover, the mesenchymal stem cell transplantation can pave the way for the treatment of acute pancreatitis in the near future with extensive research. Thank you. Thank you, ma'am, once again.
Thank you.
Sir, over to you, sir.
Yeah, thank you, Dr. Munisarvi. And at this time point, on behalf of the organizers, I'd like to profusely thank the chairperson, Dr. Mohan Srinivasan. A lot of academic work going on simultaneously. He's taken time out to be with us. Also, our moderator, Dr. Ramesh Pati, who's also involved in multiple academic and research activities. And he has been kind enough to spend some time and take care of the Q&A. Thank you, Dr. Mohan Srinivasan. Thank you, Dr. Ramesh Pati.
Thank you. Thank you, sir.
Thank you, sir.
All right. Now, the time is a little after 4. I hope all the organizing secretaries are available here. Dr. Debashish Mishra is here. And Dr. Kamil Selvi is here. Dr. Manjubala. Manjubala is also here. Okay. With the permission of the organizing secretary, I think I'll start making the concluding remarks, following which the organizing secretaries will say a few words. And finally, we'll request for feedback from a few students, a few research scholars, and a few faculty members. So that is the here. And so the dean is actually busy with an important academic activity, so he's not able to be with us here, but he's conveyed his best wishes. So first of all, we would like to acknowledge the wonderful support of our Honorable Chancellor, and who has provided a great deal of support to our effort. He has been the guiding light and the motivating factor behind all our activities. The Dean SVST has always been encouraging us, and he has been a pillar of support, and he has provided us with a lot of inputs so that we could refine our thought process and make this event a memorable one and a useful one for all the registrants and all the participants. So in terms of the conceptualization, we had a lot of brainstorming sessions with faculty members within VIT. Also, tremendous support from our industrial partner, Advancers, Mr. Vipul Jain, who was part of the inaugural, and also Dr. Sachin Kadam, the Chief Executive Officer. He was kind enough to share information about resource persons from within the country as well as from outside. Also support from the Center for Stem Cell Research. We had Dr. Biju George, Dr. Sanjay Kumar, and Dr. Shaji. Dr. Shaji especially took time out from busy schedule in identifying resource persons. So that helped immensely. Also, a very special thanks to our chief guest, Dr. Professor Krishnamurthy Kannan, who was not only part of our inaugural, but he also gave a second talk, and he was instrumental in compiling a quiz which was circulated among the registrants. We have all the answers. We just need time to compile it and find out how many answered each question correctly. Also, he was instrumental in identifying a resource person from INSTEM, Dr. Bhavana Muralidharan. So we are indebted to Professor Krishnamurthy Kannan, and he's going to come back to VIT and help us out in a number of academic activities. So conceptualization, we had to get the brochure ready. A tremendous support, specifically by Dr. Reena Rajkumari in SVST, and she was instrumental in liaisoning between us and the student outreach department. So they were involved in the promotional aspects. Advancers was also involved in parallel with the promotional part. Our thanks to the support from the Center for Technical Support, specifically Mr. Gopi, who has been helping us out with the Zoom recording and the YouTube live part. So he has been basically training us, and we learned to differentiate between what a host is, what a co-host is, and so on and so forth. We're still learning, but we are better off now than we were perhaps a week ago. My sincere appreciation to the organizing secretaries. They are going to say a few words. Dr. Manju Bala, Dr. Tamil Selvi, Dr. Debashish Mishra, and also Dr. Jabez Osborne, who helped us immensely by being the master of ceremonies during the inaugural. So it is nice that both Mr. Vipul Jain and Professor Krishnamurthy Kannan were able to be part of the inaugural, and Mr. Vipul, despite his busy schedule, was able to be part of the inaugural function. With respect to the registrants, I'm hoping that you would have acquired knowledge about stem cells. For those who already had some knowledge of stem cells, this would have provided you all an opportunity to update yourself. Okay, there were some controversial topics discussed. I hope you are able to sift through the literature, go back and start thinking about what was discussed and form your own opinions. And I hope whatever textual information that was taught to you by your teachers, you can now update it with more cutting edge information from peer reviewed papers. Not that your teachers would not have taught you that, but perhaps you would have gotten a better insight after attending the lectures the last 2 days. Also for students, I hope this is a stepping stone, a starting point for networking. In the USA, they would call it putting a name to a face. But because this is an online session, I hope you are able to take a look at the faces of the resource persons. But what that means is you know who the resource persons are, what topics they are working on, and this gives you an opportunity to write to them directly to know more about their work. And perhaps they may be impressed by your eagerness, enthusiasm, hard work, and they may take you in their laboratory. I'm sure all these resource persons were role models, okay? And so I'm sure you would be inspired by their lectures. They were academicians, academic researchers, industry specialists, entrepreneurs, and clinicians. So some of you have done basic work, can now start thinking about the translational aspects, the clinician's point of view and the product development point of view. Okay, in terms of the faculty members and scientists, I hope this provides an opportunity for collaborations, lab-based work, translational research, or testing your product, or thinking about product development. I'm sure the resource persons who came from other countries would also be willing to support. In fact, one has actually written to me and saying that you can share my email ID. I'll be more than happy to talk to the faculty members in VIT. Before I hand over the session to the organizing secretaries, I once again acknowledge the excellent support rendered by each and every chairperson and each and every moderator. I know the last 2 days, the faculty members are really harried. There are a lot of inspections going on, paperwork, and despite that, they took time out to spend some time with us and perform their roles as chairpersons and moderators, and they did a wonderful job. Hats off to each and every one of you. Now, the way we are going through this is, first we start with Dr. Debashish Mishra, and then Dr. Tamil Selvi, and then Dr. Manjubala, and then we go with the feedback. So over to Dr. Debashish Mishra.
Yeah, thank you, Dr. Suresh, for giving me this opportunity. Would like to thank you for having me in the organizing group. Although you have done majority of the things of aligning the speaker, communicating with the participants, so you really had done the biggest chunk of work, and you have left us to move the tables, and hope we have moved that too properly. And really the overall kind of talks which were there for the 2 days, I hope they have inspired all the students to pursue their career in stem cells. In this pandemic, it is really very awful to go to a cell culture lab where no students are there. And but I am sure that things are going to be better. People like Dr. Anand Srivastava and many of visionaries like him, they are trying to find a solution for COVID. I was really surprised whether stem cells can have a solution for COVID, but that was our first speaker, and he talked very explicitly about it. I should thank all of my co-organizers for their support, and we all worked really very coordinated way. I should thank our dean and the support staff of our school and CTS, of course, to make this happen very flawlessly. And I hope this kind of sessions should, this kind of conference should go on. Maybe next year we can have probably in person. We can call many of the guests in person. Especially I like Dr. Krishnamurthy Kannan. I would love to have him here and interact with him for and we could have coffee and all in food court. So thank you very much, sir. Thank you. Thanks for the opportunity. I really thank all the students. Every doubt will not be cleared in one session, but it's just this whole conference is just made an arrangement just to keep you ignited on the burning topics, whatever we are having. Thank you very much.
Thank you, Dr. Debashish. Yes, I did forget about Dr. Anand Srivastava in the context of the ongoing pandemic. Thank you for reminding us about that and about the possibility of palliative care with MSCs taking care of the cytokine storm and the fact that the emergency use has been authorized with FDA, compassionate use. That's not been done as on date in India, I think. Fantastic. And Dr. Debashish and his students are working on the certificates and they have been involved in designing the certificate. Our thanks to Dr. Debashish and his bunch of students for that. Now over to Dr. Tamilselvi.
Yeah, thank you, Professor, for giving me an opportunity to be an organizer and also been motivating me to present in this conference. And yeah, it has been very well coordinated. And yeah, like it was like a motivation, like working with Professor Suresh. Like right from the first day, he has been clearly explaining the events that is going to happen, and he's been clearly updating everything. So it was nice working with him and also with the other two coordinators, Dr. Debashish and also Dr. Manjubala. And this conference is hope all the participants and including our VIT faculties and me, we enjoyed, and we found the sessions were very informative and also valuable too. And we got the recent updates about this stem cell research. And I think almost all the speakers, I think they shared a large amount of data, which was been very helpful, and it would also been very beneficial to the people who have been working with these stem cells. So once again, I thank Professor Suresh for giving me an opportunity to participate in this conference. Thank you, Professor.
Thank you, Dr. Tamilselvi. You have done a wonderful job as being part of the organizing team. Now I call upon Dr. Manjubala.
Thank you, sir. Thank you, Dr. Suresh, for involving me in this conference. I also thank Dean SBST, Dr. Prakasam, for making me a part of this conference on stem cells. In fact, I really want to project that even there is a lot of debate going on with the stem cell research. It has gone into a therapy level, which has been recognized by the common public, and it has gone into a clinical application directly. So this is what I want to convey to all the participants also. Science is full of debates. So you should also see the good side of science and realize the potential applications, okay? So this is what we have learned also from this conference. A lot of speakers, eminent speakers, and I also thank Dr. Suresh, who has collected a very good group of scientists working in stem cells and enlightening all the participants with the different applications, different parts of the stem cells. So not only this, it has been very encouraging for the new beginners, the students, the research scholars, so that they can also move forward, not just thinking that there are drawbacks in the situation.
drawbacks will always be there, but take an encouraging step forward. You would have listened to all these talks by different speakers here, and I hope everything goes well with this stem cell research. Thank you to Dr. Tamilchelvi and Dr. Debashis as well, who has been co-organizing this event. And I'm hopeful that we definitely come forward together once again, making such events maybe more into a virtual mode, because we can get all the scientists from different part of the world. And this makes more eligible to the students and the other participants to come in one single platform without making a lot of travel for them. So thank you, sir. Thank you for this wonderful virtual event. And I hope all the participants also enjoyed it very much and learned it from this. Thank you.
Thank you, Dr. Manjubala, for wonderful support rendered to the entire team. And I think almost all the organizing secretaries are quite savvy with Zoom. I just tried to pick up the rudiments with their support and Gopi's support. But I think next time around, I'll be a little bit more comfortable handling the Zoom feature, Zoom platform rather. Now, what I will do is I'll start calling the research scholars first. And the first research scholar is Mr. Surya.
Yes, sir. Yeah.
Do you want to say? By the way, Mr. Surya is a research scholar under my guidance, under the external part-time program. He is a lab head in a company based in Gurgaon, Cellugen Biotech, and so he works on different aspects of stem cells and translation aspect. So now he's focusing on getting his papers through so that he meets the requirement for the award degree. Go ahead, Mr. Surya.
Yes, sir. Good afternoon, sir. Good afternoon, everybody. It was very wonderful listening to all stalwarts in the field. And we have touched upon all the streams of stem cells, starting from cord blood hematopoietic stem cells and mesenchymal stomal cells and iPSCs, along with their corneal stem cells as well. And with the kind of work that all these research scholars have done and they have been doing, like, it was very wonderful to listen to all of them. And it has only motivated me as a research scholar to get more involved in the research and focus with zeal and integrity. And also it was very wonderful to make sure that whatever we have been doing on a translation level, like haploidentical transplants, TCR alpha beta depletion programs, as well as CD34 positive selection, negative selection, in terms of mesenchymal stomal cells, like we have done a lot of translational work related to even to GVHD. So listening to all the people in the field, again, I have seen them and have interacted with them in few conferences, but again, bringing them on board through VIT and listening to them again in this pandemic, it was very wonderful. And it was so gluing that I was continuously watching it for last 2 days. And thanks to my guide, Dr. P.K. Suresh. And it was wonderful opportunity to listen to everybody. Thank you, sir.
Thank you, Mr. Surya. The next person is Mr. Adish Majumdar, who is Dr. Manjubala's research scholar.
Good afternoon, sir. Good afternoon, everyone. Thank you for giving me the opportunity to give my feedback today, because it is really amazing being a PhD fresher to be exposed to so many new viewpoints and insights about stem cells. It has been really great experience altogether all these 2 days, and hopefully I would be able to use the knowledge I acquired going forward while pursuing my PhD when I get to VIT, hopefully soon. I personally think that every speaker contributed something new and fascinating and updated me about the stem cell scenario. But personally, I am very amazed and inspired by Dr. Deepa Bharti's lecture on VSELs and Dr. Krishnamurthy Kannan's lecture and his recent clarification about VSEL. It was very interesting to hear the two school of thoughts, and all in all, it has been a really good experience. I really needed to understand the subject better. So thank you for organizing it, and wishing each and all Merry Christmas and a very Happy New Year.
Thank you, Mr. Adish. Now we'll get feedback from a couple of faculty members. This part is actually not pre-planned, but Dr. Balaji Balakrishnan, are you there? Dr. Balaji Balakrishnan? Okay, he's perhaps not there. Dr. George Priyadas, Professor, would you like to comment? Okay. Dr. Nilanjana Das? Yep, Nilanjana Das. Okay. Fine. Okay. Dr. Sudha Ramaya?
Yes, sir.
Yeah. Madam, would you like to say a few words?
Yes, good evening, sir. Thank you for giving me an opportunity. Really, it was a very fantastic conference. I enjoyed a lot. All the sessions were very informative. And in future, I hope you will arrange for the different topics in the conference. I hope I will surely help you, and I will listen to the speakers. Surely it was very informative, sir. Thank you very much for giving us an opportunity in dealing with the stem cell research. Thank you once again.
Thank you, madam. Dr. Sabina, would you like to say anything? Dr. Sabina? Okay. Dr. Sabina? All right. If not, madam, we pick a couple of students. Anyone who wants to say a few words? The registrant? We take a couple.
Sir, you may consider stop the recording.
Recording can be stopped?
Yeah, I think the event is over. So.
All right. All right. Okay. Thank you. We conclude the 2-day virtual international conference on stem cells, update on stem cells, academic and industrial perspectives, future challenges. Thank you for all the support and hope to see you again in the near future. Thank you. Bye-bye. So there is a student by the name of
You should announce about the certificate. They will receive the certificate maybe within a couple of days, today or maybe within 2 days. They will receive.
No, we'll do it by early next week, Professor.
Okay, early next week. So
yeah,
students should not hurry. Right, they should understand. Yes.
Thank you, Dr. Devashish, for reminding me about this. Certificates will be given to registrants who have attended at least 5 sessions, including the inaugural. Also, the feedback form has to be submitted. The feedback forms have been sent to you via Gmail. Okay, the regular Gmail feedback link has been sent. Please fill it out. Now, there is one person with the name of Mahsa Yusuf Zadeh. Would you like to comment? You have anything to say about the conference? Okay.
Hello, everyone.
Yes. Which country? Which country are you from?
I take part from Ankara, Turkey.
Okay.
Yeah. I'm an Iranian originally, but I'm a PhD student and study stem cell and regenerative medicine in Ankara University Stem Cell Institute. Actually, I work on hematopoietic stem cells and natural killer cells. And it was a great opportunity for me to take part to such a great conference. And thank you so much.
Thank you, Ms. Mahsa Yusufzadeh, for your valuable comments.
You're welcome.
We'll take one more and we stop. Khushi Srivastava.
Hello, everyone. Thank you so much for giving me this opportunity, sir. I would really want to say that this was my first international conference. And in this semester only, I took stem cell and I was in a very learner stage. But this conference has told me that I could do so much more. And this conference has also provided me an opportunity to be confident that whatever interests me, I can pursue. Although there are so many shortcomings in everything. But after getting to know so many scientists, I think like I can do much better in this field. Thank you so much, everyone.
All right, thank you, Ms. Khushi Srivastava. If there's nothing else, Dr. Debashish, Dr. Manjubala, Dr. Tamil Selvi, and all the other faculty members and other organizers assembled here, we conclude this session. Okay?
Yes, sir, we can conclude now.
All right.
Thank you very much.
I'm ending. I'm ending.
Yes.
Thank you, Professor.
Thank you. Thank you.